Welcome to the 2025 Neuroendocrine Cancer Foundation Annual Patient Conference. I'm Kavya Veligapudi, Executive Director of the Neuroendocrine Cancer Foundation.
I'm Lisa Yen, Director of Programs and Outreach.
And I'm Heather Davis, the Director of Community Engagement.
The theme for today's conference is what matters most to make your next best decision. Thanks to our speakers who are joining us today. Our annual conference would not be possible without the support of our presenting supporter, Novartis, Diamond sponsor, Crinetics, Gold sponsor, Lantheus, Silver sponsor, Exelixis, and Curium. The Neuroendocrine Cancer Foundation was founded in 2012 as LACNETS. This year, LACNETS rebranded as the Neuroendocrine Cancer Foundation. This rebranding signifies the strides we have made in reaching more patients and caregivers, and also in offering more educational and support resources. Our staff includes Lisa Yen and Heather Davis. Our board includes Donna Gavin, who is the sister of our founder, Giovanna Joyce Mbesi, and NET patient Mary Dunleavy. The Neuroendocrine Cancer Foundation is guided by our Medical Advisory Council, which includes some of our closest advisors who are committed to improving the lives of neuroendocrine cancer patients through patient care, scientific research, and education. We partner with the Carcinoid Cancer Foundation to provide its programs, including Luncheon with the Experts and the support line. Now I'll hand it over to Heather.
Before we get started, here are some tech tips for watching this live broadcast. You can pause, rewind, and fast forward during the broadcast. When you're ready to catch up, just click live to return to the live broadcast. Today's presentation is being recorded, and each presentation can be rewatched at your preferred playback speed on our website, ncf.net, and our YouTube channel a few days after this live broadcast. For audio, first make sure your sound speaker icon is unmuted. Adjust the volume control up or down to increase or lower the volume as needed. If you're watching from YouTube Live, there's a closed caption feature as well. For video, locate the square full screen icon in the bottom right corner of your screen display. You may enlarge the webinar video by clicking or unselecting that icon. Our YouTube channel features nearly 450 videos and podcasts. Click videos or playlists to find webinars on our previous annual conferences, various types of treatments, clinical trial snippets, and an array of patient and caregiver stories. Follow us on social media to stay up to date on our upcoming webinars and NET news. We are on Facebook, X, and Instagram with the handle @NCFCancer. And be sure to add us to your Safe Sender email list to receive our monthly newsletters, podcasts, and dates of our next online or in-person educational event. Be sure to take a look at the valuable information and resources on our supporters pages. Go to ncf.net/2025 conference. Visit all 5 companies' pages and receive a $5 Starbucks e-gift card. The first 200 participants to complete the Confirm Your Visit section of all 5 booths will receive a Starbucks e-gift card via email. And please note, we are not storing, sharing, or selling any of your personal information. And now I'll hand it back over to Lisa.
To submit your general questions, go to the 2025 conference page on our website, ncf.net/2025 conference. I'd like to remind our audience that our webinars are created for educational purposes only and do not substitute for medical advice. The views shared in this conference are the experts' personal opinions. Please contact your medical team with questions or concerns about your individual care or treatment. Today, you'll hear from an extraordinary panel, 19 physicians from across North America, including Canada and Mexico, along with 3 individuals living with neuroendocrine cancer. Together, We hope to share insights that supports what matters most to make your next best decision. We understand what it's like to stand at the crossroads of a treatment decision or to be bracing for the next one. Our hope is that you leave feeling more informed, empowered, and confident in your path forward. And while much of today's conversation will center around cancer, we want to emphasize this. You are not defined by your disease. You are a whole person, and we're here to support you in living fully and richly, even with neuroendocrine cancer. I'm now going to welcome our moderators for today's conference. I'm pleased to welcome our co-moderators for our 2025 Neuroendocrine Cancer Foundation Patient Conference. We're grateful to have NET expert Dr. Andrew Hendefar and NET patient Mary Dunleavy return for their 5th year as co-moderators of our annual conference. Dr. Hendefar is a medical oncologist who leads the neuroendocrine cancer program at Cedars-Sinai Medical Center in Los Angeles, and he also serves on our medical advisory board. Mary Dunleavy has been living and thriving with neuroendocrine cancer for more than 20 years, and she serves on our Neuroendocrine Cancer Foundation board. Thank you both for being here today and helping to frame today's presentations with your insights. The theme for today's conference is what matters most to make your next best decision. So let's first talk about expectations. Dr. Hendefar, some patients anticipate their doctors will tell them exactly what to do next, perhaps because of past experiences with doctors or because they expect that their NET expert is the expert. So we're wondering how you work with your patients to help them make their next best decision.
Thank you, Lisa. I think that's an excellent question. Usually, medical decision-making is a team's effort. So we talk about the state of the cancer itself and what are the options available to it. And then we talk to the patient generally about their treatment preferences. And certain things are more important to certain people than other things. Someone's number one goal might be, for example, not to take any medicine unless absolutely necessary, and someone else would never want surgery, for example. So we take these treatment preferences into account when discussing the next best step. So yeah, I like to think of it as a team effort.
Yeah, a team effort involving values, goals, and preferences. Thank you. Mary, for you, you've been living more than 20 years with this. In general, how do you go about making decisions in your NET journey?
Thank you, Lisa. Well, I would say my decision-making process has changed a lot, and it's evolved a lot over the years. Because I was diagnosed in my 30s when I had 2 small children, I was really quite overwhelmed with my initial diagnosis, and I relied heavily on my NET expert at the time, which was Dr. Wolin, to guide me and educate me along the way. Now, I became more progressively involved in self-advocating and self-educating over time. That's guided my decisions. And I still rely most heavily on Dr. Hendefar, who's my oncologist, who's wonderful and knowledgeable. And with his urging, I also kind of have taken a lot of ownership in decision-making for myself as well. So I would say it's definitely, like he said, a group job.
Yeah, again, a team effort. Dr. Hendefar, oftentimes when a patient comes to you, their most pressing question, understandably, is what treatment do you recommend? Could you explain a bit about the process of evaluating a patient and how or why this matters to be able to discuss treatment options?
Absolutely. So when a patient is evaluated for the first time, very important elements for the physician to consider, we call it the history of present illness or the symptoms and the history that goes behind that, what's been happening to the particular patient for the years prior to the diagnosis. That's one key element. Are there any side effects? Are there any issues? Are there GI symptoms? The next component that's super important are, medical records with detailed pathology reports and imaging. Imaging right now, even though in the modern era it's getting better, it's very hard to get digital images from one place to another. So that's key. Pathology reports are generally good enough, but a lot of times they need to be reviewed. The actual path specimens need to be reviewed. And then the other important pieces of information are any molecular tests done on the tumor or done on blood, and any laboratory tests that were done. So it is a lot of work to get an initial consultation about a neuroendocrine tumor or any cancer. It's kind of similar. But the more information you collect and gather and transmit to the provider, the better your experience will be and the better the information you will receive.
Yeah, thank you for explaining the process there. Mary, you talked about how it was a process for you. How did you learn to speak NET, and how has this changed your relationships with your medical team?
To be honest, I pretty much lived in denial with my disease for a number of years. Speaking NET was not a priority for me at all. And as time went on, I realized my cancer was not going anywhere and things kind of shifted for me. Giovanna Mbesi, who was the founder of LACNet's now NCF, was kind of the first to get me out of my shell with this. She helped me to realize that I wasn't alone in this. And I think I didn't quite realize how much I actually needed that in my life at the time. So once that connection was made, the NET community and the NCF team and so many others became a lifeline for me and really helped me learn to speak NET with my oncologist, Dr. Hendafar. And with all sincerity, I'm not sure I would do without this community. I feel like it's really helped my relationship with my oncologist and my surgeon and the other doctors I have had the pleasure of working with, just because it's a more collaborative experience. And we both get to weigh in on what I think my next best decisions are going to be.
Yeah, the team effort is being part of the community as well. Yeah. Well, thank you both. We're pleased to now introduce our first speakers of the conference who will give an overview of neuroendocrine cancer.
Whether NET is new to you or you are already have a great NET foundation, you will find this presentation focuses on what you need to understand about your disease. Dr. Bhavna Konda, medical oncologist at Ohio State University Comprehensive Cancer Center, the James, covers the topic, what is neuroendocrine cancer?
Our next speaker is Thor Halfdanarson. He's a medical oncologist who runs the neuroendocrine tumor program at Mayo Clinic in Rochester. He's going to be speaking about what matters about biomarkers and blood tests.
Dr. Nadine Malik, radiologist and nuclear medicine doctor, will be joining us to address what matters most about scans. She's already delivered 2 very helpful and complimentary presentations on this topic that you can find on our website, and I recommend reviewing those. This presentation specifically highlights the different types of imaging and how each of them helps to determine your next best decision.
Our next speaker is Vineeth Sukrithan. He's a medical oncologist from The Ohio State University Comprehensive Cancer Center, and he's going to be speaking about what matters about symptom management.
Good morning, everyone. Thank you so much for joining us today. My name is Dr. Bhavna Konda, and I am a neuroendocrine tumor expert and medical oncologist at the Ohio State University Comprehensive Cancer Center. I'd like to begin by expressing my gratitude to the Neuroendocrine Cancer Foundation for inviting me to speak with you. It's truly an honor to be part of this important conference. My topic today is an essential one. What is neuroendocrine cancer? Whether you are a newly diagnosed patient, supporting a loved one, or just looking to understand more, my goal today is to help make this complex condition a little less overwhelming. Here are my disclosures. A question that I get asked a lot, is this a cancer? And yes, neuroendocrine tumors are cancers. These are rare cancers that arise from abnormal growth and spread of neuroendocrine cells. Neuroendocrine cells are present in all of us in several parts of our body. These cells produce hormones in response to signals from the nervous system, hence the name neuroendocrine. When these cells start to grow and spread abnormally, they form a neuroendocrine cancer. Now, there are some rare exceptions. For example, pheochromocytomas, which are tumors that arise from neuroendocrine cells in the adrenal gland, and paragangliomas, which are closely related to pheochromocytomas but arise outside the adrenal gland, can be benign or cancerous. Leaving out these rare exceptions, neuroendocrine tumors are, for all practical purposes, cancers. It's important to understand that all neuroendocrine cancers are not the same. These are a spectrum of cancers, as you can see here, ranging from slow growing on the left to rapidly growing aggressive cancers on the right. Let's take a few minutes to go over some of the terms you might hear when learning about this disease. Knowing these terms can make it easier to understand what the disease is and how it behaves. First is origin. That is, what part of the body did the tumor first begin? For example, if the cancer started in the lungs, it's called a lung neuroendocrine cancer. If it started in the stomach, it's called a gastric neuroendocrine cancer, and so on, as you can see here. Second is stage. Has the tumor spread out of where it started from? And if so, how far has it spread? If the tumor is present only in the place where it began, we call it localized, as shown here in this picture. You see that the tumor is localized to the pancreas here. If it has spread to nearby tissues or lymph nodes in blue here, we call it locally advanced. If it has spread out of where it started from to distant parts of the body, we call it distant metastatic or stage 4 disease. At the bottom, you see that the pancreatic neuroendocrine tumor has spread not only to lymph nodes, but also to a distant location, like the liver. You see all these tumors in the liver. So this is considered stage 4 disease. Next is tumor differentiation. This is described in pathology reports as well differentiated or poorly differentiated. What does this mean? When pathologists examine a tumor under the microscope, they look at how closely the tumor resembles normal cells. This is called tumor differentiation. Normal cells are depicted in the top panel here. Well-differentiated neuroendocrine tumors, or NETs, on the left look more like normal cells. These cells tend to grow and spread more slowly. Poorly differentiated neuroendocrine carcinomas, or NECs, on the right here look very different from normal cells. These are aggressive and grow rapidly. Understanding the stage and differentiation of a tumor helps guide several aspects of your cancer care. It helps clarify goals of treatment. Is our goal to cure the cancer, to control it, or to relieve symptoms? For example, an early stage well differentiated neuroendocrine tumor might be curable with surgery alone. A more advanced or aggressive tumor might need a combination of treatments. It helps your doctor tailor treatment specifically for you, as there is no one size fits all approach to treatment here. It helps determine prognosis. Prognosis means the likely course of your disease, that is, how it might behave over time. Well differentiated early stage tumors have a better prognosis than poorly differentiated or advanced stage cancers. It helps plan follow-up intervals. That is, how often do we need to check in with scans or blood work? A slow-growing, well-differentiated neuroendocrine tumor that has been surgically removed may need monitoring only every 6 months. A faster-growing tumor would need more frequent follow-up. Let's talk about Ki67. Ki67, or proliferation index of the tumor, is a marker we use to understand how fast a tumor is growing. It's a protein found only in cells that are actively dividing. When the pathologist calculates the Ki67, he's looking at what percentage of cells in a tumor are actively dividing. For example, a Ki67 of 3% means that 3 out of 100 cells are actively dividing. If Ki67 is 20%, that means 20 out of 100 cells are actively dividing. Why does this matter? The higher the Ki67 percentage, the more aggressive the tumor. We use Ki67 to help assign a grade to neuroendocrine tumors that originate in the GI tract or pancreas. Grade 1 neuroendocrine tumors have a Ki67 less than 3% and tend to be slow growing. Grade 2 neuroendocrine tumors have a Ki67 in the range of 3 to 20%. These are intermediate in aggressiveness. And the high grade or grade 3 neuroendocrine tumors have a Ki67 over 20% to 100%, and these are more aggressive. Another important marker to understand how aggressive a tumor may be is the mitotic rate. This is measured by the pathologist, who looks at the tumor under a microscope and counts how many cells are in the process of dividing. Why is this important? The higher the mitotic rate, the more aggressive the tumor. Like Ki67, we use mitotic rate to assign grade to a neuroendocrine tumor. Again, grade 1 have a mitotic rate less than 2 per 2 millimeter square. Grade 2 have a mitotic rate intermediate, 2 to 20. Grade 3 have a mitotic rate over 20 per 2 millimeter square. Mitotic count helps us understand how fast the tumor is likely to grow and how we might need to treat it. Another important term to be familiar with is tumor heterogeneity. Tumor heterogeneity means that not all neuroendocrine tumors are the same. Two people with the same type of neuroendocrine tumor may have different tumor grades. Even within one person, the primary tumor and a metastatic tumor can have different grades. In this picture here, this patient's primary tumor is in the pancreas and is grade 1, and the lymph nodes it has spread to are grade 2. Sometimes, even within a single tumor, there can be two different grades. As you can see here in this picture on the left, a portion of this patient's tumor that has spread to the liver is grade 1, and the other portion of the same tumor is grade 2. So while markers like Ki67 and mitotic count give us valuable information, they're ultimately just tools to help guide us. Since it's not practical to biopsy every single tumor in the body, it's crucial to look at how the tumor is behaving over time, especially on imaging, to understand how quickly it's growing and how best to treat it. Putting it all together, here is how neuroendocrine cancers that start in the GI tract or the pancreas are classified. Based on tumor differentiation, we have well differentiated NETs and poorly differentiated NECs or neuroendocrine carcinomas. We talked about grading in the previous slides and how we use Ki67 and mitosis to assign grade. The higher the grade, the more aggressive the tumor. Well-differentiated neuroendocrine tumors are variably aggressive, but many of them are relatively slow growing with a natural history that can evolve over many years. In contrast, poorly differentiated neuroendocrine cancers are uniformly highly aggressive and grow rapidly. This is a classification for lung and thymic neuroendocrine cancers. Again, we have well-differentiated NETs and poorly differentiated NECs. The subcategories are a little different here. Well-differentiated neuroendocrine tumors are divided into two main types, typical carcinoid and atypical carcinoid, and this is based on the number of mitosis and whether there is necrosis under the microscope. Necrosis is basically death of cells within a tumor, which is a sign of the tumor growing quickly. Typical carcinoid tumors have no necrosis and have very few mitosis. These are usually slow-growing tumors. Atypical carcinoid tumors, on the other hand, have necrosis or a high number of mitosis, making them faster growing. Now, when you look at poorly differentiated neuroendocrine cancers on the far right, these have a lot of necrosis and a very high number of mitosis, making them highly aggressive cancers. Many patients with neuroendocrine tumors have no symptoms, and the tumors are discovered incidentally during imaging or procedures for unrelated issues. This is especially common in early stage or low grade tumors. There are others who may have symptoms. Symptoms could be due to hormone production by the tumor, which is called carcinoid syndrome, which can manifest with diarrhea, flushing, racing of the heart, which are called palpitations, wheezing, or lightheadedness. Symptoms can also be due to the tumor itself, causing abdominal pain, bloating, weight loss, decreased appetite, fatigue, and so on. What can you expect? At your first clinic appointment with a neuroendocrine tumor expert, your doctor will go over the results of your blood work and scans with you and explain what they mean. You will also learn more about the origin, differentiation, grade, and stage of your tumor. Your doctor will discuss the goals of treatment, whether that's curing the cancer, keeping it under control, or helping you feel better. You will gain a thorough understanding of what lies ahead in your treatment journey. Depending on your specific needs, your doctor may refer you to other specialists, such as a surgical oncologist, a gastroenterologist, or a GI doctor, or an interventional radiologist. These experts would become an integral part of your care team and will work closely together to come up with the best treatment plan for you. Your case is also reviewed in a multidisciplinary neuroendocrine tumor board. The board comprises of several experts, including medical oncologists, surgical oncologists, radiologists, radiation oncologists, pathologists, and many more. They review your case and provide recommendations on the best course of action. These discussions may happen multiple times during your treatment journey. If you have disease that is localized or locally advanced and resectable, typically resection is pursued as it's curative. If the tumor is not resectable, or you have stage 4, particularly low-grade neuroendocrine tumor, no symptoms, and a small amount of disease, your medical oncologist will often recommend watchful waiting to assess the pace of growth of your cancer. It's important to remember that unlike other cancers, many patients with stage 4 neuroendocrine tumors live for several years. While several treatment options exist today, they're not unlimited and not without potential side effects. So we have to use our treatments wisely. You and your team of doctors will make treatment decisions together. Always ask about clinical trials and what clinical trials might be options for you. Poorly differentiated neuroendocrine cancer, on the other hand, is a very aggressive cancer, and treatment usually begins as soon as possible. Your doctor will also talk about sending your tumor for next generation sequencing, where your previously biopsied tumor specimen will be sent off for analyses to look for abnormalities to help guide treatment. Treatment options remain quite limited in these patients, and we continue to work on developing clinical trials for this aggressive disease. As we wrap up, I want to leave you with a few takeaways. First, neuroendocrine tumors are cancers. These tumors are heterogeneous. That is, not all neuroendocrine tumors are the same. They vary a lot in their behavior from one person to another and even within the same person. Tumor stage tells us whether the tumor is still in one place or has spread out of where it started from. Tumor grade and differentiation are prognostic. That is, they help predict how your tumor will behave over time, how fast it may grow, and how likely it is to spread. Well differentiated low-grade neuroendocrine tumors tend to be slow growing. Poorly differentiated neuroendocrine cancers and high-grade neuroendocrine tumors, on the other hand, are very aggressive and grow rapidly. Treatment of these rare cancers requires a multidisciplinary team of neuroendocrine tumor experts. Finally, knowledge is power, especially when facing a diagnosis like neuroendocrine cancer. By educating yourself about your cancer, you become an active partner in your care. You are not alone, and we are here to support you every step of the way. Thank you for your attention.
Hello, my name is Thor Halfdannerson. I'm a medical oncologist and the professor of oncology at Mayo Clinic at Rochester in Minnesota. I specialize in neuroendocrine tumors, and I'm pleased to be here to talk about the biomarkers. So let's dive into it. So what is a biomarker? So we'll go through a few couple of definitions. So a biomarker is a short for a biological marker, which is a measurable indicator of a biological condition or a process in your body. So they can be molecules, they can be genes or proteins and physical characteristics, and they give us information on a bunch of different things, including normal biological processes. So this would be like hormone levels, disease states, such as tumor markers for active cancers, and oftentimes these are blood markers. And then sometimes they can actually give us ideas about the responses to treatment. Let's say if a marker is getting better after a treatment was started, that might suggest that the treatment is working. And some of the newer markers might actually help us select the most effective treatment. So there are several different uses, and this is just one of those images that I wanted to show you. So we can measure a lot of stuff in the blood. We can measure hormones and DNA and RNA and even circulating tumor cells, but most of this we're not really using much for NETs. So we can use this for early diagnosis. We can use this to monitor treatment responses. We can use it possibly to detect the relapses early. And now, more recently, we might have ways of predicting responses to therapy, let's say with genetically directed therapy or targeted therapy. And we're starting to work on getting information on how to predict the risks of treatment. But that is really not in much use yet. So is there an ideal biomarker? Yeah, there's always an ideal biomarker. Do we have an ideal biomarker? No, we don't. So the biomarkers should reflect the behavior and the activity of the NET. So it should be abnormal when there is tumor. So that is called sensitivity. So the ability to correctly identify individuals who actually have a neuroendocrine tumor. And it should not be abnormal when there is no tumor. So that's called specificity. So the ability to identify individuals who don't have a neuroendocrine tumor. So it should be easy to do, and it should be widely available, and ideally should have a fast turnaround time. It should be affordable and ideally covered by insurance plans. And most importantly, this should add value to patients' care. So it should improve outcomes for patients. It should help us guide treatment choices or avoid treatment where it's appropriate. And it should not be a source of harm, such as financial toxicity because of high costs, anxiety, or loss of quality of life. So do we have biomarkers that reduce the need for imaging? So we could think of such biomarkers where we would use them instead of imaging after surgery to monitor for tumor recurrence. So right now we're looking at the tumor grade and stage to predict the recurrences, anatomically location of the primary neuroendocrine tumor, patient's age, comorbidities, and some people wish to be followed very carefully, others maybe not so much. So if we had an ideal tumor marker for this, it should be so reliable that we could skip the scans and just use a marker. We don't have a marker like that yet. And that's reflected by some of the guidelines from the major guideline bodies like NCCN and ESMO and NANET and COMNET. They don't use or don't recommend the use of tumor markers following surgery for surveillance. So we still are dependent on imaging. So I just wanted to bring this one up there. So this was in the New England Journal of Medicine. So it doesn't deal with neuroendocrine tumors alone, but it talks about routine surveillance for patients with cancer metastases. So patients with advanced cancer and or patients with localized cancer where we follow them over time to look for metastases. And really what they point out there that we don't have good information yet. That early detection using those fancy molecular markers helps patients live longer or better. So this still remains to be researched or studied better. And the authors of this paper just wanted to point it out that we are not quite there yet with markers and with all of the questions that we need to answer when it comes to surveillance after surgery. Good piece. Let's talk about some of the commonly used NET biomarkers, and I split them up in non-specific markers and specific markers. It's not the perfect way of thinking about it. So a non-specific marker would be something like chromogranin A. So that's probably the most commonly used one. And they just don't have the sensitivity and specificity that we need for monitoring after surgery. So they can be falsely elevated. And in some patients who have a tumor recurrence, they can be normal. So these markers are not recommended following surgery. So what about non-specific markers in patients with advanced or metastatic NETs? So to date, we don't have a marker that is perfectly reflecting the disease activity in patients with advanced NETs. And we don't have a marker that has been shown to improve outcomes. So we have really promising markers, and I'll show you some of them in a little bit, but we can't really rely on them only. So we still are very dependent on imaging. We know that patients with more advanced disease, they tend to have higher marker values, but where they do have more tumor. So that's certainly something that one would expect, the more tumor, higher markers. There was one study that looked at the chromogranin, which is a marker with a lot of challenges to interpret. But at least in this study, they found that if you have advanced neuroendocrine tumor and you have chromogranin measured over time, if the chromogranin is not going up, it probably means that the tumor is not growing. But the bottom line here is that the utility of non-specific markers in patients with advanced NETs is limited. It's going to get better over time as we get better studies. What about 5-HT and serotonin? So we know that up to 50% of patients with metastatic small bowel NETs have carcinoid syndrome, so flushing and diarrhea. But we also know that flushing and diarrhea, especially diarrhea, can be from other causes. So we have to be able to tell the difference. Is this carcinoid syndrome diarrhea or is it not? And that's where we use markers that measure serotonin production by the tumor, whether that's the serotonin itself or 5-HT. So serotonin is a little challenging to do, so we prefer to do the 5-HIAA, which is what's called a metabolite or a breakdown product of serotonin. Easy to measure in blood and urine. We actually like measuring it in blood. It's much easier, has to be done fasting in the morning, and we prefer that over serotonin as a better marker. So elevated serotonin or 5-HT in patients with NETs and with diarrhea and flushing is really strongly supportive of carcinoid syndrome. But here is the thing that we need to remember is that you can have substantially elevated serotonin and serotonin production and 5-HT, but no symptoms, and you might be at risk of developing some of the complications of serotonin production. So what would those complications be? One of them would be carcinoid heart disease, and then just what we call subclinical carcinoid syndrome. So you might have carcinoid syndrome without sort of the typical severe diarrhea. And then knowing the serotonin levels or the 5-HT helps us determine if your diarrhea is from carcinoid syndrome or not. So let's say if you have a metastatic neuroendocrine tumor and you have diarrhea and the 5-HT is completely normal, then it's probably not syndrome diarrhea. But you have to think of these other diarrheas, the bile acid diarrhea, and we have better tests like 7-ACE4 and the bile acids in stool to look for that, and exocrine insufficiency. So this is what we see with octreotide and lanreotide, sort of impairment of the ability to digest fat and other nutrients. So serotonin is the critical component causing the carcinoid heart disease. So we need to know that as well. And patients with normal serotonin or normal 5-HT should not have carcinoid heart disease. And if you have metastatic neuroendocrine tumor and elevated serotonin production or 5-HIA, and even in the absence of diarrhea and flushing, you can still get carcinoid heart disease. We've seen that over and over again. Substantial serotonin production, no diarrhea, and if we hadn't looked for the serotonin or the 5-HIA, we would not have discovered that. So what about other functional neuroendocrine tumors? So a functional neuroendocrine tumor that can produce symptoms, and the symptoms do result in a syndrome, so a functional syndrome. So we can monitor such functional markers over time, and I'm just going to give you a few examples of those. Those are mostly pancreatic NETs, although lung neuroendocrine tumors can do this too. So this would be like insulinoma, where the tumors are producing excessive amounts of insulin, causing low blood sugars, gastronoma, causing Zollinger-Ellison syndrome, which is severe gastroesophageal reflux, stomach ulcers, and diarrhea. And then the really uncommon neuroendocrine tumors like VIPomas, the production of a hormone called VIP, or vasoactive intestinal peptide, which can cause severe diarrhea. And then even less common would be the glucagonoma, that causes the glucagonoma syndrome, which is diarrhea, diabetes, weight loss, and some patients get this really characteristic skin rash. And then we have those other like really rare functional tumors, or OMAs as I call them, the PTH or P-oma, somatsetinomas, even serotonin, which we did not think was produced by pancreatic neuroendocrine tumors, can actually be produced by them. So what about the novel NET biomarkers? Everyone wants to know about those. So let's talk about the NET test. So NET test is an interesting test. So it's a blood test that evaluates 51 NET or neuroendocrine tumor-related genes. And the results are reported as a NET test score, which indicates the likelihood of NET being or neuroendocrine tumor being present, and the progression score, which suggests that if you have a NET, how likely is it to progress or grow in the future? And it's been compared to chromogranin multiple times, and typically beats chromogranin in terms of how sensitive it is. But that's admittedly a low bar. So chromogranin not being the greatest test, it's kind of easy to beat that. So the problem is that the added value of the NET test is unclear. So number one, it has not been shown to result in cost savings or to improve outcomes. That is, if I use a NET test, I'm not sure if my patients will do better over time. And then a lot of patients will have detectable or positive NET test or a fluctuating NET test, but no detectable NET. It's possible that they may have an NET, a small NET that over time will show up, but there's no evidence to suggest that detecting that early with a blood test when nothing is visible on scans improves outcomes. So it's promising. It outperforms some of the other markers. The added value in the clinic is not yet proven, but we just need more data. And then we see a lot of positive results despite negative scans, and we just don't know what to do with it, and that can cause a lot of anxiety. So what about circulating tumor DNA? So we can do that with two sort of purposes, if you will. So looking for a target, and let's say someone has mutations, and we're looking to for a mutation we can target with some of our newer drugs. This is attractive, but as most well-differentiated NETs don't have a lot of mutations, and these mutations are very rarely targetable, it's not very helpful. But we're fairly early on in this, so keep an eye on these tests. I think these tests will get better. Our understanding of the mutations of NETs will get better, so we'll probably see more of this. The other one is what's called tumor-informed ctDNA or circulating tumor DNA. So this is like Signatera. These are tests that we use to detect recurrence, and they appear to be promising in other cancer types like colon cancer, but we just don't have the data for NETs yet. And I'm a little worried that this is not going to work for neuroendocrine tumors because they don't have a whole lot of mutations. So, but we just need more information. We need more research studies. Well, what about testing tumor tissue? So genetic testing is used in oncology all the time now, mostly to identify potential targets for therapy. And mostly, at least in the neuroendocrine world, seems to be mostly limited to poorly differentiated neuroendocrine carcinomas. But there must be enough tissue for testing, and sometimes we just don't have enough tissue. A tiny little biopsy, we have to biopsy again, which is no fun. And there are multiple different providers, and I'm just throwing out a few names there: Tempus, Caris, Foundation Medicine, Exact Sciences, and many other excellent labs that do this. The role for well-differentiated NETs is still small, but this, I think, will only grow over time as we get more information, as we learn more about these tumors. So what about other tests, which we can consider biomarkers? So germline testing to look for inherited conditions such as MEN1, VHL. So, but most NETs are not hereditary, and it's been studied in high-grade neuroendocrine tumors and in other neuroendocrine tumors. And the most patients will have negative tests, but as our tests get better, I think we're going to pick up more positivity, and we just need to better understand what to do with those results. So we're starting to get the tests that look at the efficacy or predict efficacy of therapy. One of them would be something called PPQ or PRRT predictive quotient. It's a relative of the NET test that might predict the efficacy of PRRT. pretty early on still, but something we might be looking at in the future. We can look at some other tissue-based tests, such as mutations in genes called ATRX and DAX, and something called ALT in pancreatic NETs. Still fairly early on, but might be entering a routine practice. And then we're just starting to look at predictors of risks and toxicity. And there's something called CHIP, or clonal hematopoiesis of indeterminate potential, which might possibly predict the risks for like low blood counts and possibly leukemia following PRRT. Okay, so to wrap this all up, I think clinicians should familiarize themselves with the most up-to-date and most recent guidelines. And I want to put this out there. So this is a combined effort of COMNET, which is the Canadian and Australian and the New Zealand NET organizations, with NANETS, or the North American Neuroendocrine Tumor Society. These guidelines were just published late in 2024. They are absolutely excellent. And actually, they do have in the appendix some really good patient-focused stuff in language that's very easy to understand. So this is open to the public. And I encourage practitioners and patients to take a look at this. So if you're going to order a biomarker, I think you should ask yourself these questions. So will this help my patient? And if I order this test, do I have the knowledge to interpret the results and explain them to my patients? And how will this alter the management of my patients? Will I do anything different, or did I just add cost and anxiety? And then make sure that these tests do not result in financial toxicity, that they're covered by insurance plans before you order them. And if there is a co-payment, is there or some sort of like an assistance program that will help with some of those costs? And how do I deal with the potential adverse effects of ordering the test? What if the test comes back positive and there's nothing on the scans? How are we going to deal with the anxiety resulting from that? So the bottom line, net tumor markers should bring value to patient care, and I think that's where we need better information. Most of them don't really bring a whole lot of value, but if you use them carefully, they can be helpful, but they're just an additional data point. On their own, they don't really do much. So treatment decisions should rarely, if ever, be made on marker results alone, and we should therefore use markers selectively. So that brings us to the end of my presentation. Thank you very much.
Hi, everyone. Thank you for having me. I'm honored to be here. My name is Nadine Malak, and I'm a radiologist and nuclear medicine physician at OHSU in Portland, Oregon. The talk today is about what matters about scans for neuroendocrine tumors. And I would like to direct especially newcomers to talks I've given in the past at this meeting, in which I cover comprehensively imaging of neuroendocrine tumors on CT, MRI, and PET scans. Today, I'm going to rather try to address some specific questions that come up frequently. First, this is a topic that I've covered before, but I'm going to reiterate today because it's important. And it's about the multi-phase imaging of the upper abdomen when we're imaging neuroendocrine tumor. So typically CT scans, the standard ones, are done in venous phase. But if we know that we're evaluating neuroendocrine tumors, we want to do it in multi-phase. And the reason for that is that a lot of neuroendocrine tumors enhance on the arterial phase. As you can see in this example of primary ileal neuroendocrine tumor that's metastatic to the liver, we clearly see the metastasis on the arterial phase to the left of the screen, but it's occult on the venous phase. Some other metastases are, however, the other way around. We see them better on the venous phase and not so much on the arterial phase. So if we know we're looking for a neuroendocrine tumor in the liver or in the pancreas, which means in the upper abdomen, we need to get multi-phase CTs. MRIs, on the other hand, are always done multi-phase. But the question that comes up about MRI is which contrast to use. So typically MRI is done with gadolinium, IV contrast, and that's basically what we use if we want to characterize a liver lesion or if we want to image, for example, spine or any other organ. Now for liver metastases specifically, EUVIST is really good. It is the best contrast agent to basically detect small liver metastases and to reproducibly follow up liver metastases over time. So EUVIST is a liver-specific or hepatobiliary-specific agent. it's taken up by the liver parenchyma and not by metastatic disease. So if we image at delayed time points, so 10, 15, 20 minutes, we could clearly see the metastases as dark holes, as we could see here on the 20 minutes delayed. So to look at this case, on the arterial phase, we see the metastases, but you can see that the measurements are a little bit larger on the arterial phase, and that's because of some blood blush around the tumor. On the 20 minutes delayed EOVIST, we could measure them accurately and reproducibly over time. So EOVIST is our contrast agent of choice if we're following up liver metastases over time. Now let's look at some cases at diagnosis and for staging of neuroendocrine tumors. So this is a patient who presented with an incidental 12 centimeter liver mass on CT. This mass was biopsied, and it was shown to be neuroendocrine tumor, well-differentiated, Ki 67 2%, so it's a grade 1. So dotatate PET was done here to look for site of primary malignancy and to also stage the disease outside the liver. Look at how diffuse the metastatic disease here is. There are more liver metastases than we knew of, and there are a lot of bone metastatic disease. And here, the dotatate PET shows clearly the site of primary neuroendocrine tumor, which is in the distal ileum, and I'm pointing to that with a yellow arrow. In addition, you see the bone metastases, which are diffuse, and we see them very well on PET, are actually occult on CT. So if you look at this red arrow pointing to a metastasis in the right iliac bone, we do not see it on CT, but we see it clearly on PET. So dotatate PET here allows us to detect the primary and to stage the disease. Now, if you look back at the CT, we kind of look in retrospect, we kind of see that this tumor was there on CT, but it was really difficult to see. Knowing it's there and looking back, we could actually see a little bit of enhancement there. But detecting that prospectively, it's hard on CT. Now, luckily, things are not as dramatic all the time. So this is another small bowel primary neuroendocrine tumor, and it's pointed at with the yellow arrow. And here, the dotatate PET helps us stage the disease. And this is kind of a classic site of metastatic disease from small bowel neuroendocrine tumors, where they go to the mesentery and to the peritoneum often. So this case had metastatic disease to the mesentery. Now, this is another case. This is a case of pancreatic neuroendocrine tumor. In this case, it was also detected incidentally, where we see on CT that was done for other reasons, that there is a mass in the head of the pancreas, the blue arrow, and there is a liver metastasis, the red arrow. So the liver metastasis was biopsied, and it's shown to be neuroendocrine tumor grade 2. So dotatate PET here, done for staging. Here we see the pancreatic mass, the liver metastasis, and also a lymph node in the upper abdomen, the yellow arrow. So the metastatic disease pattern is different for pancreatic neuroendocrine tumors. Those don't go to the mesentery and peritoneum as much, and they spread to lymph nodes around the pancreas and to the liver first. Now let's talk a little bit about the implication of uptake, or the SUVs, or somatostatin receptors. So somatostatin receptor density, the higher that a somatostatin receptor density is, the higher the uptake is going to be on dotatate PET. So sometimes questions come up as like, how can you tell that there is somatostatin receptor expression? And the clinically meaningful question is actually, how do we tell that there is enough somatostatin receptor expression? Because there might be some expression, but it's not clinically meaningful, which means that the disease we're not going to be able to stage it accurately with dotatate PET or treat it with PRRT. So sufficient somatostatin receptor expression is going to translate as uptake higher than background liver on dotatate PET. So it's not an absolute SUV number. It is basically higher than background liver. So it's an internal reference to the liver parenchyma. So if the uptake is lower than that, it means that it's not sufficient expression. Dotatate PET is not going to be good in these cases to stage the disease, and PRRT would not be a good treatment option. So in this case, we see very intense expression. So this is definitely somatostatin receptor positive disease by dotatate PET. Let's compare that to our next case, and here a metastatic lung net. And although the Ki 67 is 4%, lower than the case before, There are a lot of liver metastases that we see clearly on MRI, and they're not showing uptake higher than liver parenchyma on DOTA-8 PET. And there's a lot of bone disease, and that's also showing uptake predominantly less than background liver. So this is not enough somatostatin receptor expression. Even if there's a little bit, it's not clinically meaningful. Now let's go to surveillance and post-treatment evaluation. So for surveillance, especially if we see the disease well on CT and MRI, we use that for follow-up. We could get DOTA-8 PET every once in a while just to make sure that there is no disease outside the abdomen and pelvis that we're not seeing well on CT and MRI. Now, if the disease is mostly occult on CT, and that's basically if we have a lot of bone disease, for example, that's difficult to see on CT, then we need more frequent DOTA-8 PET to follow it. For response to treatment, we use the size on CT and MRI, but also the morphology, as I'm going to talk about in a bit. And we use DOTA-8 PET after treatment, which is going to be a new baseline for the future. It's going to allow us to detect earlier if there is unequivocal progression after treatment. And we assess for response on DOTA-8 PET by either disappearance of known lesions, development of new lesions, and very important point is that the changes in SUVs alone do not indicate response or progression. So I'm going to show you a few cases of follow-up post-treatment. RECIST 1.1 is what we use on CT or MRI, where we actually follow the size of the lesion. And here, if you look at the criteria, we measure target lesions, and we take the longest diameter of these target lesions, we add them up, and we follow the sum of the diameter. We need a change of more than 30% reduction to call that response and more than 20% increase to call it progression. And the reason for that is sometimes you can have a little bit of variability, like first in between people, like if you have two different physicians measuring, you could have like a little bit of variability of few millimeters. So that's not clinically meaningful. And also if you have different modalities, let's say CT the first time, MRI the next time, we might have like a little bit of variability. So to make sure that it's clinically meaningful, these thresholds of 30 and 20% have been set. And now the RECIST, although it correlates with outcomes and is the most studied in clinical trials, it has limitations. It does not account for the texture of the tumor, how heterogeneous it is, if necrosis happens over time, and the slow growth of the tumor also, like sometimes you need a long time to reach these 30 and 20% changes. So some other criteria have been proposed. They still need to be studied in clinical trials, so we don't use them clinically, but they have been proposed, so I wanted to mention them. For example, the Choi criteria, for which they look for a smaller change of 10%, which takes into account slow growth, and also change in density. So if we have less enhancement, more necrosis, that's also a feature of response to treatment, even if the size doesn't change much. So pseudoprogression is also another kind of limitation for the RECIST criteria and the size only to assess for response, but we see it only early on after treatment. So if we continue follow-up, that pseudoprogression is going to reveal itself that it's only pseudoprogression. And that's basically necrosis and edema in the tumor right after treatment might cause the size to increase a little bit before it starts shrinking. So it's something to be aware of and to wait for, basically, as we follow up after treatment. So to show you some examples, this is a nice example of response to treatment after 2 cycles of PRRT. We see liver metastases, they decrease in size after treatment, so that's great. Now here's another example, and this is after chemoembolization. And after embolization, we see more frequently the change in enhancement in the tumor. So here the enhancing tumor pre-treatment is not enhancing afterwards. So that's what we call necrosis. So the tumor is dead. And we see that just from the change in density, not only the change in size. So the size is shrunk a little, but also the features here tell us that this is a good response. Now, this is another similar case where actually after treatment, we see necrosis and lack of enhancement in these tumors, and then they continue to shrink over time. So on DOTA-8 PET, we look for resolution of lesions that were seen before or appearance of new lesions on DOTA-8 PET to tell whether there is response or progression. So in this case, post-PRRT here, I'm pointing with blue arrows to some metastases that resolved afterwards. So this is a good sign of response to treatment. Now let's look at some of the mesenteric and liver metastases. So this is a mesenteric mass. The size is the same on CT. The SUV went up. So this is an example of changes in SUV alone do not indicate response or progression. So although the uptake kind of went up, we're looking at receptor density. So it doesn't really signify that there's progression. Here, like the mass is stable, some of the lesions disappeared on the post-treatment PET, and the liver metastases are stable on CT. So this is a good response to PRRT, and we continue following up. Now, some of the questions are basically, what are red flags on CTs or MRIs? What do we need to worry about? And there are two things mainly. First, if we have rapid growth of tumor. So if we have a well-differentiated neuroendocrine tumor that's growing slowly, if it starts all of a sudden growing at a quicker pace, that's concerning. And if we see any tumor that is not showing uptake on dotatate PET. So I've shown in past talks some tumors that were not showing up on dotatate PET and how we manage those. Now, this is another case in which here we have a pancreatic neuroendocrine tumor. It's a grade 2. This has been treated with debulking first and then with CAPTEM. And now the patient has been on surveillance. And then we see all of a sudden within the period of 3 months, the tumor started growing quicker. So here we have a change in size of about 40% of this liver metastasis. In these cases, we worry about higher grade disease. We could either do FDG PET or biopsy. In this case, we did FDG PET, and we see that the tumor is very hypermetabolic. So that's basically a sign of higher grade disease. This was taken out. So this couple of tumors in the right liver lobe were resected, and the Ki-67 here was higher. So it was grade 3, and it was more aggressive than the initial tumor a few years ago. So the take-home messages from this talk: the best follow-up modality and the best surveillance is going to depend on tumor location. The response assessment and follow-up is going to basically be based on tumor size and morphology, on CT and MRI, and on dotatate PET, with the important point that changes in SUV alone on dotatate PET do not indicate response or progression. And signs that we worry about is if we do not see uptake on dotatate PET, or if we have rapid increase in size of the tumor, and then we could do FDG PET or we biopsy to look for higher grade disease. Thank you very much, and looking forward to your questions.
Hi, everyone. My name is Vineet Sukritan. I'm a medical oncologist at the Ohio State University Comprehensive Cancer Center in Columbus, Ohio. I specialize in neuroendocrine tumors here at Ohio State, and it's really a pleasure and privilege to be able to talk to you about symptom management and what matters from my perspective. I want to start by talking a little bit about this term that many of you may be familiar with, called carcinoid syndrome, and we'll try to demystify it a little bit. So carcinoid syndrome is essentially present in around 20 to 30% of people, most commonly seen in small bowel neuroendocrine tumors, but not exclusively, with metastasis to the liver. Normally in our bodies, 99% of an amino acid called tryptophan is used by the body and metabolized into something called NAD, which is a chemical that's used in multiple processes in our body. But sometimes what happens is in patients with neuroendocrine tumors, up to 60% of the body's tryptophan is shunted instead to another pathway, which leads to the production of intermediates called 5-HTP, which is further converted into 5-HT, also known as serotonin, and finally broken down into a metabolic product called 5-HIAA. This leads to an overproduction of 5-HT or serotonin, which leads to some symptoms which we call the carcinoid syndrome. Now, these hormones are normally broken down by the liver. But when we have metastases present in the liver, the hormones directly enter circulation and cause a panoply of symptoms we call carcinoid syndrome. There are also other chemicals that do play a role in this process, like histamine, prostaglandins, and bradykinin. But the majority of the symptoms are caused by serotonin and its breakdown products. Let's start with flushing, which is one of the most well-known symptoms of carcinoid syndrome. So what is flushing? It's blood vessel dilation of the face and the upper chest, which can last from minutes to hours. Sometimes it's associated with redness and warmth, and occasionally there are certain triggers that can lead to flushing. specifically food containing tyramine, such as aged cheese, wine, spices, exercise, alcohol, and occasionally stress. Another common symptom associated with carcinoid syndrome is diarrhea. So, what causes diarrhea? It's actually excess serotonin, which increases gut motility, resulting in reduced absorption of water and electrolytes. And what we find is colonic transit time in patients with neuroendocrine tumors is shortened to 5 hours due to the serotonin effect versus close to 18 hours normally. And this is the underlying process of what causes diarrhea. Thirdly, is carcinoid heart disease, which is also a product of excess serotonin in the body. So, what it is, it occurs in around 50% of patients with carcinoid syndrome. It affects the tricuspid and the pulmonic valve, and it leads to damage of these right side of the heart valves, leading to symptoms such as swelling of bilateral lower extremities, abdominal swelling, fatigue, loss of appetite and weight, jaundice, and sometimes liver failure. Bronchospasm is another symptom associated with carcinoid syndrome. This is seen mostly in lung neuroendocrine tumors, also called lung carcinoid tumors. And the main symptom is asthma like wheezing, which sometimes can be confused for asthma, which can occasionally lead to a delay in diagnosis. So, what are the treatments for carcinoid syndrome? We'll talk a little bit about that in the next few slides. Somatostatin analogs are a frontline treatment. What they do is they bind to somatostatin receptors present on the surface of the tumor, specifically SSTR2 and SSTR5. And this leads to a reduction in some of the hormonal symptoms that we've talked about before. There are two long-acting preparations of this, sandostatin and lanreotide. And as many of you may be aware, these are injections given every 28 days. The way they work is they inhibit the secretion of various gastrointestinal hormones, which can reduce gastric acidity and slow down GI motility and improve diarrhea and flushing. They are very effective. So the mean rates of symptom relief when somebody started on somatostatin analog is anywhere from 65 to 77%. They work really well for both flushing and diarrhea. So a complete improvement in flushing is observed in 50% of people, and more than 90% of people have greater than 50% improvement in flushing. As far as diarrhea is concerned, complete control of diarrhea is seen in around 1 in 4 patients, and more than 75% experience a greater than 50% improvement in diarrhea. So this is a very, very effective treatment to control the symptoms associated with carcinoid syndrome. That being said, there are some side effects worth knowing about. They are very well tolerated, and we have lots of people who have been on SSAs for long periods of time. But the side effects that I want to point out is sometimes SSAs can inhibit the release of other hormones, including ones like insulin and thyroid stimulating hormone. And diabetes can occur as a result of a reduction in insulin production. And we've seen this in somewhere close to 25 to 30% of patients. And the reduction in TSH production, which is a thyroid stimulating hormone, can lead to hypothyroidism, which is much rarer. But the literature suggests anywhere from 5 to 10% of people. So I make it a point to always have a discussion with patients and talk about some of these risks and what we can do to mitigate the increase in sugar that can sometimes be seen in patients when they start SSAs. There's also some effect on gallbladder contraction and bile flow. So potentially there is an increase in the formation of gallstones that we do see. Again, it's a small percentage of people over a long period of time. It is somewhere in the range of 5 to 10%. But it is worth discussing with your doctor before we start on one of these agents. So what do we do if initially you don't see an improvement in your symptoms after you've started the SSA? There is a lot of evidence that actually increasing the dose or the frequency, so instead of every 28 days, something like 21 days, actually does improve symptoms. So there was a study that showed that 80% of patients actually had an improvement in their flushing and diarrhea when the sandostatin dose was escalated anywhere from 40 to 60 milligrams instead of the initial dose of 20 to 30. So it's worth talking to your doctor about, whether you feel like the symptoms are not well controlled at the starting dose, is there a role to increase the dose or the frequency? It's also worth remembering that there are many other causes of diarrhea in patients with NETs, especially when they're being treated with SSAs. One of them is actually a paradoxical diarrhea, which can be increased for the first 2 to 3 days after you get your shot. This happens in, again, anywhere from 30 to 60% of people. It's due to fat malabsorption that happens because pancreatic digestive enzymes are not being released to the same level when you're on an SSA. And this leads to fat malabsorption and a condition called steatorrhea, where stools can be fatty. The treatment for this is supplementation with pancreatic enzymes such as creon. Now, beyond that, there are other reasons for why someone would develop diarrhea. One is bile acid malabsorption. And this happens in people who've been treated with surgery, specifically surgery that has involved the terminal ileum of the small bowel or the right colon, or a cholecystectomy as well. And this leads to bile acid malabsorption, which can irritate the lining of the stomach and the colon specifically, and leading to diarrhea. And the treatment for this is actually a trial of something called bile acid sequestrant, such as cholestyramine, cholestyramine, or cholesevolum. And a good relief with this treatment suggests that the bile acid was really what is causing the diarrhea. And finally, short bowel or short gut syndrome unfortunately can happen in patients who've had extensive small bowel resections, especially if the resections are more than 100 centimeters. So this is something to keep in mind in the differential diagnosis when you're experiencing diarrhea and if you have a NET diagnosis. More recently, we now have oral SSAs, so oral forms of somatostatin analogs that are in clinical trials that look very promising. So in phase 2 trials, the results showed that there's an improvement in flushing from a baseline of 2 to 3 times a day to 1 a day, an improvement in diarrhea from 3 to 4 times a day to 2 to 3 times a day, an improvement in the sense of urgency, which can be very distressful, from every day to every other day. And the results of this very promising phase 2 study are now being confirmed in a very large randomized phase 3 trial nationally and internationally, where the drug paltusotine is being compared to a placebo. This is an ongoing study. We are awaiting the results of this study, but we think it'll be practice changing once the results come out. And hopefully we'll have an option which is not an injection for the first time. Moving on to the third medication that is approved and is used for the treatment of carcinoid syndrome is telotristat, also known as Zermelo. So what it is it's a compound that inhibits an enzyme called tryptophan hydroxylase. This is an enzyme that is present in the body, which converts tryptophan into 5-HT, which is then further on converted into serotonin. So blocking this enzyme actually reduces the levels of serotonin and its products in the body. There was a large phase 3 study called Telestar, which compared telotristat versus placebo. And what they found was they were looking for a reduction of at least 30% in the bowel movement frequency from baseline for at least half the time that patients took it. And what they found was 40% of patients met this criteria for improvement as compared to just 20% on the placebo. So this is a good add-on agent for folks who are not getting a good degree of control with just the somatostatin analogs. Some caveats to keep in mind are it does take time for Zermelo to actually work in the body. So the median time for improvement in your symptoms can be anywhere from 4 to 5 weeks. And the pill does need to be taken at least 3 times a day with meals. So I try to counsel patients about some of these aspects so that they have a good set of expectations going in when they start this treatment. The fourth agent that I want to briefly touch upon are antidiarrheals, like Lomotil and loperamide, which you may be familiar with. But what you may not be familiar with is some of the history of some of these agents, which is rather interesting and is closely intertwined with the Cold War. So the story actually starts in 1954 with the commission of this nuclear-powered submarine called the Nautilus, which was entered into service in 1954 by the US Navy. This was a revolution simply because when you have a nuclear-powered submarine, it can stay submerged underwater for up to 4 months. And what this means is you can have a much larger crew on the nuclear-powered submarine compared to a diesel-electric submarine. But the corollary to that is you have a lot of people in a very cramped condition leading to a lot of diarrheal illness. So the US Navy actually funded some of the first work in identifying new anti-diarrheal compounds in the 1950s. And that's what really led to the discovery of diphenoxylate in 1954, which we now know as Lomotil, followed by loperamide a couple of years later. What's really interesting about this is that this also actually led us to be successful in the space race because the Apollo space mission medical kits also had diphenoxylate in them. And this is actually a picture of one of those medical kits from the Apollo missions, where you can see diphenoxylate that was sent to space. Now, I want to switch gears a little bit to symptoms that are not related to carcinoid syndrome, because they are also really important and they are worth talking about. First of them that I want to highlight is lower extremity edema or lower extremity swelling, which can be really bothersome and which can lead to a lot of stress for our patients. There are many reasons for this. It's a little bit difficult to pinpoint them, but I want to highlight a couple of them. One of them is everolimus. We use this compound. It's a drug that's used for treating systemic neuroendocrine tumors. But around 20% of patients who receive everolimus do have edema. So it's worth keeping an eye out for this and talking to your doctor if this happens when you're taking the pill. The other important mechanism is when you are on everolimus, there is an increased risk of metabolic dysfunction, specifically an increase in cholesterol, an increase in blood sugars and diabetes, which in turn leads to something called metabolic dysfunction associated steatohepatitis. That is a big term, but what it's colloquially known as is fatty liver. Fatty liver is increasingly being understood as a problem, not just in patients with NET, but also the general population. But specifically in our patient group, what's important to know about fatty liver is we do have a predisposition to fatty liver when you have had a pancreatic surgery, because it leads to a reduction in some of the digestive enzymes. And this leads to, again, fat malabsorption, and it leads to fatty liver in around 20% of patients. There's also emerging evidence that there's an axis in the body, which is body fat leading to insulin resistance, which leads to inflammation, which leads to both fatty liver as well as neuroendocrine tumors. I think this is an emerging paradigm. We need to pay more attention to this, and we need to counsel people about this, and really very closely observe scans for the development of fatty liver and intervene as fast as possible, and ideally prevent it if we can. And some of the things that can be done for this are weight loss. 150 minutes of moderate intensity exercise is what's recommended. Avoiding calorie-dense foods such as sugary drinks, fatty or greasy food, or ultra-processed food, which have a lot of dense calories, and strength training. And this is true even if you have a neuroendocrine tumor or if you have fatty liver. I think this is also good for your overall health long-term. So I do recommend people to really consider this if they have a NET diagnosis. Excessive cortisol is another hormone that can be produced due to something called ACTH, which is a master hormone that sometimes is produced by neuroendocrine tumors. Thankfully, this is rare, but it's mostly seen in lung carcinoids and very rarely in pancreatic neuroendocrine tumors. Some of the symptoms associated with this are weight gain, especially in the face, abdomen, upper back, thinning of the skin, leading to purple stretch marks, proximal muscle weakness. So some patients tell me, when they have excessive cortisol, that all of a sudden they are unable to climb stairs, which they could do, a few weeks earlier. There's also associated increase in blood pressure and blood sugar, thinning of the bones called osteoporosis, acne, hirsutism in women, and sometimes mood changes such as depression and anxiety. So thankfully, this is rare, but if you are having these symptoms, it's worth pointing this out to your doctor at your follow-up appointments. I want to pause a little bit here and spend some time talking about symptoms of anxiety and depression in neuroendocrine tumors, because I think it's underappreciated, and it would go a long way if we were better about identifying this and addressing this problem in our patients. So there's been some evidence beginning in 2011 and even earlier that neuroendocrine tumor patients have at least a 50% higher risk of anxiety or depression events compared to people without neuroendocrine tumors, specifically in the under 65 age group. And this was shown in a large database of 1,700 patients. More recent research, this one was done in the UK in 50 patients, which showed that 26% of NET patients had clinical anxiety on a validated scale. And more recently, in another study in China in 200 patients, they found that distress and anxiety is present in 30% of patients, depression in maybe around 15%, and some low resilience in 25%. The interesting thing about this is, and some people have asked the question, is this related to serotonin? Because we do know that serotonin levels are important for mood. None of the studies seem to point towards any kind of a correlation between serotonin levels or the presence or absence of carcinoid syndrome. So I encourage people, if you are feeling anxious or some degree of depression about your diagnosis, to really not to ignore it, work closely with your clinical team in identifying it and treating it with professional help. Because I think long-term, really being resilient and, fighting the anxiety really helps you live longer and feel better. And that's the whole point of everything we're doing. And finally, the best treatment for any symptom related to neuroendocrine tumor is to treat the neuroendocrine tumor. Thankfully, we have a plethora of options, including surgical debulking or transarterial embolization. And we have more systemic options that go everywhere. So PRRT, capecitabine temozolomide chemo pills, cabozantinib, everolimus, and sunitinib. So we have an increasing number of options. Thankfully, the options are improving and increasing year by year. So there's been a lot of progress. And so if there is a large degree of symptom burden that you're suffering from, always thinking about, hey, can we do something about the tumor itself, is always the right question to ask. What matters most to control your symptoms and live life to the fullest? I would say focus on the positive, focus on the things that are in your control. Trust your clinical team, work closely with them. If you're having symptoms, mention them to your doctor. And finally, try not to Google your symptoms. That's all. Thank you for your attention.
Thank you, Drs. Kanda, Halfdanarson, Malik, and Sukrathan for your informative presentations, underscoring that neuroendocrine cancer is in fact a cancer, that it is heterogeneous, and it requires looking at the whole person, not just one marker, number, or scan. It truly requires a whole person approach and multidisciplinary care. This next section is on understanding my options, surgery and local regional therapies. Dr. Handafar, when in one's journey is surgery or local regional therapies an option? And I think patients often wonder if they should see a medical oncologist or a surgeon first, or if they should see both.
Yeah, this is a super important question. At every point in the patient's journey, there could be times for a surgeon to be involved or for local regional therapy to be an option. But I think the best time to get everyone on the same page is at the beginning. And I know it's hard, but it's best to see both the surgeon and the medical oncologist right from the start. And then they'll direct you to talk with you to figure out which camp do you probably fit best into. And then every once in a while, you should check in with all the providers. We do that very often in our multidisciplinary conferences where we discuss a case and everyone's back at the table talking about it. Most places don't have that luxury. So if you're in another type of place, you can recreate that experience by occasionally meeting with your physicians and your provider team.
Thank you for describing that. So definitely in the beginning and perhaps different points along the way. Mary, you faced surgery and local regional therapies. How did those decision points feel for you?
Ooh, I can say those decision points weigh very heavily each time. As someone that has had 4 abdominal surgeries, including a Whipple and 2 liver resections, I can attest that every decision has involved a great deal of thoughtful discussion with my team, especially Dr. Handafar, and also the surgeons as well, and the IR doctors. I pursued some fairly invasive treatment because of my age and my health in the past. And at the same time, I knew that local regional therapies may not be ideal for myself due to my surgical history and because of my concerns for infection. So this is where my team and I have to weigh in what's optimal for me and specifically for me. And I really learned to appreciate how individualized the net care has to be for each person individually.
Each person is unique. Dr. Handafar, what do you hope the audience takes away from this topic that will help them in making decisions?
I think it's just super important that in a disease where there's different providers can help in different ways, I hope the audience will try to do their best to engage the entire team as much as they can. And sometimes that means maybe meeting with the provider that's not making that many medical decisions at that particular point. I think that's really important. It's also reassuring, and it gives different perspectives, different ways of solving the same problem. Because I'll be honest, sometimes I'm thinking about something a certain way and I'm doing it as the same way over and over again. And patients deserve kind of a fresh perspective on the situation as it stands. Also, Mary made an excellent point, especially after Whipple surgery, liver-directed therapy is actually potentially problematic or dangerous. So that's another great key learning point from today you should take.
Yeah. So really engaging a whole team perspective and really trusting that team approach. Thank you. Mary, what is one piece of advice you'd like to share with those who may be weighing surgery or local regional therapies as options?
Well, I'm glad I did exactly what Dr. Handafar told me to do, because about 2 years ago, I was having to make the decision between surgery and embolization, and I consulted with him first. And then I spoke to my surgeon, and then I spoke to actually 2 IR interventional radiology doctors about weighing what my next best option would be. And although I have chosen surgery 4 times, I still have considered all treatment options in systemic treatments, local, regional, at every crossroads. So I guess my advice would be to consult, like we've talked about, Lisa just mentioned, and Dr. Hendafar, with all specialties so you are very well educated and know your options and feel comfortable going with your decision.
Getting all the different perspectives help us make informed decisions. And in that note, we're pleased to introduce our next set of speakers who will focus on surgery and local regional therapies for neuroendocrine cancers.
Dr. Julie Halle is a surgical oncologist at Sunnybrook Health Sciences Center, and she will share her valuable insights and the goals of liver surgery and how these are very unique to NET, and also why and when liver surgery is best for those that are living with NETs.
We're very pleased to have Dr. Alejandro Gabuti, who is an interventional radiologist from the National Institute of Medical Sciences and Nutrition in Mexico City. The title of his talk is What Matters About Liver-Directed Therapy. We have a great panel for you, moderated by Dr. Dan Lee, and with panelists Dr. Kalissia Clark, Dr. Ahmed Ahmed, and Dr. Will Chen. They'll be talking about what matters most in making decisions about surgery and local regional therapies.
As a newly diagnosed patient, Rashilda shares her journey of how she found her NET medical team and emphasizes the importance of feeling confident and comfortable with them. She will also open up about how NET has impacted her mental health, and she'll share some steps she took to address and manage her concerns.
Hi, everyone, and thank you very much for the invitation to speak today about liver surgery. My name is Julie Halle. I'm a surgical oncologist with a specialty in neuroendocrine tumors at Sunnybrook Health Sciences Center in Toronto, Canada. I'm also a researcher at the University of Toronto. So today we'll talk about what matters about liver surgery. I'll try to go over why we perform liver surgery for neuroendocrine tumors, and then talk about a little bit of how we do it, who we would do it for, and then how to prepare people for liver surgery. So when looking at the why, I think it's important to go back to what is so special and unique about neuroendocrine tumors. One of the very important things is that this is not like any other cancer. We're talking about a chronic cancer. So people like yourselves may have disease that has spread to the liver or to other organs, but will live for years to come with this disease. And the duration, of course, depends on the specific type of tumors. But in general, people can go on to have very long survival, even in the presence of active tumors. So we have to think about this quite differently than we do in other types of cancers. In most cancers, we try to outrun the disease. We want to be faster. We want to eradicate everything. With neuroendocrine tumors, we're kind of running a marathon with you. And so what happens when the tumors spread beyond the initial organ, so beyond the small intestine, the pancreas, or the appendix, is that often we won't be able to cure. So we won't be able to get rid of all the cancer, but what we can do is we can keep it under control, and we can make sure that you can run as fast as possible, as far as possible, for as long as possible. So really think about the fact that this is a marathon and that we are treating a chronic disease. And so as such, the goals of treatment are quite different. They're all about control, not so much about cure. What we want to control is the tumor volume, so the amount of tumor in your body, the endocrine activity. So if there's hormones being produced, you want to bring that down. And finally, we want to prevent local regional complication, which means problem from just tumors sitting there, like bowel obstruction or compromise to blood supply of certain organs. And much like people that have other chronic diseases like diabetes or hypertension will never get rid of that disease, they may keep it under control and well managed for years to come with different treatments. And so that's what we're thinking about here when we talk about liver surgery. It is a tool for control. It is not a tool for cure. So try to remember that as we go through what is the benefit of liver surgery. The way that I see liver surgery in neuroendocrine tumors is for the treatment, of course, of metastases that have spread to the liver. And it is really a therapy sparing or a therapy prolonging option. What I mean by that is we do have lots of treatments with medications that can prolong the time to progression of tumors. And if there is less tumors for those medications to control, then they can work for longer. So maybe we're not curing anything, but may be that the somatostatin analogs like octreotide or lanreotide that you're on will last longer and will take longer for you to get the next line of therapy. And we're kind of stretching the options over many years. And that's important when we're talking about a chronic cancer and we want to run a marathon for a long time. And the second important aspect of why we do liver surgery is this piece of hormone control and quality of life. By removing as much tumor as possible, we can reduce the amount of hormone secretion and we can improve symptoms. This 96% number comes from over 500 people that were operated in the 2000s at the Mayo Clinic in Rochester. And what they found is in 96% of patients after a liver surgery, there was relief of symptoms. And when we talk about a disease where you're going to live for years with active tumor that we know is associated with persistent symptoms over time, this is a very important goal. Now, what do I mean by we're not curing? Is that we're not removing all the tumors. What we aim to do with liver surgery for neuroendocrine tumors is to cytoreduce or debulk. We're removing the bulk of the tumors. And what is that? That's over 70%. Our goal is not to remove everything. It's to remove over 70% of the disease in the liver. And we know that with that, we can have some benefits. The important thing, as you may understand, is if we don't remove everything, then eventually tumors are going to grow back. It's not whether there will be progression. The question is, when will that progression happen? Like, there will be tumors that are going to grow. There will be new tumors that will show up. But again, what we do is buying time. And time means quality of life. Time means more options down the road for treatment. Now, how do we pick people for liver surgery? There's a pattern of the liver tumors that make it amenable to resection or not, and we'll talk about that in a second. But first, there's some types of tumors that will fare better with liver surgery than others. So that's small intestine, and generally will do better than pancreas. And low grade, so 1 and 2, will do better than people with grade 3 tumors. So that's not to say that if you have a pancreas or a grade 3 neuroendocrine tumor, that liver surgery is not for you. It just means that we have to be a little more careful about how we think about it and how we plan for it. And so we usually will take a pause, maybe try other things to sort of learn about the tumor more to know if liver surgery will truly help. Now, how do we perform that liver surgery? Again, we have to think about neuroendocrine tumors differently than other cancers. In general, when we do liver surgery, for example, colorectal adenocarcinoma, liver metastases, we take out a huge chunk of the liver so that we're able to remove the tumor with a safety margin of about 1 centimeter, and we want to remove everything. We don't want to leave anything behind. With neuroendocrine tumors, because we know that we can't remove everything, we don't aim to remove everything, and we know that tumors will come back, and you will need that healthy liver in the future to be able to go through other therapies. We need to spare as much liver as possible. So what we tend to do is not resecting huge chunks of liver, but rather kind of enucleating, we call it, or scooping out the liver tumors from the liver itself. And we can do that in neuroendocrine tumors because those tumors tend to grow by pushing rather than infiltrating in the liver. So they have like a nice layer on the outside that we can go around to scoop out the lesions. So we think about this differently. And the reason, again, is because I don't think that we can remove everything in neuroendocrine tumors. Even in people that have tried to remove everything and were pretty convinced that they had removed all the tumors, when we looked at the pieces of healthy liver, so liver without tumors we can see under a microscope, in 100% of instances in this study, there was microscopic tumors. So what this tells me is even when we think that we've left a completely healthy liver at the end of surgery, there is probably, most certainly, tumors left. And so a complete resection in neuroendocrine liver metastases is not possible from my perspective. It doesn't mean that it doesn't help. Like we talked about, it can help, but it means that going through heroic measures and very gigantic liver resection for the sake of removing everything is not necessary because that goal cannot be achieved. So here are some examples of what I'm talking about. This is a tumor here in yellow. So in general, for something like this, we would do a resection that looks a little bit like this, taking out all the blood supply that goes to that tumor so everything is removed. We don't want to do that for neuroendocrine. Rather, what we want to do is go in and enucleate, sort of scoop out that small lesion. That's a small one. You may say, okay, that's an easy scenario. Let's look at something more complicated. If I were treating this for colorectal cancer liver metastases, we would do something like this. taking out the entire right side of the liver and then a little bit of a chunk on the left side. Again, don't want to do that in neuroendocrine. What we want to do is go and patiently enucleate or scoop out every tumor one by one. You can also imagine that if you think about it like this, then people that have a lot of tumors that with traditional resections would be deemed unresectable, when you look at it from the perspective of removing one tumor at a time and peeling it off the liver around, more people are amenable to surgery and can derive benefits from surgery. This is an even a more complex situation where if it was a traditional cancer, we would remove 75% of the liver volume and would have to do a lot of other procedures to get the liver to grow before surgery. We don't want to do that in neuroendocrine. Again, we want to go and enucleate each lesion one at a time. And sometimes when those lesions are a little bit deeper and we cannot necessarily scoop them out, we have other tools we can use, like microwave ablation, for example, that we can do at the same time in the operating room. So again, different goals, and with different goals come different techniques for surgery, and it's important to have a surgeon who's aware of that. Now, with these types of surgeries, about 20% of people will have major complications after, and there is a risk of death of 2% at 3 months after surgery, which is on par with other types of liver surgery we do in other diseases. Now, I wanted to talk a little bit about what happens when we cannot operate on the liver. Is there a role for other types of surgery? And I'll speak specifically about small intestine neuroendocrine tumors. Even if we cannot resect all the tumors in the liver, there's a role in removing the small intestine tumor and the nodes that are associated with it. And the goal is to prevent fibrosis that can happen in those tumors, because that fibrosis can lead to debilitating symptoms over time. You want to prevent that. In people that have this surgery, 80% will have symptom relief. So I think it's quite worth it. We also know that if we do that, this is work we've done in Ontario, we're able to prevent unplanned hospitalization or subsequent urgent small bowel operations. So there's really a benefit in going remove those tumors, even when we're not able to remove the liver. And again, here we look at this differently. We don't want to do those typical anatomical resection we do for other small intestine cancer. We want to spare the mesentery, spare lymph nodes, spare blood vessels, so we can spare intestinal length. What does this look like? Well, think about this like sort of a pizza. So you have a pizza, and if you're like me, I don't really like the crust. I like the stuff that's like in the center of the pizza. So what you want to do is you want to get as little crust as possible, but get all those lymph nodes, all those olives and that and the cheese without a lot of crust. So what you see in yellow sometimes we'll have to do. What you see in red is what would be a typical resection for a lot of neuroendocrine tumors of the small intestine. We really want to avoid that. What we tend to do is, again, something that's very tailored, where we're going to scoop out all the olives from the crust in the background so that we're able to remove that with just a little bit of the crust on the rim. So again, thinking differently about a different disease with different goals. So in general, liver surgery or intestinal surgery for neuroendocrine tumors is all about control. The goal is to improve symptom-free survival and quality of life and preserve treatment options for the future. And to do that, we have to think about it differently. We also want to know that you do well after surgery. And I wanted to mention this study called LifeNets that we are running right now with some partners internationally. Our first patients are being enrolled, where we're going to measure quality of life over 3 years after surgery, because it is an invasive treatment and we really want to help. So we want to make sure that you're doing well after. And then finally, I want to say a quick word about how to prepare for surgery, because I'm sure you've heard lots about this. And you've probably heard about carcinoid syndrome and carcinoid crisis. I think that this crowd probably knows about carcinoid syndrome by now. Main symptoms are here: diarrhea, flushing, wheezing. What does it mean when you have surgery or when you have any procedure? When there is lots of stress on your body, there can be sudden secretion of serotonin and other factors that can lead to what we call the carcinoid crisis. What happens with a carcinoid crisis is blood pressure either goes super low or super high, heart rate goes high, and that can threaten your key organ perfusion. And it happens during surgery in about 30% of people. So we want to prevent that, or we want to treat it. Now, we just put together recently an international expert panel to get consensus on what to do with carcinoid crisis, because there wasn't lots of guidance. So I'll go through some of those that pertain most to US patients. I think about this movie that I watched a lot as a kid about how we did things then in carcinoid crisis. A lot of emphasis on giving a lot of octreotide before surgery and after surgery to prevent it. Well, we've realized with time that that doesn't really work, that we don't really need that octreotide. So now we have an approach where we don't necessarily need preoperative octreotide, so you don't need those injections prior to surgery. You don't need a perfusion of octreotide at the beginning of surgery. What you need is a team that has expertise with this type of tumor and with carcinoid crisis that can identify the crisis quickly when it happens so it can be corrected immediately. And the fastest way to correct it is with vasopressors, things like epinephrine. Yes, you can receive epinephrine. It is safe. There were lots of taboos about it that have been dispelled now. So this is the new approach as recommended in that consensus. We do not need pre-procedure octreotide. It's not wrong to do it, but it's not needed. And during surgery, the most important thing is the expertise of the team, recognizing crisis early and treating it quickly. Prevention with octreotide doesn't really work. So what do you need if you have minor or major procedures? Well, first know whether you have carcinoid syndrome and if this pertains to you. You probably need to have your heart checked, make sure there's no carcinoid heart disease before any procedure. An anesthesiology consultation is good, and then add-on octreotide is not necessary. So to finish, what matters most to make your next best decision with this disease? First, know that surgery may be an option. Like, it's important to see a surgeon to know if that could be good for you. Maybe the answer will be no. Maybe they will tell your oncologist, I don't need to see them, it won't necessarily help, but it's good to ask. Then why are we having surgery on the liver? It's to control, not to cure, and the treatment has to be adapted to that. Most important for people with small intestine and lower grade tumor, but it can be possible in others when well selected. How we do the surgery really matters, and that's where it's important to not only seek a surgeon, but seek a surgeon that has a lot of expertise in neuroendocrine and will treat it like a neuroendocrine tumor, not like any other cancer. And finally, know if you have carcinoid syndrome so that you can seek out teams that have expertise in treating that in the operating room, but it doesn't necessarily need to have octreotide. And so with this, thank you again for inviting me and for your attention.
Hi, everybody. My name is Alejandro Gabuti. I'm interventional radiologist in Mexico City, and today I'm going to talk about liver-directed therapies in the context of a neuroendocrine tumor. So what matters most to make your next best decision? For sure, knowledge. First of all, thank you for listening to me, and thank you for giving me the opportunity to explain why interventional radiology can offer. So let's get started. First of all, my full name, it's Alejandro Gabuti Thomas. I'm from Mexico. I got my medical degree by the UNAM, that is the National University of Mexico, and I got training in radiology and interventional radiology in a public hospital in Mexico City called Instituto Nacional de Nutrición, or National Institute of Nutrition. I also have an internship in Milan, Italy, focused on liver cancer. And today I work in the same hospital where I got trained, Instituto Nacional de Nutrición in Mexico City. So what is a liver-directed therapy? It is a medical procedure done by an interventional radiologist. The therapeutic effect only occurs locally in the liver, so no systemic symptoms or effectiveness. It could be very helpful in the treatment of liver metastases for sure. But wait a minute, can a radiologist do treatments? Most of the radiologists mainly do reports of different imaging modalities. They are always behind a screen in the dark, and there are plenty of jokes about their social skills, like comparing radiologists to a vampire. But the interventional radiologists, we are a little bit different. We love the light and talking to people. So we initially are all conventional radiologists, but then we got trained using the imaging techniques to guide interventions. Interventional radiology procedures characteristic is that they are minimally invasive, most of them through a very small puncture of 2 millimeters. They are really well tolerated, fast recovery after the procedure, and can be also really effective. But are interventional radiology procedures for everyone? The answer is not always. The patient should be evaluated by multiple specialists. A clear benefit from the procedure should be achieved, and there are some technical criteria to consider for sure. And how it's possible to execute a procedure within the liver just with a small puncture, that was my face when I was a medical student and someone explained me for the very first time what interventional radiologists can do. So let's make it simple. We use the ultrasound, the X-rays to mainly see inside your body, okay? So this allows us to place a medical device in a very precisely way in order to deliver a treatment locally. It's better to explain with example. So I introduce to you our enemy, a single liver metastasis. This round-shaped lesion within the liver that it's white, shows enhancement with contrast. We use the ultrasound to localize what we found in the CT scan and then to place a needle in a very precisely way. As you can see, we work looking not the patient, but the screen of the ultrasound. This is the percutaneous liver-directed procedure. Go through the skin into the liver. If I use a biopsy needle, it will be called a biopsy. But if I use a therapeutic device, it could be called an ablation. But sometimes it's not easy to find things with ultrasound, so we can also use a CT guidance to place my needle in a very precisely way. When we are under a CT-guided procedure, we can lay in the CT scan in different positions. So it's normal also during the procedure to change a little bit our position. But sometimes we don't have just a single metastasis. We have multiple metastases within the liver, and it's not possible or safe to punct every one. Can you imagine to make 20 or 30 punctures into the liver? It will not be comfortable for our patient. But we have an alternative way to reach them, an endovascular procedure. So we use the arteries as a roadway to get into the liver and then find the vessels who feed these metastases. The access site is almost always in our right wrist or in the right groin. These kind of procedures are performed in a cath lab that is the same one that the cardiologists do to treat myocardial infarction. We use X-ray guidance, and we do an angiography of the hepatic artery. So we use contrast media to depict the whole artery who is feeding the liver metastasis. So far by now, we know how interventional procedures are done. There are two main groups, as we saw, the percutaneous and endovascular, but how do they actually work? First of all, let's go back to the ablation, a single metastasis scenario. We put our needle, in this case, ablation probe, and we deliver energy. Could be heat, could be cold, could be an electric current. The point is to destroy the tumoral tissue. And in the CT scan, you see how now the tumor looks dark, no enhancement, and that means tumor death. So the percutaneous interventions as ablation can be very effective. Good candidates, those patients with 1 to 3 tumors no larger than 3 centimeters. Ideal candidates, patients who has just 1 tumor who measures less than 3 centimeters. In this scenario, ablation could be as good as surgery. So it's a very, very good alternative because fast recovery, almost just 1 day hospital stay, and no wounds at all. Unfortunately, this scenario of a single metastasis in the neuroendocrine ambience is not really common. Moving to embolization or endovascular interventions, embolization means to occlude a vessel. But wait a minute, doesn't blocking a blood vessel cause an infarct? The answer is yes, but the normal liver is the exception. Why? Because the liver has a dual blood supply. Okay, we have the portal vein and the hepatic artery. So if we close the hepatic artery very distally, very close to the tumor, we still have the portal vein who supplies enough blood to avoid an infarction in the kidney. But guess who doesn't have a single vascular supply? The liver metastasis. So we can occlude this artery or this branch of the hepatic artery as a therapeutic weapon to treat our metastasis. So once the catheter tip is placed as selective as possible within the hepatic artery, especially the artery who is feeding the metastasis, we can deliver 3 types of therapeutic agents: just embolization, chemioembolization, or radioembolization. I should mention that nowadays chemioembolization is under investigation because of safety reasons. And it was really common to perform chemioembolization in neuroendocrine tumors, but nowadays we are keeping it out from our first choice as treatment. So further research must be done. So embolization is the main active of these endovascular therapies because they cause the tumoral infection and tumoral death. So embolization, this treatment could help us to stop the tumoral liver progression. Tumor-related symptoms may also improve after embolization as hypertension, hypoglycemia, or diarrhea. And the embolization is an on-demand treatment, so we can receive as many as possible until we have normal liver function. The different techniques as TIE, TACE, or TAR are considered equivalents, but as I said, nowadays TACE is under investigation because of safety reasons. And healthy arteries are mandatory. As I explained, the arteries are our road to reach the tumor. So if we have problems with arterial circulation or arterial surgeries previously, may impair how we can reach the tumors within the liver. Okay, now I'm going to answer some of the most common questions that my patients ask me. First of all, are liver-directed therapies painful? The answer is no. During the procedure, local anesthesia, sedation, or occasionally general anesthesia help us to avoid the pain. But after discharge home, conventional painkillers are usually enough to treat residual pain or discomfort related to the treatment. Are liver-directed therapies safe? Yes, but special orientations should be taken in fragile patients, especially elderly patients, okay? Also, hormonal-related symptoms may increase transiently after the procedure. Think the tumor is a hive, and the bees are the hormones. What happens if we hit the hive? A lot of bees will come out, okay? So the symptoms may worsen, but at the end, the hive will be destroyed and no more bees will be able to come out. That's a little bit how it works. And before any interventional radiology procedure, a multidisciplinary board should assess carefully the case, including the safety profile, and should say it's okay to go ahead. Post-embolization syndrome is something unique that happens with the arterial-directed therapies as embolization. It will happen 24 to 48 hours after an endovascular therapy. Fever, nausea, and abdominal pain are the most common symptoms, and usually it's self-limited and could be managed symptomatically at home. But special attention should be put when we treat bulky disease, big tumor, big infarct, so a lot of symptoms could come out after the treatment. How fast is recovery after a liver-directed therapy? Most of the procedure could be done with a short hospital stay, maybe just one night. And in some selected cases, it could be done as an outpatient way with just local anesthesia, especially when the patient has low tumoral burden, there's a radial access, and a good performance status, so a very strong patient. No special care should be taken after the procedure because, as you know, the wound is really small. It's 2 millimeter puncture, like when we have a blood sample. So there's no need to have rest for a long time at bed or to cover a wound for a long time. And return to normal activities sometimes takes very few time, like 24 to 48 hours post-procedure. But every case it's different, okay? So we have to individualize what the symptoms or the complications may be treated or expected in a patient. So take home points of what matters most to make your next best decision, to know that liver-directed therapies are really effective. Patient selection is mandatory to guarantee a good safety profile. Ablation may compete in effectiveness with surgery, especially in a small single meds scenario. Vascular or endovascular procedures may improve the hormonal-related symptoms as diarrhea, hypertension, or hypoglycemia. Recovery after an interventional radiology therapy is really fast, and treatment-related symptoms could be managed at home. To decide to get liver-directed therapy doesn't exclude you for a different treatment in future, and that's something really important to recognize. Thank you very much.
Welcome, everyone. I'm honored to moderate this panel discussion, really discussing what matters most and how do we make decisions regarding when to do surgery as well as local regional treatments for patients with neuroendocrine tumors. My name is Dr. Danae Lee. I'm a GI medical oncologist at City of Hope and direct our neuroendocrine tumor program. And I'm honored to share this panel discussion with my panelists, and I'll have them each introduce themselves accordingly, starting with Dr. Clark, followed by Dr. Ahmed, and with Dr. Chen. So Dr. Clark.
Hi, I'm Calistia Clark. I'm a surgical oncologist at the Medical College of Wisconsin. I'm the Division Chief of Surgical Oncology, and I also co-lead our neuroendocrine research program.
Hi, everybody. My name is Osman or Oz Ahmed. I'm an interventional radiologist at the University of Chicago and have a very strong interest in what's known as interventional oncology.
Hi, I'm Dr. Will Chen. I'm a radiation oncologist at UCSF, where I mainly treat GI malignancies. I have a special interest in neuroendocrine tumors, which is why I'm here.
Wonderful. So I think we definitely have an entire panel of expertise for this topic that we're going to be discussing. So I'm going to be really kind of presenting two common scenarios as well as cases that we typically see for our patients with neuroendocrine tumors. And then I'll go around and really share the expertise of the panelists in terms of how they look at those decisions and how to make those decisions regarding surgery as well as liver-directed therapies. So kind of starting off, one of the most common scenarios that we typically see would be a patient that generally presents with a well-differentiated grade 1 neuroendocrine tumor of the small intestine. Oftentimes they come, whether or not it's a incidental finding on imaging, or if they presented with some nonspecific symptoms in terms of abdominal pain and ultimately underwent imaging studies to make the diagnosis of the disease. And oftentimes, as you know, for these patients, even when they don't have any major symptoms, oftentimes the disease would have already spread and several times involve metastasis within the liver. So maybe I'll start off with Dr. Clark. If you're seeing kind of a new patient like this, walk into your clinic, well-differentiated grade 1 small bowel neuroendocrine tumor, and I would say even non-functional, so not having any symptoms of carcinoid syndrome. And they have, let's say, 5 lesions in the liver with somewhat of a slightly bilobar distribution. How do you counsel them regarding kind of decision-making and whether or not should they be pursuing surgery as an initial step, or whether any other treatment would be initially indicated prior to thinking about surgery? How do you have that conversation with them?
So I think these conversations are quite nuanced. I typically spend a fair amount of time upfront just talking about neuroendocrine tumor and neuroendocrine tumor biology, and I try to tailor it towards their particular tumor, its location, and extent of disease spread. And so this is when I really impart what we know about how tumors behave. And in a grade 1 patient, I would basically be counseling them on the fact that these tumors can have an indolent course. And so our goal is, in this setting, not curative because we have metastasis outside of where the tumor started, but really to try to convert this to a chronic disease that we can treat and manage without impacting their quality of life over time. And so I think that message is somewhat reassuring for many patients because they've usually had, at this point, some uncomfortable interactions with the healthcare setting. They may have had mild symptoms that have been ignored or not necessarily worked up for several years. And I try to give them the opportunity to work through their frustrations with usually what is almost always a delay in diagnosis. After we get through the emotions of that, then I talk a little bit about what the treatment options are. In a person with a grade 1 small bowel neuroendocrine tumor, I think surgery is certainly an indication, even with bilobar metastasis, for a lot of reasons. Number one, we can try to cytoreduce the tumors by removing as much visible disease as possible, including what's seen in the liver. But also, I think the primary and the mesenteric lymph node metastases from the primary can ultimately cause significant symptoms down the road. And so even if they're asymptomatic now, we definitely want to try to ameliorate any challenges with the primary tumor and lymph node metastasis before they become a problem. I typically do a screen of these patients, even if they're not actively having symptoms, for things like carcinoid syndrome and carcinoid heart disease. And so we would discuss the lab values that we're going to obtain. I do a 5-HIA screen of all of these patients to make sure that they don't need any further workup for carcinoid heart disease. And if they do, then we would talk about that again as well. But typically, if somebody is meeting me for the first time at the time of their diagnosis and they have metastatic disease, even in grade 1 disease, we try to get good biologic control and sometimes symptom control in these patients before going to surgery. And so I think a test of some systemic treatment up front is usually my recommendation. I usually see these patients in conjunction with my medical oncologist. And then after we see the patient, we typically present these patients at a multidisciplinary tumor board to see if there are any other options or tools that anybody wants to implement at this time. But if surgery is something that we can offer to cytoreduce, then we typically would go there as a sort of a step 2. Step 1 being getting them started on some somatostatin analog treatment, and then step 2 perhaps being cytoreductive surgery.
Yeah, thank you so much, Dr. Clark. And I think, for the audience, some nuances here is really the fact that even if you have metastatic disease, surgery is an option. And I think that's what differentiates some of our patients with neuroendocrine tumors compared to other malignancies. So I think it's really good to have kind of that multidisciplinary approach. I'll go to Dr. Ahmed. Dr. Clark kind of talked about kind of debulking and maybe potentially resetting the clock for these patients, even with relatively indolent disease. Where do you think the decision-making kind of comes in about adding the role of liver-directed therapy? What are some of the scenarios that you see yourself where oftentimes liver-directed therapy is incorporated initially in these types of settings?
Yeah, definitely. Great question. So I would say, I think at our institution, we also sort of follow the approach that Dr. Clark outlined with our surgical team as well. We do like the surgical debulking concept for the cytoreduction as mentioned. Now, there's obviously will be some potential situations where surgical debulking may not be feasible. And so if there is a very high tumor burden, then we may opt for something like a bland embolization, which is one of the tools that we have available to us, at least in interventional radiology, to treat these tumors. And specifically, that's a process by which we go through the artery with a very small catheter, and we basically starve the tumor of its blood supply by injecting inert beads into the hepatic arteries that feed the tumors. Sometimes, in addition, another potential role that we play in this scenario is after surgery. Our surgeons are excellent, but sometimes there are maybe 1 or 2 lesions or even 3 lesions that are very difficult to get to or maybe close to critical structures. So we kind of we're kind of the cleanup folks, kind of do the touch-up work. And so there may be a few lesions left or where our surgeons say, can you zap that last 1 or 2 tumors? And in that scenario, we do something called percutaneous ablation, where we'll actually take a needle and then guide it through the skin using imaging techniques to burn that tumor away.
Great. Yeah. So I think a lot of timing of different things where certainly liver-directed therapy can come in, whether it's embolizations or other ablative techniques like Dr. Ahmed said. Let me turn towards Dr. Chen. As a radiation oncologist, sometimes for neuroendocrine tumors, it's less often used in terms of kind of traditional radiation technologies. But there are instances where no matter how skilled our interventional radiologists are, such as Dr. Ahmed, you might not be able to necessarily reach certain areas in the tumor and everything within the liver or other areas. I guess, what are situations where you think patients may benefit from the role of some of the radiation techniques that you often provide to our patients with this type of scenario?
Yeah, great questions. And yeah, I do see, radiation oncology as kind of an additional tool in the toolbox for treating liver tumors, but also, metastases to other organs like adrenal metastases or sometimes peritoneal metastases. We don't see as many grade 1 tumors in radiation oncology. Usually we're seeing metastatic patients with, grade 2 or grade 3 disease. But just like you intimated, sometimes their locations are more challenging for interventional radiology to access, or perhaps, perhaps these tumors are near the dome of the liver, for example, or in the caudate lobe. Those are instances where I've seen our colleagues refer to us. And so we're able to do a very targeted radiation, a technique called SPRT, which stands for stereotactic body radiotherapy. The advantages of this approach are that it's usually quite non-invasive. We essentially do imaging to make a mapping the target. Then we create a radiation plan, and receiving radiation is very much like having a scan. Patients can just lie there and there's a machine that moves around them and delivers x-rays from the outside in. All of these x-rays intersect where the tumor is and deliver a high dose there. But usually we're able to spare organs nearby and also much of the liver from a higher radiation dose.
Wonderful, Dr. Chen. I think that's really helpful to understand where kind of radiation may come in and be helpful to our patients. So usually for a well-differentiated grade 1 neuroendocrine tumor of the small intestine, I think hopefully the audience can get a sense is that there's a lot of kind of nuances and a lot of kind of decision making. There's not necessarily, like I would say, kind of one right answer and everything. And it really takes a group of experts like this, kind of together to really try to define, what might be the best fit, for you and everything. So certainly talk to, your local teams and everything to kind of get that, consensus of, what might be beneficial. I'm going to switch kind of a little bit to a slightly different scenario. So a kind of a second most common scenario that we often see might be someone that has a diagnosis of a pancreatic neuroendocrine tumor. And for pancreatic neuroendocrine tumor, sometimes we might do things a little bit differently because the treatments that we might have for pancreatic neuroendocrine tumors are slightly different, and the response to treatments that we have are slightly different. So let's say you have a patient that has a well-differentiated primary pancreatic neuroendocrine tumor, a slightly higher grade 2, let's say Ki-67 proliferation index about 15%, so meaning that it's dividing a little bit more quicker. And then same scenario where you have bilobar liver metastasis, so stage 4 disease that's already traveled to the liver, non-functional still and everything. In that scenario, Dr. Clark, does that at all kind of change your discussions regarding the role of surgery for your patients? And then if surgery is pursued, does it change your approach whether to resect all the disease or maybe just the primary, maybe just the liver and everything? How do you think about this in kind of this slightly different but very common scenario?
Very different scenario, and it really depends. So tumors in the head of the pancreas require a surgery called the Whipple procedure, which I think many people are familiar with. But in this surgery, you're removing the head of the pancreas, and the portion of the small intestine called the duodenum, a portion of the stomach, and then the bile duct, which connects the liver to the intestine. After that operation, we have to reconstruct the patient. And a part of that reconstruction is the creation of what we call a biliary enteric anastomosis, which is a new connection between the bile duct that drains the liver and the new intestine that we're going to move up towards that area. The challenge with that is that there's bacteria that lives in the intestine, and in normal anatomy, before we take out anything, there's a valve that prevents the reflux of that bacteria into the liver and the bile duct. But after a Whipple procedure, that valve has been removed. And so now after a Whipple, what we've done is essentially created an anatomy that allows for colonization of the liver with bacteria from the intestine, because there's free flow between the bile duct and the intestine. Now, the patients actually live very long, healthy lives with that. However, it does complicate any procedures to the liver afterwards. So surgery on the liver, even blend embolization, as we discussed, as a treatment option for the liver, other ablative therapies, they then pose a much higher risk for infection and abscess after the Whipple procedure. And so a Whipple procedure in the setting of liver disease, where we know that the liver disease or the metastasis is what's going to actually control the length of your survival, really complicates how we can manage the liver metastases. And so if the lesion is in the head of the pancreas, every surgeon should pause in the setting of liver metastasis for pancreatic neuroendocrine tumors. So that's number one about location. Tumors in the body or tail of the pancreas are entirely different. We can resect those without touching that valve between the intestine and the bile duct. So we don't lose any options in how we treat the liver. And so we're much more aggressive about treating tumors in the tail of the pancreas and the body of the pancreas, even in the setting of liver metastasis, because we can address both at the same time, or even then treat the liver later on if we can't really effectively reduce the amount of tumors in the liver. So grade 2 tumors with a Ki-67 of 15 always make me pause as well, because I am not clear about what the tumor is going to do, exactly how it's going to behave. I'm also very interested to know what the grade of the tumors in the liver are, because if those are a higher grade than the tumor in the primary, again, I'm going to pause about whether or not we proceed with surgery, even if it's in the tail of the pancreas. So for grade 2 tumors, we're one of the institutions that like to challenge patients biologically with some neoadjuvant systemic therapy, even if they are candidates for surgery. So let's say they just have a single liver metastasis that's easy to get to, and they have a grade 2 tumor in the tail of the pancreas, and the surgery is still going to be relatively straightforward. I think, biology trumps surgery and surgical techniques. So I want to know that, number one, I'm going in and I'm removing as much of the tumor as we're going to find, and that I'm not going to do a big operation and then 2 weeks later or 3 weeks later, there's another lesion in the liver that pops up. So these are definitely patients that I would like to treat preoperatively with some systemic treatment. There are a lot of options for that. One of the treatment groups that we like to use is CAPE-TEM. CAPE-TEM is a combination of 2 cytotoxic treatments that can decrease the burden of disease, both in the liver and the pancreas. But it also, for me, then makes sure that we're not getting any new lesions popping up for a period of time. And so that the time that we go into for surgery, we feel actually much more confident about removing that disease.
Thank you so much, Dr. Clark. Yeah, I think that there's a lot of complexities here and everything. And I would like to, go to Dr. Ahmed. Dr. Clark kind of mentioned, maybe some pause with reservation for a tumor that's, dividing a little bit more aggressively, potential infection risks and everything, depending on the location of the tumor. When you're seeing these kind of cases, are you having, potentially similar concern? And let's say oftentimes we see some of these liver metastasis in patients from these, higher grade tumors and everything are a little bit bigger. And I can tell you as a medical oncologist, while I would love to give them kind of systemic therapy, my concern is if I give them systemic therapy and there's no response, and let's say a mass in the liver, depending on the location of where it is, essentially knocks off the portal outflow and everything, then I have no other systemic treatment for that patient. So from an interventional radiology perspective, how do you approach kind of this balance of being aggressive, or maybe we should hold back a little bit because of the biology of the disease?
Yeah, obviously a lot of these decisions are very personalized to the specific condition, and sort of taking a holistic approach in that sense. I think some general IR principles that apply for us when we consider treatment, I wouldn't say necessarily the grade or aggressiveness of the tumor, but I think the things that we look at are sort of what's the distribution of the tumor would probably be the first. So where we can mainly act for neuroendocrine primarily is in the liver. So for us, then it makes sense that if the primary site of disease outside of the originating site, if most of the bulk of disease is in the liver, what we call liver dominant disease, then it makes sense to try to go in there and potentially try to control that in a local regional fashion, like you said, to potentially prevent growth and compromise of vital structures in the liver. So that would be one sort of scenario. The other sort of general scenario that we also like to advocate for IR treatments is when your systemic therapies may actually be working, and hopefully they are, but for whatever reason, sites in the liver aren't. That could be one lesion, or it could be all of them. And so if those are progressing despite good control with systemic therapy, then we also consider our therapies as well, again, to try to locally control the liver, because the liver is very important from an overall prognosis standpoint in terms of preventing liver compromise or decompensation.
Yeah, great. And Dr. Chen, as a radiation oncologist, especially for some of these more centralized tumors and everything, where oftentimes it might be difficult to reach. How do you make the decision for those type of patients that have those areas of liver metastasis in a similar scenario here, with more aggressive disease? Do you make the decision to think that adding on additional local regional treatments that you do be beneficial to the patient or not.
Yeah, so echoing what Dr. Ahmed and Dr. Clark have said, many of these decisions are made in a multidisciplinary tumor board setting, very individualized. But in the specific scenario you're mentioning, so like a central, clearly growing metastasis that's threatening at a mass effect that will cause impacts on quality of life or future options for chemo, certainly SPRT is an option if IR-directed therapies are an option. And one of the advantages of radiation is we can reach deep structures. X-rays, energies of X-rays that we use penetrate very well into the body, and so the depth of the tumor doesn't make a big difference for us. I think our main limitation is really we can't treat so much the multifocal tumors, probably as well as interventional radiology approaches might be able to. But if there's a cluster of tumors in a certain region of the liver or a single dominant lesion, that's where SPRT might have a good role.
Great. So one of the things I want to talk about as well is that the first two scenarios that we presented were for patients that had essentially non-functional tumors, meaning that they don't produce any type of excess hormones causing them certain type of syndromes, depending on the hormone that's produced. And I think certainly there are patients that we see that unfortunately have excess hormonal production from their tumors. And sometimes that makes it, certainly much more difficult. And unfortunately for neuroendocrine tumors, a lot of the systemic therapies that I might administer as a medical oncologist, they only really stabilize the disease, meaning that they keep the disease there, they prevent it from growing and everything. But for someone that might be very symptomatic from their excess hormonal production as leading to syndromes, does that change at all in terms of your decision making to introduce any of your local regional approaches earlier rather than later to try to really get that volume of the tumor down and everything?
So I love this question because I think that in the setting of metastatic functional neuroendocrine tumors, especially functional pancreatic neuroendocrine tumors, surgeons aren't always involved in the care of these patients early enough. So what we're trying to do here is reduce as many active cancer cells as possible that are creating or making the hormone that's causing the symptoms. And surgery, which essentially removes chunks of tissue, thereby many of these individual cells that are making the hormones, can be a very effective way of cytoreducing that patient very quickly and almost immediately decreasing the burden of hormone production. I think when used in highly selected patients after discussion in a multidisciplinary setting, surgery is one way, if a patient is actually a candidate for surgery, to ameliorate some of the symptoms that patients are feeling very, very quickly. And then we can utilize some of the systemic treatments that you mentioned that can actually then keep the rest of the disease that we can't quite remove quiet, not growing, not changing for a period of time, so that we can control symptoms that way. So that's one way of doing it. Not every patient's going to be a candidate for surgical cytoreduction or essentially removing as many of the tumors as you can. However, if they're a candidate, it can be a very effective way of managing the burden of disease.
Great. And Dr. Ahmed, Dr. Clark's made a very good, point and everything that, surgically they can go in, they can remove the tumor, reduce the dose. I guess, from your perspective, I think you can do somewhat similar things. That's why I hear. So how do you talk to a patient that's deciding between surgery, or maybe you're saying, hey, I can just offer you interventional radiology techniques and make that decision?
Yeah, this is probably a sweet spot for us, in terms of patients who are hormonally active, because it does work very well when we do what's known as bland embolization and trying to do some of the stuff that Dr. Clark talked about without obviously a surgical intervention, without actually removing the tissue. What we obviously have the ability to do is to go through the artery and basically block the blood flow, cause those tumors to become ischemic, basically, meaning they don't get enough blood flow and they essentially die. And we can do that in a much more minimally invasive fashion that's sort of more quality of life sort of oriented. It's basically an outpatient procedure, 23-hour observation type of procedure. It works incredibly well and can treat every single tumor because we do it in a lobar fashion. So we give it from sort of the parent artery and it goes to every single branch. So every tumor is essentially theoretically devascularized. So it works very well, and it is one of the more common reasons or indications we are doing our local regional therapies.
I'm going to give Dr. Clark a chance to rebuttal because sometimes some of the patients hear that and say, "Hey, less invasive, sounds great. Why would I ever want to do surgery?" But then I also hear from some patients they're like, "Well, but the tumor's still there. Yes, you might have killed it off, but it's still there, and I might want to just get everything out." So, Dr. Clark, what's your sense? And what has been your kind of conversations with your patients when they're kind of trying to decide between these decision making?
So in reality, this isn't really much of a debate. The fact of the matter is that surgeons and interventional radiologists and medical oncologists work together collaboratively all the time in these cases. And we're looking from a team-based approach about what the best option is right now. For example, in a patient that has, bilobar disease, but may have one or two, lesions that can be easily cytoreduced, surgery might be a faster way to cytoreduce than interventional radiology if they have to treat one lobe at a time, for example. The other thing is the size of the primary tumor matters as well. So while we have good options for liver-directed therapy, if the bulk of the tumor is in the primary tumor, then surgery can sometimes be employed to remove the primary tumor. Interventional radiologists can be used to manage the liver disease. And so the most typical scenario is that multiple physicians are working together in these patients and using what tool we think is best able to address what portion of their disease. So it's actually usually not that controversial. I would say that in high volume expert centers, the consensus is actually made at the tumor board discussion and the patient is presented with what we think is the best option.
Yeah, no, I absolutely. I cannot agree more. Let me go to Dr. Chen. So, one of the areas, certainly, as you mentioned, you have radiation techniques that can be delivered to the liver, particularly maybe in areas that might be difficult, for our surgeons as well as interventional radiologists. But I think one of the points here is that oftentimes for our patients with metastatic neuroendocrine tumors, they might even have disease outside of the liver. So, for example, whether it's in the nodal areas or in the bone and everything. So for a syndromic patient that might not have, let's say, bone pain if they have bone metastasis, but they have symptoms of their syndrome, how do you make the decision to deliver additional kind of palliative RT to areas outside of the liver or areas of disease that maybe our surgeons or interventional radiologists are less likely to get to?
Yeah, absolutely. Great question. Just like you mentioned, one of the advantages of radiation therapies is we can reach, any part of the body, bone metastases, nodal metastases, et cetera. And, I will say that compared to interventional radiology approaches and surgery, data for the ability of radiation to reduce kind of hormonal release by these tumors is probably not as robust, but the small amount of data that is available does indicate that radiation can play a similar role. Probably the time frame in which the hormone levels come down is probably slower than surgery, probably most immediate, and then interventional radiology somewhere in between. But exactly like you said, if a patient is not having pain in a bone metastasis, but if we discuss this patient in a tumor board setting and it's felt that cytoreduction would be beneficial, then radiation would be a great option, pretty low risk option for going after that.
Great. So I'll just end with kind of a final kind of quick scenario and everything. For patients that have bone metastasis, does that impact your decision, kind of going back to Dr. Ahmed and Dr. Clark, for cytoreduction if you're trying to get essentially close to 100% cytoreduction? Meaning that, do you count the bone metastasis or not when you're trying to make those decisions?
So I count the bone metastasis when I try to make those decisions, not because we're going to go after them surgically, but because we want to have a plan for those lesions. And so a lot of times, if we're able to cytoreduce all the other visible disease and the bone met is the only outstanding lesion, then we would refer those patients sort of very early on to Dr. Chen or a colleague like Dr. Chen to talk about targeted therapy for that. There's some other options to deliver radiation. We haven't discussed PRRT very much on this call, but PRRT is sort of a targeted radiation therapy that allows us to tag somatostatin analog, which essentially can be drawn to the receptors that are expressed on well-differentiated tumors. And essentially, we can tag that somatostatin analog with a targeted radioactive nucleotide. And by administering that drug, we can get selective uptake of the radiation treatment into tumors themselves. So we can employ multiple different modalities to tackle any lesions, especially bony metastasis, that we usually don't tackle surgically. The biggest thing that a patient needs when they get diagnosed with neuroendocrine tumors, and especially if they have a metastatic disease at presentation, is a very well thought out comprehensive plan that really addresses the tumors that they have currently and the tumors that we all know they're at risk of developing later on. And so trying to make sure that that plan is very clear up front is like my first obligation.
Dr. Ahmed, any last words of advice and everything?
No, I think the overall theme has been that everybody, regardless of where they are, works very closely together to treat these patients in a multidisciplinary fashion. And really, wherever you decide to seek care, I would try to mirror the model of care that Doctors Clark and Chen and yourself have outlined, which, because I think it's very important that it's very nuanced. There's a lot of great treatment options out there, and it's a matter of just not picking between one, but it's sort of sequencing them in sorts of what's right for you and at what time.
Yeah, thank you so much. Very well said. So I would like to really thank our panelists, Dr. Clark, Dr. Ahmed, and Dr. Chen, for joining me to make these decisions. I know it's hard for our patients, but I think what you can see is that really having that whole team approach there, where we're really here for you, and I look forward to helping all of you in the future.
Hi everyone, my name is Rashilda and I've been living with a grade 2 stage 4 neuroendocrine tumor of the small intestines for a little under a year. I received my biopsy report in June 2024, and to say it's been one of the harder years of my life would be an understatement, but nevertheless I'm still here thriving, and I'm going to share just a small portion of my story with you all today. In terms of navigating treatment decisions, when I found out this was a neuroendocrine tumor and that this was cancer, my thinking was that I wanted the very best working on me. So I got online and I was able to find a database of all the doctors in the country that specialized in neuroendocrine tumors. And I found a surgeon that I liked on that database. I saw her patient reviews. They were all so amazing. So I made my way. I called up Cedars. I would like to schedule an appointment with Dr. Alexandra Ganji. Of course, I can't just call Cedars-Sinai and get myself scheduled with a surgical oncologist right away. But they were able to schedule me with an oncologist. And after he did his preliminary workup, the first thing out of his mouth was, I'm going to send you to Dr. Alexandra Ganji. And I was thinking, perfect, because that's exactly who I came here for. And I made my way over to Dr. Ganji. And when I saw her, I think I knew I had made the right decision for me. I've been in healthcare since 2007, and she knew this. Yet she still sat down with me on that first interaction. She drew on her little notepad exactly where my tumor was in conjunction with the rest of my main organs. And then she told me exactly what she was going to do in that procedure to remove that tumor. So I made the decision right then and there to have Dr. Alexandra Ganji perform my surgery. I was very comfortable with her. Her bedside manner was excellent, and she had spent so much time with me in that first visit. I believe more time, probably double the amount of time that I had with all 3 of the visits I had with the surgeon I saw from the other place cumulatively. She just took her time and explained everything to me, and I feel like that was important. So in terms of navigating treatment decisions, definitely getting a second opinion and feeling comfortable with the providers that you have. I cannot stress this enough, and I cannot reinforce this. I also realized the decision to see Dr. Ganji was the best one when she recommended the Neuroendocrine Cancer Foundation group to me. And this group has been a wealth of knowledge. Full transparency, in February when I was asked to do this video, I kind of had a bit of a moral dilemma because I did not feel like I was thriving with neuroendocrine tumor. I felt like I was barely surviving. It was February and I had my first scan in December. The radiology report had some things I did not want to see, and I just became very depressed. So at that time, I was working my way out of that depressive episode. I had restarted therapy and I restarted going to the group just so I could find a way to manage my next scan appropriately. And to say the group has been an amazing wealth of information would be an understatement. The group has been so helpful to me in terms of the specialists that you see and the treatment, learning about all the different treatments that all the different people in that group are experiencing, and also learning from people who've had many more years with this disease, how to manage any scans or how to manage any anxiety or depressive episodes I may have was also significantly helpful. There is no book on how to live and thrive with cancer, but I honestly can say the group has been the closest thing for me to that guide with living with this disease. So I think getting a second opinion is important, finding a provider that you trust, finding a provider that you're comfortable with, and then most importantly, learning what thriving means to me. And I guess I realized that unlike many other people with different forms of cancer, I still work. I still do all the things that I used to do before the diagnosis. So while I do have this disease and it's been a mental struggle, physically I am still able to do all the things that I love doing. And I just decided to make kind of a bucket list of all the things I've wanted to do. And then I've also made the intention of living day to day, not worrying and not stressing and not harping on the things I have no control over. So I'm working my way slowly through that bucket list. I'm seeing all the concerts I want to see. And most importantly, I'm scheduling all those trips I want to take and spending all the time I can with my loved ones, ensuring I'm not doing anything that doesn't spark or bring me joy. And if it's not something I don't want to do, I'm not going to force myself to do it. Just living intentionally and staying present with where I am has been helpful in helping me cope with this disease.
Thank you, Dr. Haley and Dr. Gabuti, for your educational presentations highlighting ways to control, not cure, advanced neuroendocrine cancer. And we thank Drs. Lee, Clark, Ahmed, and Chen for their enlightening discussion on what matters most in making decisions about surgery, liver-directed therapy, and radiation therapy. This next section is on systemic treatments and sequencing treatments. Mary, while it's exciting that there are now many options, people often feel overwhelmed by the decision-making. Could you speak to your experience or perhaps what you've heard from others?
This actually does hit very close to home because I've been there many times and I'm quite familiar with that overwhelming feeling of having to make your next decision. I am constantly reminded, though, which is pretty extraordinary, that most of the treatment options that I have either considered or undergone in the last few years were not even an option when I was first diagnosed. And I do not take lightly how fortunate I am to have the option of choosing different treatments now. I was considered non-operable for many years, and yet recently had the opportunity to undergo a liver resection, but this time robotic. And that was just due to the recent surgical advancements we've had. So as a newly diagnosed patient, what I would say is, I know you're anxious and you feel pressured to make decisions, but take the time to talk to your team. and to get all your questions answered until you feel comfortable and confident and really understand what your treatment options are.
Thanks, Mary. Dr. Hendafar, what do you say to your patients who are at a crossroads, feeling overwhelmed with making a decision?
Yeah, it's a tough spot to be in. It unfortunately occurs pretty often where you're at a crossroads, and as a NET patient, you have many options that are probably equally good, and your provider is talking to you and saying you can do A, B, or C. So I think in these scenarios where there's, call it in medicine, equipoise, which means the risk benefits have been considered and you have three equally good options or two equally good options, I always tell the patients just to go with their gut, what they feel deep down is the right decision for them. And if that doesn't quite help them sort it out, I would just say, you never know how something is going to be like until you do it. And once you do it once, you'll have that experience under your belt. It'll make future decisions much easier. So don't fret too much. Don't overthink it. Just kind of go with your gut, pick the best one. And the process, you'll learn a lot. And the next decision probably be easier for you.
It's a learning process for sure. And this is a challenging place that we've all been in. Mary, you've been on systemic treatments. What has helped you with your decision-making process?
Well, as I just mentioned, my decision-making process was a little bit simpler because in 2011, when I was switching to a systemic drug, there just weren't that many choices. This is when my trusted team suggested I start a trial drug. And at the time, that was everolimus or Afinitor. And I was 41 years old with 4 young children. I was very aware of the goal that it was neither curative and nor likely even to cause shrinkage, but instead stability. And I achieved that goal for 13 years on everolimus, 13 years of feeling well enough to raise my family and to continue my career and to also deal with the chronic side effects associated with the medication, but all the while living with liver metastases. And I consider that a really wonderful success.
You are a success story, and thank you for being part of a clinical trial that helped bring a new drug to market. So thank you for your part in that. Dr. Hendafar, what do you hope that the audience takes away from this topic that will help them in making decisions?
I hope they listen to our wonderful speakers and kind of take Mary Dunleavy's story to heart and just, know that it's never an easy decision to sequence or to pick your next best treatment, but that again, it's a process. And as time goes on and things move forward, I think the decision-making process gets better and a little bit easier.
Yeah, learning skills and doing this along with our team. We're pleased to introduce our next speakers who will focus on systemic treatments and sequencing treatments.
Jennifer Chan from Dana-Farber Cancer Institute will give you a thorough overview of the many systemic treatments available to us, including one that was just approved this March of 2025. You will gain a valuable understanding of what the benefits are compared to surgical and regional options.
Our next speaker, Dr. Cecilia Carreras, is a nuclear medicine physician from the hospital in Angeles Lomas. She'll be talking about what matters about PRRT, what is PRRT, and how does it work. Our next speaker is Dr. Aman Chauhan, who's a medical oncologist from the University of Miami. The title of his lecture is What Matters About PRRT, Preventing and Managing Toxicities and Latest Advances.
Having been enrolled in 2 clinical trials very early on in my treatment and again more recently, I know how important and confusing this topic can be. Dr. Pamela Kuntz, oncologist at Yale, is going to share everything you need to know about the myths and facts surrounding clinical trials.
Next, we have an exciting panel for you, moderated by Dr. Randy Hecht, including Dr. Alexandra Ganji, Dr. Eric Mitra, and Dr. David Zen. They'll be talking about what matters most in making decisions about systemic therapies and sequencing therapies.
In this patient's story, Judd shares his unique treatment journey and what has helped him along the way. You'll hear how his experience has been very positive with his team, which has made him become a very outspoken advocate for NET patients, and specifically men living with cancer.
Hello, my name is Jennifer Chan. I'm a medical oncologist and director of the program in neuroendocrine and carcinoid tumors at Dana-Farber Cancer Institute. My talk today will focus on what matters most about systemic treatments. During my talk today, I'll cover a few different topics, including what systemic treatments are and how they work, what factors influence decisions regarding systemic therapy, and I'll discuss the systemic therapies that are currently available to treat neuroendocrine cancers. So starting first with what are systemic treatments? Systemic treatments are drugs that travel throughout the bloodstream to reach cancer cells that are located throughout the entire body. And this is in contrast to local regional therapies such as surgery, ablation, hepatic artery embolization, and histotripsy that are designed to treat local areas of disease. By getting to the entire body, systemic therapies can treat cancers that have spread. They can be administered through several different routes, including by mouth, as injections under the skin or intramuscularly, or given intravenously. There are several benefits of systemic therapy. They can slow disease growth and spread, in other words, slow disease progression. Systemic therapies also can reduce the burden of disease by shrinking cancer, and this can be particularly important if disease is bulky and causing symptoms related to tumor mass. Systemic therapies also can reduce hormone production and secretion of hormone, and this can be particularly helpful if patients are experiencing symptoms related to hormone excess. The ultimate goals of systemic therapy are to improve and maintain patient quality of life and also to extend survival. As we think about what matters most with systemic therapies, there are important factors to keep in mind, and it's also important to recognize that treatment decisions need to be individualized. As we make decisions, we consider tumor-related factors. We also will incorporate patient-related factors, as well as factors that are related to specifics of the treatment. So starting first with tumor-related factors, some of the important factors that are important to keep in mind are the primary tumor location, in other words, where the primary tumor started. Other important things to keep in mind are features of the tumor pathology and biology, and this can include factors including tumor differentiation and grade. We can incorporate findings from radiology imaging to understand the extent of the cancer, in other words, the stage of disease, and we can also identify locations where the cancer has spread. We can learn important information from nuclear medicine imaging with dotatate PET CT scan to understand whether or not the cancer expresses or has the somatostatin receptor. And finally, we can also understand whether or not the tumor is secreting hormones by understanding whether there are symptoms that patients are experiencing related to hormone excess. So primary tumor location is important, and the reason why it matters is that tumor biology and prognosis vary according to where the primary tumor started. The biology of neuroendocrine tumors that start in the GI tract is different from those starting in the lung and in the pancreas. And stage for stage and grade for grade, the prognosis, for instance, of small intestine neuroendocrine tumors is more favorable compared to lung and pancreas neuroendocrine tumors. The other reason why primary tumor site matters is that treatment sensitivity can also vary according to primary tumor site. For example, some of our treatments that are used to treat neuroendocrine tumors have a higher chance of reducing the tumor size in pancreas neuroendocrine tumors compared to GI neuroendocrine tumors. And also in general, chemotherapy is more active against pancreas neuroendocrine tumors compared to gastrointestinal neuroendocrine tumors. As we think about the pathology of neuroendocrine tumors, it's important to note that there are various categories of neuroendocrine tumors, mainly based on the differentiation or the appearance of the cancer. Well-differentiated neuroendocrine tumors are different than poorly differentiated neuroendocrine carcinomas. They have a very different biology, and we also treat these two categories of neuroendocrine cancers differently. With respect to well-differentiated neuroendocrine tumors, there also are important distinctions based on grade, which are measures of tumor proliferation. Grade 1 disease is lower grade disease, grade 2 is intermediate grade disease, and grade 3, which are more proliferative cancers, are high grade disease. With respect to poorly differentiated neuroendocrine carcinomas, these carcinomas are all high grade by definition. As we look further into features related to tumor grade, again, grade is a measure of tumor cell proliferation that pathologists can see under the microscope on a biopsy by looking at the number of cells that are in the process of division, in other words, the mitotic count. We can also measure grade by looking at the staining for a proliferation marker called Ki67, and the pathologist also can look for features in presence of cell necrosis. As you can see from this table, there are different definitions and categories for grade based on whether a tumor starts in the GI tract or pancreas, or if it starts in the lung or the thymus. But one general and basic principle is that grade, again, measures proliferation and can give us a better sense of what to expect with future growth. Grade 1 disease is slower growing and can spread over a longer period of time compared to grade 3 disease, which is faster growing. The other important thing to keep in mind is that grade is prognostic. Again, lower grade disease grows more slowly and spreads over longer periods of time compared to high grade disease. But the other important thing to keep in mind is that it's important to see how the disease behaves over time. And this is really important because you can gain a lot and understand a lot about the tumor biology by seeing how it grows or it doesn't grow over periods of time. So in the long run, it may be more important to see how the tumors are behaving and growing as compared to relying just on the grade that you see at one single time point on a biopsy. Some of the important features also to keep in mind are patient-related factors that can include age, medical history, and whether patients have other medical conditions that might influence how they tolerate different treatments. Performance status is a way that we measure how patients are impacted by the cancer and how they're able to live with their cancer or how they may be impacted or limited by their cancer. It's also important to consider whether or not patients are experiencing cancer-related symptoms due to the presence or the burden of disease or from hormones that may be secreted by the tumor. One other important thing to keep in mind is that patients may have certain preferences regarding therapy and which agents they might prefer to use and when to use them. Finally, it's important to consider treatment-related factors, and this can include some of the features that I've listed on this slide, including side effects of therapy. They differ from one agent to the other, as does the mode of administration. Again, some agents can be given by mouth, others are given intravenously, or as injections that are intramuscular or under the skin. All of the different treatments vary in terms of the schedule and the frequency of treatment, how available they may be, and the cost in terms of finances as well as time. I'll next go into an overview of the different treatment options for neuroendocrine cancers, starting first with well-differentiated neuroendocrine tumors, where the main categories of treatment include somatostatin analogs, molecularly targeted therapy, chemotherapy, and peptide receptor radionuclide therapy. Poorly differentiated neuroendocrine carcinomas, again, which are different in the biology and different in the treatment from well-differentiated neuroendocrine tumors, are typically treated with chemotherapy, and in some cases, we also will consider immunotherapy. So as we start first with treatments for well-differentiated neuroendocrine tumors, I'll begin by discussing somatostatin analogs. Somatostatin analogs have been a mainstay of treatment for neuroendocrine tumors for decades, and these are drugs that are synthetic versions of the naturally occurring hormone somatostatin. They work by binding to somatostatin receptors that are found on the vast majority of well-differentiated neuroendocrine tumors, particularly those that start in the GI tract and in the pancreas, and also to a lesser degree in the lung. Some of the benefits of somatostatin analogs include that they can improve carcinoid syndrome and other hormonal syndromes by reducing hormone secretion. So, for example, patients who may have carcinoid syndrome can have improvement in symptoms of flushing and diarrhea through use of somatostatin analogs. We've also seen from several clinical trials that somatostatin analogs can slow growth in GI and pancreatic neuroendocrine tumors. There is also data that they may slow growth in lung neuroendocrine tumors as well. Somatostatin analogs are given as injections, either intramuscularly in the case of octreotide or as a deep subcutaneous injection in the case of lanreotide every 4 weeks. We can sometimes shorten the duration in between injections if patients have symptoms that begin to return after a 2 or 3 week time point. And sometimes we also may consider increasing the dose of somatostatin analogs because there is some data that higher doses may be able to slow disease growth. Some of the side effects of somatostatin analogs include diarrhea, GI upset, high blood glucose levels, gallstones, and pancreatic exocrine insufficiency, which is usually manifested by loose and greasy or oily stools. I will say that somatostatin analogs are generally well tolerated, and this is one of the reasons why they also are often used as a first-line therapy. The next category of treatments that we use for neuroendocrine tumors include molecularly targeted agents. And this class of medication works by blocking signaling pathways in cells that are responsible for survival of cells, growth, as well as formation of blood vessels. The main categories of agents that we use in this class include tyrosine kinase inhibitors. The way that these classes of medications work is that they can inhibit receptors that are found on the surface of the cancer cells that can signal for the formation of blood vessels and cell growth and spread. The other class of medications that we use are mTOR inhibitors, which can block the mTOR signaling pathway that also can lead to cell growth as well as changes in cell metabolism. Everolimus is an example of an mTOR inhibitor that is used to treat neuroendocrine tumors. And the benefits of everolimus is that it can slow disease progression. In other words, slow the process of growth and spread to new areas in pancreas neuroendocrine tumors, as well as in non-functional GI and lung neuroendocrine tumors that are not associated with a hormone syndrome. Everolimus is taken by mouth as pills daily. Some of the side effects of everolimus include fatigue, mouth sores, skin rash, high blood glucose levels, decreased appetite, diarrhea, lung inflammation, or what we call pneumonitis, swelling in the extremities, and changes in taste. It's important to recognize that these side effects may occur, and if they occur, it's important to know that doses can be modified to make treatment more tolerable. Cabozantinib is also a molecularly targeted agent. It's an example of a tyrosine kinase inhibitor that works by blocking multiple receptors that are found on the cancer cell surface, including the vascular endothelial growth factor receptor and the receptors called MET, AXL, and RET. These receptors are responsible for blood vessel formation as well as tumor growth and spread. Cabozantinib is one of the newly approved agents for treatment of neuroendocrine tumors and was approved by the FDA in March 2025 for the treatment of patients with pancreatic neuroendocrine tumors as well as extrapancreatic neuroendocrine tumors. And the extrapancreatic neuroendocrine tumors are tumors that originate in organs outside of the pancreas, most commonly in the GI tract, lung, also unknown primary sites and rare primary sites like the thymus. Cabozantinib can slow disease progression and also in some cases can lead to tumor shrinkage, particularly in patients with pancreas neuroendocrine tumors. Cabozantinib is also a tablet that can be taken daily by mouth. Some of the side effects that can occur with cabozantinib include fatigue, diarrhea, high blood pressure. There can be development of swelling and redness and discomfort in the palms and the soles, mouth sores, decreased appetite and weight loss, as well as changes in taste. And again, it's important to recognize and to watch for these side effects because if they do occur, treatment doses can be modified to help make treatment more tolerable and to maintain quality of life on therapy. Sunitinib is another example of a tyrosine kinase inhibitor. Like cabozantinib, although it blocks different receptors from cabozantinib, it has been shown to slow disease progression and is approved to treat pancreas neuroendocrine tumors. Sunitinib, like everolimus and cabozantinib, is taken daily by mouth. Some of the side effects of sunitinib are similar to those seen with cabozantinib and listed here on this slide. Cytotoxic chemotherapy is another broad class of treatment used to treat neuroendocrine cancers and other cancers. They work by killing cancer cells through interfering with DNA replication and cell division. Chemotherapy with alkylating agents, including streptozocin or temozolomide, can be effective for treating pancreatic neuroendocrine tumors. One commonly used chemotherapy regimen for pancreas neuroendocrine tumors is the combination of capecitabine and temozolomide, or CAP-TEM. And this is an oral chemotherapy regimen that can slow disease progression in pancreatic neuroendocrine tumors and also can lead to shrinkage in many cases. More commonly, we do not use cytotoxic chemotherapy for small intestine neuroendocrine tumors, while it is routinely used to treat pancreatic neuroendocrine tumors and also lung neuroendocrine tumors. Some of the common side effects that can occur with cytotoxic chemotherapy include fatigue, nausea, vomiting, mouth sores, diarrhea, a weakened immune system, low blood counts, as well as discomfort and redness in the palms and the soles. Peptide receptor radionuclide therapy, which you'll hear about in several other talks, is a class of medication that consists of a somatostatin analog that's linked to a radioactive radionuclide. The way that these agents work is that they bind to the somatostatin receptors on neuroendocrine tumor cells. They're taken up into the cell. They release the radiation internally to cause tumor cell death. Lutetium-177 dotatate is an example of PRRT, and it has been approved for the treatment of somatostatin receptor positive gastrointestinal and pancreatic neuroendocrine tumors. Some of the benefits of lutetium-177 dotatate is that it can slow disease progression. It can also lead to tumor shrinkage, particularly if it's higher grade disease or if the tumor originates in the pancreas. And lutetium-177 dotatate can also improve symptoms that are related to hormone secretion by disease. Some of the side effects of peptide receptor radionuclide therapy include fatigue, nausea, GI side effects, and there is also a need to use amino acids to protect the kidneys. And there's a small but real risk of myelodysplasia and leukemia that needs to be monitored for. This slide is a summary of all of the agents and the categories of treatment that I just reviewed. I won't go into detail since we reviewed this information already, but I just wanted to point out that it is important to keep in mind some of the factors that we discussed, including primary tumor location, somatostatin receptor presence as we make decisions regarding treatment. There also are some differences in the treatment outcome between these various classes of medication. For example, with peptide receptor radionuclide therapy and chemotherapy, there's a higher chance of shrinkage. So these categories of therapy may be more important for patients who have high burden of disease and symptoms where shrinkage can be important. The way that these treatments also vary is in terms of their side effects. So again, it's important to consider and monitor for side effects. And also as we make decisions regarding selection of treatment, we have to consider patients and their underlying medical conditions because certain agents may be more tolerated and better for some patients compared to other classes of medicines. So again, as we think about the various categories of treatment and the systemic treatment options that are available for well-differentiated neuroendocrine tumors, there are important points that I wanted to make. One, again, is that treatment selection must be individualized and really needs to be made with multidisciplinary input. As we think about sequencing of therapy, this is a very complicated topic and again needs to be individualized, but somatostatin analogs are very often used in the first-line setting, given their effectiveness as well as the fact that they are well tolerated. In some cases, for example, patients who may have high disease burden or who might have higher grade neuroendocrine tumors, we can consider alternative first-line treatment choices such as PRRT or chemotherapy before or even in conjunction with somatostatin analogs. One approach is to select one therapy, and if there is disease progression, meaning growth or spread, we'll switch to another agent. The other important point to make is that there has been a lot of progress in recent years in the treatment of neuroendocrine tumors, and clinical trials are an important way that we investigate and find newer agents. So if there are clinical trials that are available, this should be discussed with your treatment team. Next, turning to poorly differentiated neuroendocrine carcinomas, these are different and more aggressive cancers than well-differentiated neuroendocrine tumors. They are not usually associated with hormone syndromes, although in some cases they can be. As mentioned before, treatment is very different for poorly differentiated neuroendocrine carcinomas compared to well-differentiated neuroendocrine tumors. For the poorly differentiated neuroendocrine carcinomas, we typically will treat with chemotherapy with agents such as cisplatin or carboplatin with etoposide. Immunotherapy also may have a role in the treatment of neuroendocrine tumors, and there are clinical trials that are ongoing to investigate this. So for take-home points, the first point that I've mentioned before and will say again is that treatment decisions need to be individualized and made with multidisciplinary input. There are multiple treatment options that are available, and we need to consider both patient-related, tumor-related, as well as treatment-related factors as we make decisions regarding therapy. And I do want to end on a high note that progress continues to be made in the treatment of patients for neuroendocrine cancers. We have an expanding number of treatment options that are available, and it is our hope that with this progress that we will extend survival and continue to improve quality of life for our patients. Thank you.
Hi, my name is Cecilia Carreras. I am a nuclear medicine physician in Hospital Ángeles Lomas in Mexico City, and I am here to talk about what matters about PRRT. Thank you for taking me for this lecture. So, what is PRRT? PRRT stands for peptide radioreceptor therapy, and for this kind of therapy, we need two statements. The first one is to localize the receptors on the tumor cells, and the second one is to have a specific molecule able to bind to the receptors and a radionuclide at the same time. So here in the graph, you can see the green triangle is the specific molecule binding with a radionuclide, and this receptor will bind to the receptor specifically to show where the tumor cells are in our bodies. With this kind of treatment, we can see what we treat, and we treat what we see. In the left side, we can see a PET-CT, and in the right side, you can see a scintigraphy after the treatment with lutetium-177.8. As you can see, the same black spots in the left image are the same that in the right image. And that's the meaning that we are treating what we see and seeing what we treat. I think this is one of the most important slides on my presentation, where I will try to explain what theranostic is. So theranostics is compound with two words. The first one is diagnosis, and the second word is therapy. Depending what kind of element of the periodic table we are using, we can emit gamma rays, and with this we can make an image for PET-CT or SPECT-CT. Once we have diagnosed or found the cells with the expression of somatostatin receptors, we can use or change with the same molecule, we can change the element for an alpha or for a beta emitter. And with this, we can provide treatment for the patient, which will provide radiobiological effects. What kind of tumors can we treat? All depends what receptors we are looking for. We can treat, for example, neuroendocrine tumors or prostate cancer, but we have to pick the specific molecule which will bind to the specific receptor. In this color code periodic table, we can look which elements can we use for diagnosis with PET-CT, for example, with the red color, or with SPECT-CT or scintigraphy with the green color. We can also notice here that there are some elements colored with blue. These blue colored elements are the ones that we can use for beta negative treatment. For example, lutetium-177 is colored with blue. You can also see here in the lutetium square that we have also a little bit of green. That means that we can perform as well SPECT-CT, and this is very useful for dosimetry. There are other kinds of treatments like alpha therapy or Auger electrons therapy. They are colored with yellow and purple respectively. I will try to explain later in the next slide. So we have here the different kinds of emissions with radionuclides. So the first one, colored in red, is alpha therapy. With alpha therapy, we can see that the molecule is very heavy and it doesn't go very far away from the emission. And you can stop this molecule with just the skin of the patients. So for radio safety, you can use alpha therapy and is very well accepted. The beta emitters, as you can see here in the video, they fly a little bit further than an alpha particle, and you can stop it with a metal plug. For gamma, it's a little bit different because it's not a particle but a photon, and it will fly very far away from the emission point, and you need a lead for stopping this kind of energy. Here in this table is very important to notice that the alpha particles are the most lethal ones because they have this linear energy transference is very high for them because they are too heavy and very energetic, so they can kill any DNA strand in their way. Can you see here in the picture of the DNA? You can see how the alpha particles can hit a lot more than the betas, but with this, we need the crossfire from other cells to hit with beta minus particles, this double strain to kill this cell. It's very important to highlight that for betas to do an appropriate therapeutic effect, we need a high uptake of this radiopharmaceutical. Otherwise, with this, you can notice that if you don't have this double or crossfire, you will not be able to destroy this DNA chain. Very important to remember before PRRT, we need to know exactly what type of tumor you have. And that is important because sometimes the neuroendocrine tumors can have this tumor marker that the name is Ki67. And with this, we can differentiate between grade 1, grade 2, grade 3, or grade 4 neuroendocrine tumors. And for patients to receive PRRT, we really need that Ki67 is really low. Otherwise, the treatment will not be good enough, and the patient will not have enough receptors to receive enough amount of energy to kill the cells. Before the treatment, it's also important to test some laboratory thresholds, because if the patient is with some issues with the blood cells, it will be some complications that we will talk about later on. It's also important to have renal and liver function tests to ensure that the patient has these organs functioning properly before the treatment. We also need to have an imaging study that the name of the study is PET-CT, and the radiopharmaceutical used to imaging is dotatate or dotatok, and it is labeled with gallium-68 or copper-64. This is also important because with this we can ensure that the patient will receive enough amount of energy or treatment or beta particles after treatment. The PET-CT is a hybrid study. It's done with something that shows the metabolic imaging and also the anatomic imaging like a CT or MR. In this patient in particular, we can see after the treatment, this was the tumor located in the pancreatic and also with some adenopathies in the near zones. And after the treatment, it was smaller and the uptake was lower as well. After this, the patient received surgery to take out all the remnants. So in the treatment overview, the patient will receive 4 cycles of 177 lutetium dotatate, and the activity that he will receive is 7.4 gigabecquerels or 200 millicuries every 8 weeks, and each treatment or each treatment visit can last 5 to 8 hours because we need to pre-medicate the patients with some antiemetics, because one of the most frequent symptoms after the treatment is nausea. It's very important to pre-medicate, and also the amino acid solutions can produce this effect. So the first thing that we have to do is antiemetic pre-medication. Afterwards, we start with the amino acid solution infusion, and this is for renal protection. And after 1 hour of the patient came to us, we have to start with the infusion of 177 lutetium dotatate. It's been very important to notice that after finishing the PRRT infusion, we will continue with the amino acids for renal protection. There are some symptoms related to PRRT that you must be aware, and if some patient or the family of this patient notice that they're presenting these symptoms, so they have to communicate it to the physicians or nurses. It's also very important some radiation safety recommendations, and they are divided into 3 big groups. One is sleep, that the patient should sleep alone, no sharing beds with adults, infants, or children, and of course, no with pregnant partners. The second group is urination, or the excretion of the radiopharmaceutical via renal excretion. So the toilet should be flushed twice, and it's very important that the patient sits in the toilet. Also, as a general recommendation, distance between the patient and the public should be at least 3 meters and stay no longer than 1 hour per day. This is an example of a patient journey, and I only want to highlight the importance to notice and to know where the nuclear medicine department is when somebody has a neuroendocrine tumor, because after the first symptoms and diagnosis, all the steps further will be in contact with the nuclear medicine physicians at the beginning for staging and to grading to say if you or the patient have enough somatostatin receptors for treatment or not. After the treatment, that it could be surgery, chemotherapy, radiotherapy, or PRRT, the patient must be evaluated for response assessment, and it has to be as well with laboratories, imaging, and any study from nuclear medicine department. After the treatment, we can divide the patients between responders and non-responders, and in both cases, they will be attending regularly to the nuclear medicine department. So with this, I close my presentation. I thank you all for your attention.
Hello, everybody. My name is Aman Chauhan. I'm a medical oncologist. As you know, we have made a lot of progress when it comes to neuroendocrine cancers and new drugs and how we treat these cancers. And theranostics related modalities, be it dotatate PET scans or now PRRT, Lutathera, have really revolutionized the way we treat these cancers. As you can see on the diagram in front of you, I've labeled all the theranostics related, either both diagnostics as well as therapeutic trials and drugs in front of you with a star. So PRRT is a very, very important tool in our toolbox to fight this cancer. However, like any medication, we have to be very careful in selecting the right patient. Each treatment has a potential for side effects and harm. So we have to guide the patient appropriately so that they can undergo treatment with least possible side effects. So Lutathera right now is the only FDA-approved PRRT agent in neuroendocrine tumors. And if you type in Lutathera package insert, this is the information you'll find. It's freely available online. And this drug was FDA approved based on a large important study called NETTER-1. And NETTER-1 study tested Lutathera against high-dose octreotide. In this slide, you can see the side effects that was noted in the Lutathera arm versus the control arm with octreotide. If you look into all comers, any adverse events, in the top line, 96% of patients reported some side effect on the Lutathera arm as compared to 86% in the high-dose sandostatin arm. To reassure all the audiences here, these includes even every mild to severe adverse events. So if you sniff, if you sneeze, it is noted down, right? So the meaningful adverse events are SAEs, severe adverse events, or grade 3, grade 4, higher grade illnesses, which has potential to cause trouble. It was 26% for Lutathera and 24% for high-dose sandostatin. So relatively even keel. But when it comes to efficacy, the patients who were on Lutathera, as we now know, had stability of disease for almost 28, 29 months as compared to just 8 months on the control arm. Moving forward, so what type of SAEs were noted in the Lutathera arms? Primarily, it's a radiation-based treatment, so radiation can cause bone marrow suppression. Although this drug is designed to target neuroendocrine tumors because it attaches itself to somatostatin receptors, which are present in neuroendocrine tumors. But while the drug is circulating in the body, normal exposure to other organs, including bone marrow, is what happens. And bone marrow being sensitive to radiation, we do see bone marrow suppression. In fact, that is one of the reasons why we space the Lutathera treatments 2 months apart, because we expect some bone marrow suppression. And then within a month, month and a half, the counts recover and patients usually back to normal at 2-month mark when they're due for the next dose of Lutathera. As you see, these are extremely rare as compared to the subset of over 100 patients were treated in the Lutathera arm. So these are very smaller numbers. Now, for practical purposes, I like to divide the side effects that we often see or notice with Lutathera or PRRT into three categories: acute, subacute, and long-term. Acute means it happens immediately or over the next couple of days. Subacute, these are the side effects that can happen over the next several weeks. And long-term, these are residual side effects that patient may experience long after they've been exposed to PRRT, several months to years later. Let's discuss acute toxicities. The commonest acute toxicity is nausea and vomiting. One of the problems with the amino acid is it is highly emetogenic. That means it makes you throw up, makes you feel nauseous because of the osmotic pressure. Fortunately, since the FDA approval of Lutathera, we almost never use the amino acid that was originally used in the clinical trials. For example, in our center, we use AminoProtect. It has two amino acid, lysine and arginine. It is very well tolerated and does not have a lot of nausea or vomiting side effects. And some patients who may be a little bit more sensitive, we often prescribe them Zofran for the first few days if they do feel queasy and have that nausea issues. But this problem has largely been solved with help of appropriate amino acid infusion. The other acute toxicity, that means a side effect that we see immediately post PRRT or over the next day or two, is carcinoid crises. Now, as you know, some patients with neuroendocrine tumors, they can secrete certain hormones. Based on what hormone they secrete, they are classified to have the functional neuroendocrine tumor. For example, carcinoid syndrome patients have high serotonin secreting neuroendocrine tumor. Some patient might have VIPoma, where the pancreatic neuroendocrine tumor is secreting VIP. Insulinoma, where the tumors are secreting insulin. By far, the commonest functional syndrome is carcinoid syndrome. And patients who have uncontrolled carcinoid syndrome, after they get treated with PRRT, they may develop carcinoid crises where the tumors are being radiated. As they die, they spill out that stored serotonin in their cells. And that sudden surge of serotonin can cause acute crises, which patients are familiar with, and they may have dizziness because of low blood pressure. They may experience diarrhea, they may experience flushing, headaches, etc. So patients who have carcinoid syndrome gotta be on a lookout for potential of carcinoid crisis and be prepared. And what do we do? One is being aware that this can happen, so that if you need to seek out help, you go to urgent care or emergency room, you can tell, I'm a carcinoid syndrome patient, I got this drug, so they can start you on appropriate supportive care drugs. And then also have short-acting octreotide handy. That's what we use for acute crises. And of course, patients who are functional neuroendocrine tumor patients, they oftentimes continue the monthly injections after the Lutathera. So if they're due for one, that is also recommended that the patient gets the scheduled monthly somatostatin analog injection. Moving forward, now we've kind of been through the first few days and we are kind of hitting first few week, and those are subacute toxicity timelines. What do we expect in the first month? Roughly about 2 to 4 weeks from infusion of PRRT, we can expect some blood counts to be lowered. Again, this is very common, expected. Most of the time, this is a mild to moderate lowering. It's very rare for us to see patients having severe cytopenias, but it can happen, and this would be the time to see that. Cytopenias are so rare that we don't give the growth factors, or these are immune booster shots, what we call commonly. These are shots that stimulate production of new white blood cells, which are very commonly given with strong IV chemotherapy drugs, but is not needed with PRRT because our counts oftentimes don't fall that low. Transfusions also rarely needed. But again, if there are rare patients who are experiencing a lot of fatigue and we check their blood count and their hemoglobin is now 7 or 8, they might benefit from blood transfusion. Majority of patients, that we do not expect the hemoglobin to fall that low. Same rule lies for low platelet counts. Majority of patients will not have severe thrombocytopenia or decline in their platelet counts. But if you have a patient who started having bruising, a lot of bleeding during brushing, nosebleeds, it's fair to check their platelet counts. And if they are low, then the doctor will give them the platelet transfusion. Again, this is a complication that we see a few weeks into the infusion and is also very transient. Those who do experience low blood count, it reverses relatively fast. In my experience, within 2 weeks, the count should improve. This is important in patients who have had prior exposure to chemotherapy, especially alkylator chemotherapy. You've probably heard of a chemo regimen called CAPE-TEM, capecitabine temozolomide. Temozolomide especially can have a profound effect on bone marrow, and patients who've been on temodar-based chemotherapy for a long period of time are even more risk for developing blood count issues with PRRT. What are some other subacute toxicity we need to be aware of? Small bowel obstruction. Now, one of the commonest sites for neuroendocrine tumor origin is bowel. And one of the commonest places where it likes to metastasize besides liver and bones is lymph nodes. And these lymph nodes oftentimes are in the bowel or around the bowel, in the mesentery. So if we have a patient with a lot of mesenteric disease, big bulky disease in the abdominal area, or peritoneal carcinomatosis, this is when the cancer is spread over the coverings of bowels, the peritoneum, and it basically cakes the whole abdominal cavity. These are the patients who are at a very high risk for developing bowel obstruction after the PRRT. Why? Because as we infuse the PRRT agent, it goes and binds to the tumor. If the tumor is in around the bowel area, the drug will sequester there, and the radiation is going to cause inflammation. Inflammations cause swelling, and that transient swelling can cause the bowel obstruction. And in a rare event, we've also noticed perforation, and patient may present with septic shock. So fortunately, this is a rare complication, and it is important to select the patient population appropriately. If there's a very high risk of this happening based on the bulk of the disease and location of the cancer, we might opt for another option before we're doing PRRT. So these are the things that we got to be aware of. And many high volume centers are now prescribing 2 to 3 weeks steroid course to minimize that radiation-induced inflammation and swelling, and to reduce the risk of bowel obstruction. The data regarding this practice is very limited, but it is a relatively low-risk proposition, and many doctors, including myself, we do consider giving steroids prophylactically to prevent obstruction. Now, other subacute toxicities that we got to watch out for is kidney impairments. We've been treating patients with Lutathera and beta PRRT for a while, and we have a lot of confidence in long-term safety to the kidneys. In fact, there are now a couple of very good publications supporting that post-Lutathera, we do not see increased incidence of renal problems. And in fact, patients who have mild renal insufficiency, even they tolerate these treatments very well. However, there are some patients who at baseline might have borderline renal function, maybe for years and decades of uncontrolled diabetes, high blood pressure, or some other renal issues. So gotta watch those patients very closely in terms of how they tolerate the PRRT. We give amino acid infusion during PRRT infusion to protect the kidneys. We don't want this drug to be hovering around the kidneys and radiate the kidneys. So all in all, from kidney standpoints, Lutathera is very, very safe, but gotta be careful. And I encourage my patients to drink plenty of fluids after Lutathera infusion for several days. They are not dehydrated and don't add stressors to the kidneys. What about liver? Well, the data regarding hepatotoxicity is relatively scarce. Most patients who are treated on the clinical trials, they oftentimes have normal liver functions. In fact, no trial treat patients who have more than 3 times upper limit of bilirubin, unfortunately. So it's not that I have a lot of data to quote regarding safety of PRRT in patients who have very high volume disease in the liver with compromised liver functions. Having said that, my anecdotal experience as well as some case series have suggested that PRRT is very safe, even in patients who would have large volume disease affecting the liver. We just gotta be careful. And if there are other alternative options, sometimes we use those as well. One of the markers that I watch very closely in this situation is bilirubin. If the synthetic function as well as the bilirubin is elevated, then my concerns are higher with terms of liver toxicities. But if liver synthetic functions are normal, bilirubin's normal, it's just that it is a high volume disease in the liver, I feel relatively comfortable in treating or recommending PRRT to those patients. We also have other tools in our toolbox, so don't forget that PRRT is not the only way to treat the disease, and we can also consider liver-directed therapies among various other agents as well in these cases. All right, now let's jump on to the last segment of the toxicity, the long-term toxicity that gets everybody concerned, and rightly so, is long-term risk of leukemia or myelodysplastic syndrome called MDS, where it's sort of like a bone marrow failure. Your bone marrow does not make blood cells, thrombocytopenia, etc. Fortunately, this complication is very rare. Based on what we know so far, both from prospective studies as well as retrospective studies, this risk is about 1 to 2%. So it's a very low risk, although it's not 0%. So you got to always counsel patient that there is a very teeny tiny possibility of this happening. And if this happens, it happens over several months to several years later. What we are also learning now is patients who have had prior exposure to a lot of chemotherapy, especially alkylator-based chemotherapies, as we mentioned, Temodar, theirs might be a little bit higher, although this is based on smaller studies and retrospective data. So they got to take it with a grain of salt. So my personal practice has been moving away from prolonged use of chemotherapy, as most of our patients would eventually get PRRT. Having said that, this risk of AML and MDS is very, very low at this point in time with the current FDA-approved agent. How would this risk pan out in the era of the novel PRRTs, the alpha PRRTs, and the retreatment strategies where we're giving more than the currently FDA-approved doses of PRRT? That is yet to be known and is a topic for study. All right, so in conclusion, beta PRRT, which is lutetium-177 dotatate or Lutathera, the only FDA-approved agent as of today in the United States, is safe, effective, relatively convenient. It's only 4 doses, and each dose is every 2 months. Has a very good, safe side effect profile, much favorable as compared to many other systemic therapies, the targeted therapies that we know of. In fact, this one was one of those rare cancer studies where the patients reported better quality of life in the study arm as compared to control arm. So all in all, relatively safe, but that doesn't mean that there are no side effects. And we went over some of those acute, subacute, and long-term side effects. Patient needs to know about those, empower themselves so that they can recognize the symptoms and flag their doctors so that they can start the appropriate treatment at the right time. So what is the future of PRRT? Well, there are newer PRRT agents, one of them being lutetium-177 edotriotide, which is a sort of another Lutathera drug by another manufacturer. And they reported their data from COMPETE study from the sponsors ITM at recent ENADS. And the study was reported positive. And hopefully this leads to another agent being FDA approved in the US. So we now have not one, but multiple options in future. That's our hope. Other group of PRRT agents called alpha PRRT are under investigation using actinium-225, lead-212. That would certainly give more choices to our patients and providers, and more tools to how to treat these cancers. We are also investigating several novel combination strategies. So we know Lutathera is a very effective drug, is also very safe, but can we make it even better? And there are several studies currently looking at combining Lutathera with radiation sensitizers, triapine, olaparib, peposertib, cabozantinib, so on and so forth. In near future, you'll see and hear about more data. Again, the goal here is to improve the effectiveness of these agents, to reduce the side effects, be it short-term and long-term side effects, and also make it user-friendly, reduce financial toxicities for our patient. All right, with that, I'm going to highlight some of the key national multi-center studies which are currently ongoing, and you can look out about these studies in detail at Neuroendocrine Cancer Foundation website as well as clinicaltrials.gov. One of the study, this is Dr. Simran Singh and myself are collaborating across the border of Canada, US joint effort, where we are trying to see patients who've got Lutathera at progression, could they benefit from more Lutathera? And as long as they benefited at least for a year or longer after the initial Lutathera, We are taking this hypothesis under this cooperative group study, which is open at several sites throughout the US. And we're going to retreat patients with limited dose Lutathera and compare it to standard of care everolimus. So very, very important study for us to generate a role of continued Lutathera retreatment strategy at progression. The other study which is going on right now is by Dr. Petta and Dr. Hope, and is looking at PRRT or Lutathera in lung net patients. Patients are going to be randomized into Lutathera versus standard of care everolimus. This is also a national study open at several sites. So lung net patients, please look into participating in the study. Moving forward, this is a concept that is under development and very, very exciting. I've been working on this for now almost 7 years. So we are combining Lutathera with a drug called triapine, which is a ribonuclide reductase inhibitor. It's a pill that patients take with Lutathera. So the way the Lutathera works is damages the DNA of the tumor cells. But then you may ask me, why do the cancer cells survive and come back? Is because the DNA of cancer also heals itself. The tumor cells have the capacity to heal the DNA. So what we are trying to achieve here is we damage the DNA with Lutathera and we try to block the repair process with the triapine. So we did some animal studies, looked very promising. And then we did first in human phase 1 study that looked promising. And that led to this ongoing phase 2 national studies open over more than 14 sites through the US. And if it looks promising, the next step would be the randomized phase 3 study. So you've heard all these studies that I talked about were beta PRRT or lutetium-177 based PRRT agents. What is beta PRRT? It's the type of ionizing radiation. As you can see here, there are 3 main types of ionizing radiation that we use in medicine. Beta ionizing radiation is what we use from lutetium-177 to cause single-stranded DNA breaks in neuroendocrine tumor patients. However, there are a set of drugs that are alpha PRRT. These are alpha ionizing radiation emitting radionuclides like actinium-232 or lead-212, actinium-225. So these have different physical properties. The alpha PRRT, alpha ionizing radiation is high energy but low path length. Beta has lower energy but longer path length. So it's not that one is better than other, they just have different characteristics. So there is an ongoing study called Action 1. Action 1 is looking at patients who have previously been treated with lutetium-177 dotatate and has progressed and are in need for more PRRT. Patients will be randomized to the study arm, which is an actinium alpha PRRT arm versus standard of care. And this was a very important study open at various sites in the US and abroad and looking at role of alpha PRRT. There are also other studies which are either in development or already enrolling, especially lead-212 based alpha PRRT studies that patients may want to look into at clinicaltrials.gov. With that, I would like to thank you for your time and attention. And thank you, Neuroendocrine Cancer Foundation, for this opportunity to speak to your patients.
Hi, my name is Pamela Coons, and I am a medical oncologist at Yale Cancer Center. It is my pleasure to talk to you today about what matters about clinical trials. These are my disclosures. And I will be reviewing clinical trial facts, clinical trial interpretation, what's on the horizon for new clinical trials, how you can find a clinical trial, and to bring in the theme, what matters most to make your next best decision as it relates to clinical trials. So first, why are clinical trials important? Clinical trials are key research tools for advancing medical knowledge and patient care, and we do clinical research to learn whether a new approach is safe and effective and which treatments or strategies work best for certain cancers or groups. And I think really one of the most important is that clinical trials provide hope. Yet only 7% of US adults with cancer participate in clinical trials. So I'd like to try first to separate myths from facts, and I think we will talk more about this as we go through the presentation. So the first myth is that clinical trial participants are, quote, guinea pigs. The fact is that strict guidelines are in place to inform clinical trial volunteers and protect their safety. We have informed consent forms and really go over the entire design of a trial with patients and families. The second myth, if I join a clinical trial, I will receive a sugar pill or placebo instead of the real medication. Placebos are used less and less in NET clinical trials and are really only ethical if there are no standard treatments available. And that has really fallen out of favor for NET clinical trials, in large part because we've had so many advances in the last decade. The third myth, once I decide to participate in a clinical trial, I cannot change my mind. When in fact, the truth is that you are free to leave a clinical trial at any time, even after you have signed the informed consent. Fourth myth, there are no costs associated with a clinical trial. While many aspects of a trial are covered, some participants will have copays with standard items, such as a standard routine doctor visit or a routine scan that might otherwise be done as part of standard of care. The fifth myth is that clinical trials are only for patients without other options. The truth is that there are clinical trials available for all stages in many situations. For example, that includes patients who've had curative intent surgery and may be looking at a clinical trial for postoperative treatment. So the path to drug approval in the oncology world is long. It includes preclinical studies in test tubes and in mice, moving on to phase 1 clinical trials with the purpose to evaluate safety, phase 2 clinical trials with the purpose to start evaluating efficacy. A phase 3 trial includes many more patients. In NET trials, it's often just hundreds of patients looking to identify whether a new treatment is better than an old treatment, and then moving on to FDA review. And even phase 4 trials is post-FDA review to learn more about safety. Sponsors for clinical trials include investigator-initiated, industry-initiated, and the National Clinical Trial Network, or the federally funded trials. So a sponsor is really who is responsible for the trial. Sometimes this includes funding, but really who is legally responsible. So investigator-initiated trials are usually an idea initiated by an academic physician, often smaller, usually available at a single institution, and the funding usually comes from that institution, sometimes philanthropy, a private organization, and/or a pharmaceutical company. Industry initiated, usually that idea is from that pharmaceutical company, could be any phase, usually involves multiple sites in academic institutions, and sometimes is international, and that funding comes from the company. For the NCTN or federally funded trials, the idea is usually initiated by an academic physician, multiple phases, open at centers who participate in that National Clinical Trial Network, and the funding is federal. I'd like to move on and talk about why these federally funded NCTN trials are important. They represent an important way to ask practical questions that won't often be asked by pharmaceutical companies, like standard of care comparisons. In fact, we have a number of these trials in the NET space because we need multiple sites in order to accrue effectively. So I've listed 5 here. Unfortunately, the first one, the Alliance trial of lutetium dotatate versus CAPTEM in pancreatic NETs, closed in March of 2025 due to low accrual. We still have 4 NCTN trials open in LungNet, PNET, GEPNET, and in pheoparaganglioma, but we risk of these other important trials closing if they don't accrue. I'm sure many of you are asking this, and I get asked this question: why should someone consider a trial for an already FDA-approved treatment? Well, a trial may be comparing one FDA-approved treatment to another, and we learn key information on how to sequence these treatments. There's usually equipoise for the treatment arms, meaning that we don't really know if one is better than another. And there are really no more placebo-controlled trials in NETs. So for example, that one that just closed was lutetium dotatate versus CAPTEM in pancreatic NETs. We don't know if one is better than another, and that question will never get answered because unfortunately that trial closed. The side effects for these are well understood because they're already FDA approved, and you will pay it forward and help future patients. So moving on to thinking about how we design and interpret trials, we think about eligibility criteria. It's like a checklist. which primary site, which grade, which stage, is someone progressing or not, have they had prior treatment? And then we think about how are we going to measure success of the trial? Usually the most common endpoint in NET trials is something called progression-free survival, or PFS. How long does it take for the tumor to grow? Overall survival, response rate, and safety are usually secondary endpoints. So I'd like to walk you through how we look and think about these metrics of success. This is a survival curve. This is often what's published when a clinical trial is completed. This is an example of a progression-free survival curve, and I'm going to walk you through the components. So that x-axis along the bottom is months. The y-axis is the progression-free survival probability, and the dashed line is the median progression-free survival. So we look at something called a hazard ratio. It's a hazard of progression. So a p-value is also reported that indicates the level of statistical significance, and a low hazard ratio and a low p-value are good for both. And we really want to see separation of those curves. So that yellow curve is the CAP-TEM arm, and the blue curve is the temozolomide arm. This is an example from the ECOG 2211 trial. And that yellow curve being on top indicates that it did better compared to those two arms. It had a longer median progression-free survival of almost 2 years. We also look at shrinkage rates, and we measure that through criteria called RECIST, the Response Evaluation Criteria in Solid Tumors. Key features of RECIST, I get actually asked about this by patients. They ask on trials, can you measure every lesion? The answer is no. We pick 5 representative lesions, up to 2 per organ, and we then take those measurements and we do the sum of the longest diameters. I'm going to walk you through that with an example. So this is a picture of a liver, or pretend that it's a picture of a liver. And in yellow are an example of 2 liver metastases. One of them is 6.5 centimeters and the other is 2.5 centimeters. So the sum of their longest diameters is 9. Imagine then a patient has had 3 months of treatment. We then do those measurements again. Fortunately, this patient is having tumor shrinkage. Lesion 1 is now 2 centimeters. Lesion 2 is 5.5 centimeters. That sum has decreased, and there's a 17% shrinkage from baseline. They go on to get an additional 3 months of treatment. We've had further shrinkage. They've had 44% response rate. And then I'll remind you how we look at this. So we then, a complete response, partial response, stable disease, and progressive disease are the categories that we look at. And so for this ECOG 2211 trial, we saw that the total response rate, which is complete response plus partial response, was 34% in the temozolomide arm and 40% in the combination arm. And that combination arm did better, both in terms of progression-free survival and a little bit better in terms of that response rate. Another really important way that we measure the success of a trial are the side effects. And I would argue that this is one of the most important things to patients. So we actually grade side effects on a scale of severity, and we call side effects adverse events. The severity scale is on 1 through 5. And it's very specific depending on what that side effect is, whether or not it's related to the treatment or not. And then I will mention that patient-reported outcomes are becoming increasingly used in trials. These are often done through apps or online tools for patients to report their own outcomes. This below here is just an example of a chart of how we grade anemia through this criteria called the NCI Common Terminology Criteria for Adverse Events. So as we think about exciting trials on the horizon, I know that you've already had a presentation by Dr. Chan, so I'm not going to go into the details, but I wanted to have this for future use and future reference for you. But we have a number of trials in NET and paraganglioma FEO, pancreatic NET, CAP-TEM versus observation after surgery for certain patients who are at higher risk. The Sorrento trial, looking at octreotide every 2 weeks versus investigator choice, and another NCTN trial looking at temozolomide versus TEM plus olaparib in paraganglioma FEO. We have a trial in neuroendocrine carcinomas. These are the higher grade studies looking at immunotherapy. And then we also have a number of PRRT trials, and I know that you've had presentations by doctors Carreras and Chauhan. And I think this is an area where we are seeing many trials, both in terms of using lutetium dotatate, using alpha therapy like actinium-225. So that's the Action 1 trial. We're looking at PRRT retreatment. So really an exciting space that we're seeing new treatments. And then I'll end with a trial that we are looking at symptom management. So this is an oral somatostatin analog, so like an oral octreotide called paltusotine. And this is for patients with flushing predominant carcinoid syndrome. And we hope that this will open in the summer of 25. So how can you learn about trials? I think number one, your oncologist or NET specialist should really be your primary guide. This is a complicated space, and you should ask them first. Secondly, your regional cancer centers have websites that list often the trials offered at that site. I've listed a few institutions here who have been good partners with NCF over the course of the last year for patient events, but you can look up your favorite institution, and I'm sure that they have a website for clinical trials. Clinicaltrials.gov is a website sponsored by the federal government. It is, I will say, is often complicated to navigate. They have tried to make it a little bit more patient-friendly, so I encourage you to play around with it. There are buttons that you can click on, search terms, etc. That's another option. And then there are a number of patient support groups and professional societies that also have websites, including NCF, NANETS, and NetRF. So I think in terms of take-home points, I hope that you've learned over the course of the day, not just from my talk, but there have been incredible advances in the last 10 years in terms of treatment and imaging, really in large part due to clinical trials. They are critical to this progress and are reason for great hope in this space. I think what we're seeing are that there are a number of novel radioligand therapies, that's the PRRT, immunotherapies, and personalized therapies that are being incorporated into current and future clinical trials. And I think to bring it back to our theme, what matters most to make your next best decision? I think I would encourage everyone at times that a new treatment is needed, I would encourage you to ask your physician, what about a clinical trial? What clinical trials are available and what standard of care options are available? And I'd like to give a shout out to all clinical trial participants. Thank you so much. It's really been a pleasure to talk today.
Hi, my name is Randy Hecht, and I am a medical oncologist at UCLA. And I'm really fortunate to be asked by the Neuroendocrine Cancer Foundation to help run this session. And the title of the session is What Matters Most in Making Decisions About Systemic Therapies in Sequencing Treatments. I'm very lucky to have three other panelists who represent not just medical oncology, but other specialties as well from around the country. So they're going to go ahead and introduce themselves. Dr. Ganji.
Hi, my name is Alex Ganji. I'm a surgical oncologist, and I'm at Cedars-Sinai in Los Angeles.
Dr. Mitra.
Hi, everyone. I'm Dr. Eric Mitra. I'm a nuclear medicine physician at Oregon Health and Science University in Portland.
Dr. Zen.
Hi, I'm David Zen. I'm a GI medical oncologist here at the Fred Hutch and specialize in neuroendocrine tumors, and I'm the co-director of the neuroendocrine program here.
One of the good things about the treatment of neuroendocrine tumors, particularly in the modern era, is that we have an awful lot of different options. What we don't have necessarily are many trials comparing one option to the other. And so part of what we're going to talk about today is how we put all this together. So there is no one size fits all for patients with neuroendocrine tumors. And in fact, there are many, many different types of, of situations where patients with neuroendocrine tumors interact with their physicians. And so what I decided to do today was present some cases. And not only are we going to discuss these cases and see different physicians' viewpoints, but also we may alter the cases so that we can see how those alterations may change what you want to do. So if it's okay with the team, I'm going to go ahead and present a hypothetical, but definitely drawn from real life case. A patient comes to see me She's a 53-year-old female. She has had chronic intermittent abdominal pain for a number of years with really without any ability for it to be diagnosed. She eventually has cross-sectional imaging and is found to have a mesenteric mass and multiple liver metastases. She has a normal liver function test. Biopsy of the liver shows a well-differentiated neuroendocrine tumor with a Ki-67 of 1%. She then undergoes further testing with a dotatate scan, which shows only the mesenteric mass as well as multiple liver metastases. And so the first question is, at that point, what would you do if the patient comes? I'm going to ask Dr. Zen to start out with, because the patient may come to see you first, or Dr. Ganji. But let's start with Dr. Zen. What would you do at this point for this patient?
Yeah, obviously, with this patient, it seems that there, is evidence of stage 4 cancer with, metastases to the liver. With that said, I think, one of the things I would appreciate from Dr. Ganji's standpoint, it sounds like this patient is pretty symptomatic from the primary mass and be worried about potential risk of bowel obstruction. So even though we could discuss starting some systemic therapies, I probably would want a referral from the surgery to see if resecting the mass would be of help to prevent a future bowel obstruction, but then also even with the liver metastases, if there's any role to even optimally debulk the liver metastases there.
This is also where a multidisciplinary, conference or tumor board is really particularly useful, because it's critical to have our surgical colleagues as well as our radiologic pathology colleagues all to sort of, bring this in. So even though often the patient may start with one physician, though some institutions have, multidisciplinary clinics where everyone's all in one place, is that if they start with one physician, there are many physicians who are involved. Dr. Ganji?
Yeah, so I think as Dr. Zen mentioned, it sounds like this patient has a symptomatic small bowel primary. I think one other thing that would be important for us in her surgical evaluation would be to evaluate the number and location of her liver metastases, because certainly I think from the perspective of the small bowel lesion in the mesenteric mass, resection would be indicated secondary to symptoms. The possibility of doing that would be dependent on where the bulk of the disease is with respect to the nodes along the mesentery, and how it's involving essentially the SMA, which is the main arterial pedicle that supplies a majority of the blood flow to the small intestine. So we kind of gauge our ability to resect that based on where a bulk of that mass is in the mesentery. And then simultaneously, we would look for the primary tumor, which it sounds like wasn't evident necessarily on the dotatate scan. And sometimes we talk to patients about the fact that those could be very, very small, even the size of a sesame seed. So it requires some manual palpation to identify that lesion. And in 30-40% of patients, there can certainly be more than one lesion. So the goal would be to remove that mesenteric mass along with the associated small intestine. Certainly in scenarios when we're already in there, if the liver is debulkable, meaning if we can take out at least 70% of the disease in the liver, there is some evidence that that improves outcomes for patients in terms of hormone overproduction, and could slow down the propagation of additional metastases developing over time. But that would be, again, entirely dependent on how many and where. So does that, I think, answer the question, I hope?
I think so. And I think it is really important. And of course, you probably would also take out the gallbladder as well in sort of anticipation of systemic therapy. Dr. Mitra, do you have any thoughts about, we sort of put dotatate scans together. Any other imaging thoughts about one type of dotatate scan versus another?
Yeah, thanks for that. So I was, as a nuclear medicine physician, glad that you mentioned dotatate PET right up front, because, that is definitely the most sensitive way to kind of evaluate these tumors, and also gives some information right away in terms of potential therapies related to the somatostatin receptors as well, which could be something that we talk about in the future, although I completely agree, so far with what the others have said about the evaluation and in particular the surgical approach. At first, I would add from the imaging side that while dotatate PET is so critical these days, it is also very important to get conventional anatomical imaging, good quality as well. And probably Dr. Ganji would agree with that from the surgical approach too. So to get multi-phase CT of the abdomen and pelvis to kind of fully evaluate that would be necessary. As far as the different types of dotatate PET, my comment there would actually be that they're all quite good as long as your PET scanners are optimized for whichever isotope that you're using and you have a good availability of it. They're all very good agents.
Amazingly, I saw someone for the first time in a long time this past week who actually had an Octria scan, the old fashioned, and I guess those are still out there in the wild.
Wow.
The other thing, I think that's a really good point because only certain places actually do combined PET CT, and I think it's really important if you're trying to do local therapies versus systemic therapies. But frequently, I know Cedars does combined, UCLA does combined. I assume your institutions also do combined, but often we see people without IV contrast. So I think that's something that's actually very good to discuss. This hypothetical patient did not have any significant hormonal symptoms. So we'll talk about that, later when we talk about systemic therapies. And so let's say that the patient is able to have liver resection of, say, all of the disease, as well as we have a dedicated surgeon who's able to get down to the root of the mesentery and remove all the primary. The question comes up then if someone has a complete resection, including of liver metastases, is there any role for systemic therapy at that time? Dr. Zen?
Yeah, so I think that's a fantastic question. And, there's a lot of variability in practice there. I think one of the things we always want to remember is kind of what is the goal of giving the systemic therapy, right? So in this patient who had a complete resection, I think our goal is there any therapies that could try to eliminate any microscopic disease with the goal of trying to increase the chance of keeping it away? And I think at this point in time, I don't think we have any clear systemic therapies or clear data to suggest that that's the case. However, I would allude to there is a national ongoing clinical trial being led by the NCI, SWOG 2104, which is focusing mainly in pancreatic neuroendocrine tumors, with the premise that pancreatic neuroendocrine tumors often are a little bit more sensitive to chemotherapy. And so this trial is randomizing to patients who have higher risk pancreatic neuroendocrine tumors, so higher risk of recurrence, and randomizing them to either surveillance, which is our current standard of care, versus 4 months of capecitabine and temozolomide, or also known as CAPE-10. So
I'm really glad that you brought that up, though. You've actually stolen a little bit of my thunder for my next case, which is a pancreas case. But I think that you did bring up something that is important with systemic therapy, is that not all neuroendocrine tumors are not the same, and there clearly are differences in responses to various systemic therapies between small bowel versus pancreatic neuroendocrine tumors. And I think particularly for low-grade tumors, I think that what you just said, that the response to chemotherapy really is a difference. I think as you get higher, I think small bowel is more likely to respond to sort of the standard chemotherapies, though most people don't really necessarily end up with those. So afterwards, I agree that, the systemic therapy that might be reasonable after our surgical colleagues have done a complete resection could include observation and, in following the patient. Though I can't say that it's wrong to treat, but I can't say necessarily that it's right. Now, hypothetically, let's say our surgical oncologist was able to debulk but still left disease, or that on the dotatate, to change the scenario slightly, our dotatate scan, instead of just showing liver only, also showed lymph nodes as well as bone metastases. And I have to say, one of the real changes with switching to dotatate scans were the very large number of asymptomatic bony metastases that we see in patients with neuroendocrine tumor, though most of them, don't cause problems. So let's say that, Dr. Zen, that the patient went to surgery, whether they had debulking or not. However, on the dotatate scan preoperatively had significant unresectable extrahepatic disease. With a Ki-67 of 1%, what would you do next?
Yeah, it's a great question. And these, I think, require both a multidisciplinary discussion, but also a discussion very closely with the patient about what their goals are. Because I think, Dr. Heck, you alluded to the fact that, one, obviously, we could start a systemic therapy, and I think many of us might consider a somatostatin analog. The goal there being, obviously, if a patient has functional symptoms, we want to try to suppress the hormone production and quality of life. I think that's pretty clear if that was that scenario. But then the other, in a patient functional or not, whether we want to try to delay the disease progression, right? Trying to keep the tumor controlled for as long as possible. But also, I will say that if a patient has a low-grade neuroendocrine tumor, like in this case, sometimes these tumors just might stay stable on their own. And if we've removed most of the disease, that might not cause a problem for a while. So I think the other option would be to offer the potential for surveillance too.
And actually, I agree with that. The biggest problem was fixed by the surgeon, which was the sort of intermittent obstruction from the from the primary and the mesenteric scarring and around that. So let's say that the same patient who has extrahepatic disease, you watch them, and after a period of time, 6 months, a year, unfortunately, on either cross-sectional imaging, which means CT, or MRI, that's the term of art that we use, or on a dotatate scan. And I don't know how it is in north of California and Washington, but it's not so easy to get actually a dotatate scan because of insurance, particularly if you didn't start with disease that can only be seen on a dotatate scan. But let's say after a while, this patient has some progression. So you would start presumably with a somatostatin analog. Do you think there's any difference between them from an anti-cancer standpoint?
Yeah, I agree that most of us would likely consider starting somatostatin analogs given the tolerability profile. And, we have two main injections, either octreotide LAR, also known as sandostatin, or lanreotide. And, at least from my perspective, and at least from the data, I don't think there's any major difference except in terms of the administration of the two. So obviously with the octreotide LAR, longer needle, lanreotide, a little bit shorter needle, comes in a prepackaged syringe and stuff. So oftentimes my patients do prefer lanreotide, but many times insurance here at least will reject lanreotide and will often do octreotide. But from that standpoint, I think they're both equally.
We've actually moved mostly to lanreotide, at least for now, though that may change because of lower copays for patients. And they're just to mention, because patients are very interested in this, is that, well, as I always say, that the treatment is literally a pain in the butt. It's generally really well tolerated. And while people can have pancreatic enzyme insufficiency, diarrhea, some fatigue, in general, it's really well tolerated. And patients often ask about this. On the horizon, there is potential for versions of somatostatin analogs that block that signal, or actually the signal to grow, that are analogs of this turn-off signal, that's a better way of saying it, that maybe be able to inject it themselves at home. And oral agents are approved in other indications, though I don't know whether they will be available anytime soon for patients like the one that we just discussed. Okay, so the patient is, doing well, does not have any significant side effects from the treatment, is going about doing what they usually do. However, and it can be years, if you look at the randomized trials that looked at both octreotide as well as lanreotide, that it can be years before the tumor gets worse, but eventually the tumor gets worse. If the majority of the progression is in the liver, I know there have been other discussions about liver-directed therapies. And however, let's assume in this case that there's sort of progression everywhere. So the person has had first-line somatostatin analog, now has progression, does not have significant hormonal problems. What would you consider next? I know that you're usually the person who's involved often at this point. What do you think about second-line therapy?
Yeah, I think, the nice thing about neuroendocrine tumors is that we have a menu of different options. But the difficult part, and when we're counseling patients, is when we have a menu of options based on the current data, it's hard to say if one is truly superior than the other, right? So I think there's ongoing studies to hopefully answer sequencing kind of questions. But from my standpoint, I think the therapies that I often consider, at least for this low grade kind of small bowel and primary, I would often consider PRRT with lutetium-177 dotatate or Lutathera. We do have systemic therapies, like everolimus and now even cabozantinib. But I think the difference here, why I often might consider Lutathera, is number one, it's an IV dose, 4 doses. There's logistical things, but it's a 4 dose and you're done versus coming
fire and forget to a certain
Yep.
extent.
It's a continuous treatment and the ongoing side effects related to that. So,
Dr. Mitra, what would you say about that?
No, totally agree. I mean, that's exactly the scenario that PRRT or Lutathera was approved for, is patients with lower and intermediate grade tumors that have progressed with SSAs. Just a couple of comments on the imaging side is that I think at that point, especially as you're saying, oftentimes it can be years that, from the baseline imaging. And so it's important to repeat a dotatate PET scan to reconfirm somatostatin expression, and also to ensure, kind of restage the disease as well, and to see what areas are currently involved. For instance, you mentioned the liver dominant disease that patients sometimes have, which is well captured on CT or MRI, but those can often miss some of the extrahepatic disease, especially in the bones that you refer to. So it's important to repeat a dotatate PET. And the other quick comment about imaging with relation to follow-up and progression is, again, that's super important to get high quality multi-phase CT or MRI scans. It's so often the case that we'll see patients in that scenario that they've been treated, with the initial agents for X number of time, but they don't have good baseline imaging. And so it's really hard to then actually compare, what's been going on. And so that, I can't really stress that enough. It's so important to have good conventional imaging and periodic PET scans, ideally.
Virtually all those patients will actually have somatostatin receptor that you can see. And so my question is that how often do you see loss? I mean, we think about resistance, and yet, my understanding is that the vast majority of patients who are on a somatostatin analog, when they progress, still remain positive on the dotatate scan. In someone in the second line setting where we've seen loss. But so I would just say that I think it's worth doing. And if you want a good baseline to compare with, but I think it's not very common to, am I correct in that?
No, that's a good point. It's relative to the Ki-67. So the lower it is, the more likely it will retain the somatostatin expression, and the higher it is, the converse to that. But also, we know that certain patients do have some heterogeneity, and not everyone's the same. So that's why I sort of do advocate at least periodically to get a PET scan, and at least our practice is that just prior to initiating PRRT, we do like to get a new baseline at that time.
And this is something that's actually come up, and maybe it's not necessarily for this. When do you check again? Since we're talking about sequencing, the vast majority of people have at least stable disease. Major responses are not that common, in the teens, but most people don't need a major response. They just need their tumor not to grow. And I think occasionally people need tumors to shrink, but neuroendocrine tumor patients mostly need it not to grow, because they're otherwise doing, really well. When do you check a set of scans after someone who's had standard PRRT, which just for the patients who are on, which is the radioactive somatostatin analog, which has been discussed earlier today?
Yeah, great question, because again, there's a lot of controversy around that, and related to that is insurance issues that you also alluded to previously. But our practice, and I think what a lot of places would do, is at least to repeat the conventional imaging again after the completion of PRRT at some point, approximately 3 or 4 months later. We also do try to get a PET scan as well, but it is very true that context of that is a little bit hard to evaluate, and there aren't good response criteria for a follow-up PET scan to know really what to do with that information. So we do advocate mostly for conventional imaging, but if possible, to also get a dotatate PET.
So I think Dr. Zen actually brought up some really interesting points about how we sequence. So the questions are, one, what does the patient want, and how much do they want to be there? We're all at major academic centers, but patients don't always live within walking distance of major academic medical centers and often come from far away to get expert care. So that also means that something where if someone has to come frequently for either follow-up for an oral medication, or let's say we talked earlier about chemotherapy, being able to do something that's only for and then done is attractive. The other thing I think that's really important is, what are the endpoints that we care about? And the endpoints we care about are overall survival, how long the patient has to live, which can be many years, and as well as quality of life. Now, the sequencing trials that have been done, the problem is, and this is a good problem, it's often really difficult to look at overall survival because patients do so well, and people retire sometimes before they come off the trial. And so, Dr. Zen, you had mentioned about trials comparing one versus the other. But for example, the recent, COMPETE trial, which looked at a progression-free survival endpoint, it seemed to look like PRRT was better than everolimus, which is an mTOR inhibitor, which is approved. However, the question that comes up is that, first of all, if you could, for our audience, explain what progression-free survival is. And the next thing is, and my question to you is, how important an endpoint is that?
Yeah. That's a
Mm-hmm.
great question. So
Mm-hmm.
progression-free survival essentially is our, oncology terminology we use in studies to demonstrate how long does a therapy is able to keep a cancer or tumor under control, right? And I think the definition of how we define tumor control is usually based on imaging. And there's also very specific criteria in terms of what we determine as growth, what we determine as stability, and what we determine as shrinkage, right? Which sometimes those bars are very different than neuroendocrine tumors compared to what we may see with other cancers, right? And what I mean by that is, I think if we're hoping for shrinkage, a lot of times many of our treatments don't provide a lot of shrinkage. But just like what you said, Dr. Hecht, is that shrinkage doesn't always is very meaningful, right, in this disease, right, as well too, right? And so I think progression-free survival, I think, is meaningful to an extent in terms of that if we can keep a disease under control for a long period of time, that's great. But also, I think we still have to take into account some of the other treatment side effects, the logistics and stuff. So even if something may look a little bit better, we're still measuring time, as you mentioned, sometimes on order of years, right? So even if something may be a little bit better or maybe a little bit worse, we're also talking about something that when we talk about sequencing, we're not necessarily meaning that if we do 1X first, it might mean that the patient lives a shorter period of time, right? The time might still be overall the same, but
right. So the eventual destination, basically is the same, whether it's one versus the other.
Yeah.
And one of the things I always think about is, and I think you had brought this up, is the ongoing toxicity. Particularly as medical oncologists, we give medicines that have ongoing toxicity. Yeah. Unlike our surgical colleagues who are in and then they do something for our patient, our nuclear medicine colleagues who treat a certain number of times, but our medicines do have, even somatostatin analogs can have some toxicity. So let us say that the patient has PRRT and does well, this hypothetical patient, and often, as you pointed out, can be for years. Our hypothetical patient does not have any hormonal symptoms. Hormonal symptoms actually make it easier to continue the somatostatin analog. Another question about sequencing is, how do you feel about continuing the somatostatin analog after PRRT?
Yeah, that's a great question. A very common question on referrals as well too. And I think, I think that's also an area where we have little data about what best to do. And I think there's a lot of personal preference in terms of what we do. From my perspective, I think if we were to follow the data for a patient who doesn't have any hormonal symptoms, I think it's very questionable about whether we want to continue the injections. At the same token, too, I also have patients who come to me and they say, well, what if there's some cells that are still being controlled by the therapy and I'm tolerating the therapy well and I don't mind continuing to get injections every month? There I also, won't necessarily disagree if they want to continue, but yes, yeah.
I mean, there are toxicities, not to mention potential financial toxicity, because we know how eye-wateringly expensive these agents can be, though the patient themselves may not necessarily be paying for it, which is appropriate and good. So let's say that our hypothetical patient has PRRT, then does well for 2.5 years, and then continues to be asymptomatic, as many of our patients are. Though there are certainly other things that can happen after surgery. It just reminds me that sometimes patients can have diarrhea for non-hormonal reasons after surgery, particularly after removing the end of the small intestine as part of that. But the patient's doing well and now has had good, stable disease, as most patients do, and has now progressed. Dr. Zen, can you say what the systemic options would be at this point for this patient who started out with low-grade neuroendocrine tumor? And then I'm going to ask Dr. Mitchell what he thinks.
Yeah, so I think number one, obviously, is just with any cancer, if there's any clinical trials that are ongoing, we always try to find those options.
Thank you.
Right. But in terms of standard therapies that we would have here, right, and this is where I think we alluded to this earlier, the site kind of does matter, right? So for example, small intestinal neuroendocrine tumors generally have less response to chemotherapy. Not to say that we don't use it, but generally have a less response, especially for lower grade. So I think in this scenario, I think the systemic therapies that would be reasonable would be either everolimus, that would be one option, but also we have cabozantinib, which is a now new oral targeted agent that we have that was based on the positive results of the CABINET study. So it's nice that we also have a new FDA approved option too.
Though both of those agents, how do you choose between the two of them? Both of them have different sort of toxicity profiles.
That's
And,
correct.
and the patient who comes in to see you may be different. How would you choose between one versus the other?
Yeah, I think this is where the toxicity profiles are very important, explaining to that patient and helping to make a choice. Number one is always activity. Do we have any data that suggests that it might provide more robust shrinkage if I need to achieve that in a particular patient? I think overall, based on the results, it's not that much different. We're talking about response rates about 5% or so. So here the toxicities I think are more important. And here it's kind of what is the patient willing to tolerate, right? So, with the everolimus and such like that, the risk for potential mucositis, the potential for diarrhea, the potential risk for lipid issues, glucose issues and stuff like that. But then cabozantinib has its own side effects with the diarrhea, right, and blood pressure issues, right? So I explain that to patients and see what they tolerate, but also taking into account what symptoms are they actually having, right? Am I also willing to take that risk of seeing some of those symptoms worsen as well too? So
I think it's also important for patients to realize is that none of these are set in stone.
Correct.
So this is the art of what we do, is that if you start with something, you can always switch to something else. And then, as I always tell my patients, the doses we start with are guesstimates. It's what a large group of patients were able to tolerate, but that doesn't mean that that's necessarily the dose that you have to have, and we adjust. So I think it's really important for patients to realize if they do have side effects, doesn't mean those drugs might not help them. Thank you again for bringing up trials. I have to say that we really are in a new era of trials for neuroendocrine tumors. And so for so long, it was really considered a disease or a condition where it was impossible to do studies. And because there just weren't enough patients out there and there wasn't enough interest. And we know because of advocacy groups, so like the Neuroendocrine Cancer Foundation, as well as the realization at the national level from our cooperative groups, as well as the pharmaceutical industry, that these patients deserve and need additional options, over and above what we've just been talking about. But I do think it's important to put people on study as a physician. And I think as a patient, it's important to consider clinical trials. So back to Dr. Mitchell. So what do you think about additional PRRT in our hypothetical patient? So the patient is still asymptomatic. They have good preserved liver function, has had a good, I would say, stable response for a long period of time, that progression-free survival that Dr. Zen was talking about, doing well. How do you feel about salvage PRRT?
Yeah, it's definitely something to consider in this scenario. The way we sort of think about it is if the patient has had a really good response to the initial round of PRRT, and by that we sort of define, it's a little bit vague, but most people define it as at least 12 months, if not 16 months of a stable disease. If that's the case, and again, a repeat dotatate scan still shows good somatostatin receptor expression, and as you mentioned, labs are all in order, then that's exactly the scenario where we would consider repeat PRRT. There's a couple of caveats to that. However, one is that it's not entirely known how many additional cycles are appropriate. Many studies were done with 2 cycles, but there are other studies that do, complete repeat of 4 cycles. We actually at our institution are using patient-specific dosimetry to try to help determine that to some extent. Another thing is that there is a lack of good prospective clinical data on this at this point. However, there's a lot of retrospective data that does support doing this. So, and then the third is there could be some insurance issues related to that, which I think is, as we know, with a lot of things is very regional. In our area in the US, we haven't really had any issues with it, but it could be something that comes up in some other areas.
And also, I know there have also been previous talks at this meeting about sort of the next generation of PRRT. So I'm not going to go with that. Instead, I'm going to focus on what we can do now. Are there patients that you would not consider, that the medical term is contraindications, or patients that you're more concerned about not doing salvage PRRT?
Yeah, a few different things come to mind. One is the initial stable period of disease, as I mentioned. If that's less than 12 months, then we wouldn't consider it. If there's been a change in the somatostatin receptor expression, we wouldn't consider it. Also, if there's been a change in potentially how quickly the tumors are progressing over time, then perhaps some of the other therapies that Dr. Zen mentioned might be more appropriate in that scenario as well. So those are kind of the main ones that come to mind.
One thing that has been brought up is that, some patients with neuroendocrine tumors, we had talked about the scars, but can also have peritoneal disease. And so that means that disease, neuroendocrine tumor that's growing along the bowels, even though it may not be necessarily easy to see. Sometimes those patients have obstructions and need to see our surgical oncologist. But I know that it's also been brought up that there may be some interaction between PRRT and small bowel obstructions, meaning blockage from that. Do you have any thoughts? Would that change how you would treat a patient?
Yeah, that's another area which is a little bit controversial. There's anecdotal data that PRRT can exacerbate that. It's thought that the inflammation from the radiation may cause some of that small bowel obstruction. However, there isn't really necessarily strong data to support that as well. So what a lot of places have started doing is prophylactically to use some sort of steroids. There's a variety of different regimens that can be used in conjunction with the PRRT to sort of ward that off from happening. So that's one thing that people do think about. I personally don't think it's a contraindication myself, but it's something to keep in mind for patients.
Okay, so let's say then that our patient went ahead and had salvage PRRT because they didn't want to come and see the medical oncologist as often. Even patients who benefit, it may not be quite as long. And hopefully by that time, since we started, remember that these things add up, and we're now talking years and years. My hope is that we have newer agents, but let's say that the agents that we have, so patient then you could start on everolimus or cabozantinib. To be honest, as I said, other than the patient characteristics, I don't feel really strongly, one way or the other. Let's say that it's continued to grow. Would you consider rebiopsying at that time, Dr. Zen? Now we're several years out. We're probably 4 or 5 years out. Patient has had salvage PRRT, cabozantinib, and/or everolimus. Is that a time that one would consider rebiopsying? Because it started out with a Ki-67 in this hypothetical patient of 1%.
Yeah. So I do think if there's a really significant change in the behavior, both based on imaging, if there's like a more rapid growth than what I normally would have anticipated for a low-grade neuroendocrine tumor, and also the symptomatology of the patient that's like just seems a lot sicker than what normally has been the course, then yeah, I think the concern that's being raised is whether there might be some grade transformation, meaning the cancer, the neuroendocrine tumor is evolved into a higher grade neuroendocrine tumor or even a neuroendocrine carcinoma that might affect our treatment decisions as well. So yes, I definitely would consider a biopsy.
So Dr. Ganji, what if, one of the things we always talk about to a certain extent in oncology are resistant clones, where most of the time things go in one direction, but sometimes one lesion is growing differently than another. Do you want to comment on potential surgical resection in that setting?
Yeah, I think surgery always kind of remains part of the toolkit that we have in management of these patients. And I didn't mention earlier, in a patient who presents with liver metastases, and it sounds like there were numerous, it's very common, greater than 80% likelihood that they're going to have some kind of in-liver recurrence, if not in other locations within a 5-year window based on all of the data that we have. So I don't think repeat surgery is ever necessarily off the table. It's just that we have to reevaluate the other options that we might have. And so in the scenario that you presented, it was a patient who was progressing throughout, right? Systemic progression. And so they were PRRT, right? Slowly. But then ultimately, if we're at a steady state with all of the other disease and there's one area that's progressing more rapidly, then it's not uncommon for us, if we're able to go in and essentially cytoreduce the patient yet again and try to, with the target of that one particular area being the main focus. And certainly if there's anything additional that we can debulk, we would certainly consider doing it.
And then finally, we were really talking about initially someone with a small bowel neuroendocrine tumor or small intestine for the patients. What if this instead had been a pancreatic neuroendocrine tumor? I had sort of a separate scenario, but let's just assume that it's similar and starting out as low grade. Dr. Zen, can you comment then on, standard, what we call cytotoxic chemotherapy? And this, you mentioned it earlier, but if you could just, sort of elucidate a little bit more if this had hypothetically been a pancreatic neuroendocrine tumor.
Yeah, I think if this had been a pancreatic neuroendocrine tumor, whether low grade or high grade, we know based on studies that the site matters here. So pancreatic neuroendocrine tumors generally have more sensitivity to oral chemotherapy agents, here specifically referring to a combination of an oral chemotherapy pill called capecitabine and another oral chemotherapy pill called temozolomide. We call it CAPTEM for short. And this has been around based on a very large study that was done several years ago that demonstrated that not only does it help with disease control, but it even has pretty significant chances of tumor shrinkage, right? And I think this opens up the pathways in some scenarios, for example, where if for some reason surgery was not an option or was going to be very difficult, and a patient was very symptomatic, having a lot of pain and such like that, we actually have a treatment option in this setting where CAPTEM could actually provide a significant shrinkage and might even have a significant quality of life benefit in addition to the tumor.
And that actually brings up the question of what our goals are. If someone has widespread metastatic disease, shrinking it, unless it's causing a local problem, may not be as important. Do you have any problems about patients who are on capecitabine and temozolomide, what we call alkylating agents, who have also received PRRT? Because one of the feared side effects, though rare, PRRT, are blood problems, either myelodysplastic syndrome or very rarely leukemia. Does that change at all how you feel about sequencing?
Yeah, so I think just like many other things, we kind of still have very limited data or understanding. I think we know there's an association that in patients who've been exposed to prior alkylating agents like temozolomide and then let's say get PRRT, I think there might be a higher risk of that myelodysplastic syndrome or MDS and leukemia. But I think one of the tough parts is that while we know that association, it's not a guaranteed association, right? And I think one of the tough parts when you're having patients in front of you, making sure that we're also not avoiding potentially effective therapies for a risk that could happen, but might not necessarily happen too.
And I think that once again is that, taking care of patients with neuroendocrine tumors is a team sport. And that I feel that at least at some point in the treatment of these patients, that they should be evaluated in some sort of multidisciplinary form. And I think probably when there is worsening of the disease, that's a very good time to go ahead and reassess that. So just to finish up, I'd like to thank actually the Neuroendocrine Cancer Foundation, because one of the many things that they do is also help with patient education. So by watching this and the other talks on this as part of this meeting, is that you become a better patient. And I think you should always feel free to echo what Dr. Ganji said. It's really important to ask your physician, why are they doing this? Why one thing versus another? Have a list of questions. And to be honest, if they can't answer your questions, then you should find someone who can answer your questions. So with that, I'd really like to thank you for your attention and for the panel for actually really this wonderful session.
Hi, my name is Judd, and I am a neuroendocrine cancer patient and advocate. I appreciate this opportunity to share a little bit about my NET journey with you and a few of the things that have helped me along the way. So I was diagnosed with stage 4, grade 3 small bowel NET with mets to my mesentery and liver in September of 2022. That was after about a year or so of gradually worsening carcinoid syndrome symptoms and a number of dead ends in terms of trying to diagnose what was going on with me. But one of the things that's kind of unusual about my story from there is that I went almost immediately into a clinical trial. I enrolled in the NETTER-2 study and was assigned to the Lutathera branch. So starting about a month after my diagnosis, I started receiving PRRT. That went through the spring of 2023. I then went about 18 months just receiving octreotide LAR shots to help control my carcinoid symptoms. And then last fall in 2024, I had surgery to remove my tumors via resection and ablation. Fortunately, that was a successful surgery. And so now I'm basically tumor-free for now. and just really excited to have better health and spend more of my energy on patient education and advocacy. I was asked to address what matters most to me in my decision-making process in my NET journey, and there's a couple of things. One is information. For me, having as much information as I could about NETs, about how they work and treatment options was very reassuring to me. It helped me control my anxiety, and it empowered me to be an active participant with my NET care team in making decisions, including the decision to enroll right away in that clinical trial. Another thing that has been crucial for me along the way is having really a strong level of trust in my care team. I'm fortunate to have a wonderful NET specialist as my primary oncologist, and then my surgeon is also a NET specialist. And so between the two of them and the three of us really have had a robust, respectful, active listening type of conversations. And I think without that, I would have had a harder time making some of the decisions that I did, including the decision to have surgery, because at that time, my tumors were still stable and I was feeling pretty good. And I struggled a little bit with why would I have this surgery now? I believe I did make the right decision at the right time, but it was through information and trust in my team that I got there. One of the things that's really helped me along the way over the last 2 or 3 years is peer support. I have a wonderful family, wife and 3 kids and pets, but it was really meeting people in the NAN community, as well as men with all sorts of cancer that has really helped me with my mental health and just weathering the ups and downs of the NET journey. I want to make a special plug for Man Up to Cancer, which is a nonprofit that is just men supporting other men through their cancer journeys. Men are very likely to have depression and shame and anxiety and to socially isolate with their cancer journeys. And Man Up to Cancer is all about changing that paradigm. One thing I would add as a lesson learned is to exercise or do whatever physical activity that you can. When I was undergoing PRRT, I didn't really realize this, but I'm sure I was depressed and the fatigue just sort of led me into a funk as it relates to physical exercise. And I think that if I had really had a program of staying active to the best of my abilities, that would have been better for my mental and physical health. So I've really tried to pay attention to that more recently and won't be making the same mistake down the road. And then finally, I'm just really inspired as a NET patient and advocate by the constant advances in medical technology, medical research, and what it means for neuroendocrine cancer treatment. Receiving PRRT as my first line of treatment made me kind of a nerd about nuclear medicine in particular, but I just really enjoy and get a lot of gratification from learning about these evolving treatment modalities and then sharing my knowledge with other NET and NEC patients. And finally, along those lines, I started a little Facebook group called Neuroendocrine Cancer Event Hub. That's really a master calendar of all the events that are being offered by NCF as well as other organizations for patient education. And I hope to grow that into a website in the future and to just keep sharing information to help all of us in the NET patient community be more confident and empowered in our care decisions. So I hope that was helpful, and I look forward to meeting some of you soon. Thank you.
Thank you to Drs. Chan, Carreras, Chauhan, and Kunz for the informative presentations. And we thank Drs. Hecht, Ganji, Mitra, and Zen for the thoughtful discussion on what matters most in making decisions about systemic therapies and sequencing treatments. We appreciate Judd sharing the patient perspective of what matters most to him in making decisions. We will now address your questions in this live question and answer session. Please note we will address broad-based questions only. The speakers cannot provide specific feedback on your individual situation, and also we will not necessarily address the questions in the order they were submitted, but instead an order that makes sense. To submit your general questions, go to the 2025 conference page on our website, ncf.net/2025 conference. This question and answer session is for educational purposes only and does not substitute for medical advice. Please talk to your medical team with questions or concerns about your individual care or treatment. Welcome back, everyone. We're very fortunate. Welcome back, everyone. We are very fortunate to have this incredible panel of NET experts join us for a live question and answer session. It's an honor to introduce today's participants. Dr. Cecilia Carreras, nuclear medicine physician from the Hospital Angeles Lomas in Mexico City. Dr. Jennifer Chan, medical oncologist from Dana-Farber Cancer Institute in Boston. Dr. Aman Chauhan, medical oncologist from the University of Miami Sylvester Cancer Center. Dr. Kalicia Clark, surgical oncologist from the Medical College of Wisconsin, Froder Hospital. Dr. Pamela Kuntz, medical oncologist from Yale Cancer Center and Smilo Cancer Hospital. Dr. Nadine Malak, radiologist and nuclear medicine physician from Oregon Health and Science University. Dr. Eric Mitra, radiologist and nuclear medicine physician from Oregon Health and Science University. Dr. Vineet Sukrathan, medical oncologist from Ohio State University Comprehensive Cancer Center, the James. And Josh Mailman, president of NorCal Carcinate and patient advocate extraordinary, who will be serving as co-moderator for today's question and answer session. We have approximately 85 minutes for our question and answer session that will be divided into two parts. I will moderate the first part of the question and answer session with Drs. Clark, Kuntz, Malak, and Sukrathan, and Josh Mailman will moderate the second part with Dr. Carreras, Chan, Chauhan, and Mitra. So I now invite the first group to stay on with me while Josh and the second group can now turn off their cameras. And we will go to the first question. So thank you again for being here. And the first question is a very reasonable and common one. How often should we get scans? And Dr. Kuntz, I'm going to start with you. I mean, PET, CT, MRIs, how often should we be getting scans?
Thanks, Lisa, and hi, everybody. That's a great question, and it really depends on a number of factors. So it depends on the stage of the cancer, whether your cancer has been removed or not, whether it's metastatic, and it also depends on the grade or differentiation. I know you've learned about all of these things over the course of the day. So for example, for a patient who had a well-differentiated low-grade pancreatic NET that was resected, we might consider doing cross-sectional imaging following surgery and then annually for 10 years from the time of surgery. We typically use cross-sectional imaging as our primary tool to monitor patients. I get asked a lot about how often and when do we use gallium-68 PET scans or other types of DOTA PET scans. And we typically will use those for patients perhaps at time of diagnosis and perhaps more frequently for patients who have metastatic disease, especially as we're trying to determine eligibility for lutetium dotatate or radioligand therapy. And I might just make one, it's a kind of complicated answer. I'll maybe make one more point and then happy to have my other colleagues comment. For patients with poorly differentiated neuroendocrine carcinomas that are metastatic, we often will image more frequently. So perhaps every 6 to 8 weeks, unlike patients with metastatic low-grade NETs where we may image every 3 to 6 months.
Thank you, Dr. Kuntz, and especially for weighing in from the oncologist perspective. And Dr. Clark, as a surgeon, how would you answer this question?
So I think Dr. Kuntz really summarized that well. I think as a surgeon, we tend to get many of these images before surgery. So I tend to get a good cross-sectional CT scan with arterial and venous phases for surgical planning. Additionally, especially if there's disease in the liver and we're going to cytoreduce or debulk, an MRI of the liver is more sensitive than the CT scan of the liver. It gives us a lot more architectural information, and so that can help us in the planning of liver resection. And then a dotatate scan preoperatively is very important if we have a well-differentiated tumor, to just ensure that I understand exactly what areas we need to be targeted, and so we can remove as much tumor as possible. The frequency of exams after that is really dependent on all of the factors that Dr. Coons mentioned, so I'm not going to repeat. But essentially, I think the summary is we usually use cross-sectional CT scans to follow patients at the desired interval. And the most common question I get is, well, why not survey me with a dotatate scan? And it's a very expensive scan. It has there are also false positives and false negatives. We tend to reserve dotatate scans for suspicion of recurrence, and really try to not use them as a common tool for surveillance after surgical resection when all of the visible tumor was removed. So we rely more on cross-sectional imaging for surveillance and dotatate to confirm or to help us elucidate any suspicious new findings.
Thank you. We're honored to have both the medical oncologist and surgical oncologist perspective. Dr. Malak, what else would you have to offer with that? And also, there's actually a specific question about, is it possible for net metastasis to not have diffusion restriction on contrast MRI?
Great. Hi, everyone. So the first question, Dr. Coons and Dr. Clark answered it beautifully. I have really nothing meaningful to add to that. I would just emphasize that, yes, dotatate PET is something that we get for specific indications and not for routine follow-up, except if the disease is disease that's occult on CT and we see it only on PET, then we get those more frequently. But otherwise, we rely on CT and MRI and occasional PETs when there's an indication to get them. And for the diffusion restriction, typically neuroendocrine tumors do show the diffusion restriction, but also that correlates with the grade of the disease. So basically, the higher, there are papers that show that the higher the grade of the disease, the more diffusion restriction there is. So typically, they do show up on diffusion restriction, but the degree of diffusion restriction is very variable based on the type of tumor.
Thank you, Dr. Malak. Dr. Sukathan, at what point does active surveillance need treatment?
Oh, that's a great question. Thanks for asking that. So I think it's very variable. All of us know that, thankfully, sometimes neuroendocrine tumors can be quite slow growing, and we're all thankful for that. But at some point, once we start to see suspicious looking lesions, on a scan, a good anatomic scan, which is either an MRI, or a triple phase CAT scan, as Dr. Clark had mentioned earlier, I think that should raise our suspicion for, maybe this is a recurrent metastatic tumor. But I always try to, counsel patients that just because we find a spot, I don't think it necessarily necessitates that we need to jump and intervene on that, because all of us know that, thankfully, sometimes you can go many, many years with just active surveillance. So I think this has to be tailored to every patient's unique perspective, because I don't think it's a one-size-fits-all approach. A lot of the times it depends on, where the tumor is, how much tumor bulk there is, what the pace of disease is, which is an extremely important thing, which we can really only know with some serial imaging, over 6 to 12 months. So I counsel patients not to, feel overwhelmed with anxiety about, a small spot that was found on the liver, because as we all know, we have lots of good treatment options and the options are getting better and better every day. So I ask, people to really, we have some time to figure out what is going on, what is the pace of the disease, and, we can take our time to intervene. But a lot of it depends on, the context, the symptoms, the pace of growth, and how much tumor there is and where exactly the tumor is.
Thank you for that answer. Dr. Coons, so when there is progression, is there benefit in staying on octreotide or lanreotide long-term, even if the disease is progressing?
Lisa's trying to
stump us with hard questions. So that I will say that we don't have clear evidence to use somatostatin analogs beyond progression. And with the exception for patients who have functional NETs, patients with a functional NET, meaning it secretes a hormone that leads to symptoms of hormone excess, those patients will be on lifelong somatostatin analogs. So I think that it's really thinking about, is a patient, do they have a functional NET or non-functional? Non-functional, I typically do not continue SSAs beyond progression. And for functional, I would continue that indefinitely.
Thank you. Dr. Clark, what are the current recommendations for confirmed pancreatic lesions less than 2 centimeters that have been stable or non-growing for multiple years?
So, there's more data that really supports observation of small, non-functional, asymptomatic pancreatic neuroendocrine tumors. And it's really important for us to make sure that we're meeting all of those criteria, right? So they have to be non-functional. Only in the pancreas. There's no role really for observation of small, like small bowel neuroendocrine tumors, for example. I do get that question a lot. And again, these must be asymptomatic. We've found out that there's some criteria that we can see on imaging that may tell us that these tumors are going to misbehave, even if they meet the other criteria. So the other thing that I look for is to make sure that the main pancreatic duct is normal. It's not dilated. It's not being impinged on by the tumor. Sometimes that can portend a more aggressive subtype of pancreatic neuroendocrine tumors that metastasize more frequently. Also, we want these to be PET dotatate avid. And again, that really underscores a well-differentiated tumor that is likely to be more indolent. And specifically, if possible, to get an FNA measurement of the Ki-67 and to document that it is a grade 1 tumor, which I tend to do for lesions that are above 1.2 centimeters in size, because we can usually biopsy those well. And if they're grade 1 tumors, then we can watch those. Tumors that are size criteria that I don't feel as comfortable watching, we just don't have as much data for grade 2 disease for sure. Makes me a little uncomfortable, even though there's some data that it's possibly okay. And if there's any abnormality to the main pancreatic duct, I'm always concerned that we're missing something else. But my preference is to observe these lesions as much as possible, as long as they haven't demonstrated any worrisome features, which are the ones that I mentioned before.
Thank you for that. And I'll ask a follow-up question, Dr. Clark, because there were a couple questions about the differences between an FNA, which you mentioned, if you could explain what that is, and a tissue biopsy, and how there can be differences sometimes.
Right. So essentially an FNA is a tissue biopsy. There's another kind of biopsy called a core needle biopsy, which is a larger needle. And basically all we're doing is looking at the size of the needle that's used to ascertain this tissue. An FNA is a much smaller needle. And so because of that, what we tend to have to examine with the pathologist are almost single cells. So the architecture is not quite as complete as like a bigger needle biopsy. But it allows us to be able to biopsy lesions, especially in the pancreas, through the GI tract, through the stomach, through the duodenum, without too much compromise. Essentially, to get a larger needle biopsy, it's not safe to go through organs as well with some of these larger needles. And so a core needle biopsy or a larger biopsy may require an external biopsy, more of a percutaneous route. But I think our techniques now for FNA are so good. At our institution, the FNAs are performed with a pathologist, so we have real-time assessment of the adequacy of the specimen sample. And so at our institution, these can be very accurate to help us identify the grade of disease.
Thank you for clarifying. Dr. Sukrathan, I'm going to shift this to you in terms of lung, because I know that you have a special interest in lung. How does a tissue sample maybe show normal lung tissue, but a needle biopsy confirm neuroendocrine tumor?
Yeah, unfortunately, as you know, it's can be tricky depending on where in the lung we're talking about and what the size of the nodule is. So anything less than 8 millimeters can sometimes, it's not easy to biopsy transbronchially. It can be missed even with EBUS. The location also matters. So peripheral nodules that are closer to the pleural, to the surface, are sometimes easier to biopsy from the outside by interventional radiology rather than by pulmonology. So in these, when we get cases that are not straightforward, a lot of the times we convene a tumor board, especially in the thoracic group, where we discuss individual cases to come up with a plan that makes sense for that person. Because, as you said, sometimes it can be missed with FNA. And if we are worried about, let's say, if you need more tissue and we're not sure that an FNA would be enough, especially if you're sending it out for next-gen sequencing and things of that nature, sometimes we want to get a biopsy rather than FNA. So we always make sure that we have multidisciplinary discussions around this, which includes intervention pulmonology, intervention radiology, us, and sometimes even thoracic surgery, because sometimes it's easier to actually take out the entire cancer along with the lobe around it. So these are very nuanced discussions that really require expertise from all the groups that I mentioned.
Yeah, the importance of a multidisciplinary discussion. Thank you, Dr. Sukathan. Dr. Kuntz, how common are NETs in the ovary or pelvic wall as metastasis from small bowel?
So I don't know that I have a specific percentage, but I will say that we can see for GI malignancies in general, we can pretty commonly see metastases to the ovaries and to the abdominal wall, which would be called peritoneal metastases. In my experience, we see these more commonly often with small intestine neuroendocrine tumors for the peritoneal mets, but ovarian mets can really happen with almost any GI malignancy, neuroendocrine tumors included, and including pancreatic nets. These can be tricky areas to treat, and often in terms of ovarian metastases can grow despite other areas in the body maybe being controlled. And peritoneal metastases, I like to describe these as little seeds of cancer that can line sort of the outside of the intestines and the abdominal wall, and they can really slow down the GI tract and can place patients at risk for obstruction. So they do require tailored strategies to think about how to care for patients with these.
Thank you for that, Dr. Kuntz. This question is about gastric nets. I'll start with Dr. Clark and then Dr. Malak. What scans are recommended after diagnosis with a foregut gastric grade 1 net? This person has an endoscopic ultrasound scheduled, but unsure of what else to ask for. Dr. Clark?
Okay, so this is a very complex question. So gastric nets in particular are very difficult to explain because there are multiple types. And so I'm going to try to do a very brief summary of the multiple types of gastric nets. This is a really tough question, Lisa. Okay, so let's start with the really 4 types of gastric nets. The most common type is a type 1 gastric neuroendocrine tumor. These are multiple, usually small tumors, typically seen in chronic gastritis or in people that have prolonged PPI use. And they're almost hyperplasias of the neuroendocrine cells within the stomach. And these tend to be more benign and indolent, and they're typically not managed with surgical resection. And they can just be observed with repeat endoscopies, medication modifications, et cetera. And those patients really tend to do very well. Type 2 gastric neuroendocrine tumors are more commonly associated with endocrinopathies that are hereditary. So like MEN1 is a very common association with these. These tend to be multifocal. They tend to be functional. And they don't respond well to surgery because of the multifocality. And we really try to manage and optimize other medical conditions in these patients, somatostatin analog therapy. And again, surgery is reserved for, certain cases, but again, may not be the mainstay of treatment for this disease. The surgery really plays a role in type 3 and type 4 gastric neuroendocrine tumors. These are more solitary tumors. They tend to be much larger tumors, and they metastasize at a much more aggressive rate. And so type 3 and type 4 patients certainly we want to get good biopsy, we want an endoscopy, we want a dotatate scan to look at the extent of disease. If there's evidence of metastasis, we typically delay any surgical intervention and start first with either systemic therapy with a somatostatin analog or something else, especially if these are higher grade tumors. And then really only use surgery in patients where we think that cytoreduction is going to be beneficial. So a loaded question. I think what this person may be referring to is a type 1 gastric neuroendocrine tumor. And those can be observed with endoscopy and occasional EUSs at regular intervals, 6 months to a year, depending on symptomatology, how confident they are in the type 1 diagnosis, and then the number of lesions or the size of the lesion that was initially seen.
Thank you for that fantastic overview. And Dr. Malak, is there anything else you would add to scan recommendations?
Yeah, so for scan recommendations, typically these lesions are very small, and those are difficult to see with CT and even with dotatate PET. So basically, to look at the tumor itself in the stomach, endoscopy is best, as Dr. Clark described. So those, this person might get a CT, might get a dotatate PET, and we might not be able to actually see the primary, which a lot of times could be very small, especially if it's a type 1. Now, if there is any concern that the disease might be more aggressive than that, or that it might have spread, then a CT and a dotatate PET potentially would be helpful for staging, especially if there's consideration of surgery.
Thank you so much. Dr. Sukrathan, are lung nets different from other nets? Why or why not?
Yeah, so I think in many ways, starting with from the genomic aspect, from a prognosis aspect, from a survival aspect, from a treatment aspect, there's lots of nuances for lung nets. So maybe just a very quick overview. So first of all, as many of you may be aware, the way we classify lung nets is a little bit different compared to GI nets. So the terms typical and atypical carcinoid that you may have come across. Generally, we have moved away from the term carcinoid in the gastroenteropancreatic space, but as of today, we still use the term carcinoid for the lung nets, and there are historical reasons for it. But there's also these terms typical and atypical, which really they're determined by what the pathologists are noticing under the microscope in terms of mitosis and necrosis, and that plays a huge role in the overall prognosis, how we treat this disease, how we think about this disease. So I think straight off the bat, the terminology is very different. I also want to point out that lung nets are also quite different genomically. So there's been quite a few studies now that have looked at, what are the tumors, what are the mutations that we find in these tumors, and a lot of the times there is some evidence that they're, dramatically different from gastric or enteric or pancreatic neuroendocrine tumors. There is an association with MEN1 in some patients, but many of times not. Sometimes we find, a lot more of what's called chromatin remodeling genes that are altered, especially in atypical lung nets. And, there is some evidence that some of these respond a little bit differently to immunotherapy than what we expect otherwise for the gastroenteropancreatic net. I also want to point out that the way we even follow these may be different because some of you may be aware, lung nets are notorious sometimes for not showing up on dotatate PET scans. And this is increasingly a concern because, we think around, the sensitivity for other nets is so high, but in the lung net space, it's closer to maybe 60% of tumors that are positive on a dotatate PET scan. And a lot of the times we end up needing to do, what's called an FDG PET scan if a dotatate PET scan is negative. And that also has implications for, how we think of it in terms of aggressiveness. So, that's a big difference. In terms of treatment as well, so we don't have as much, I would say, robust evidence that certain treatments work in lung nets. So some of it is because being a rare subset of neuroendocrine tumors, I think we are lagging a little bit behind, specifically in terms of designing trials. And so I would say we are, some of the evidence that we have is more retrospective in nature, and we're hoping that in the future we're able to correct that. Right now we have a study of Lutathera in lung nets that's currently enrolling in the US. So that should tell us more about how effective it is in the lung net space. And beyond that, even certain drugs like capecitabine and temozolomide have only been studied retrospectively and not in prospective fashion. So there's a lot of extrapolating that we do. So there's a little bit of, I would say, increased, we're not entirely confident about how well these treatments work, but there's a lot of evidence from personal experience, from expertise from centers. So the guidelines are very clear that some of these drugs do work very well and we use them very effectively. But I would say there's a lot more yet to be learned about lung nets, and we're hoping to get more data in the future.
Thank you. And that underscores, the differences underscore the importance for lung nets to be included in clinical trials, of course. Dr. Kuntz, feel free to comment on that last question, but this question is for you as well. Is it helpful to use systemic treatments other than somatostatin analogs, for example, PRRT, Captem, everolimus, cabozantinib, etc., when the disease is still small or limited to one area? I think oftentimes people worry about the spread or the growth, and can we just kind of hit it when it's small?
So that's another really good question. And I would say that my general approach and really consistent with guidelines is that we look for clear indications that are for physicians to say, what's the trigger for me to recommend a new treatment? And typically that's clear evidence of progression or growth. And this is for patients with metastatic disease. So if we start with a somatostatin analog with the goal of it suppressing growth and controlling the disease, I think as long as a patient is tolerating that and as long as it's controlling the growth of the cancer, I would recommend that a patient stay on that as long as both of those things are true. If at some future point we see clear evidence of progression, we then think about adding or kind of switching to a new treatment. At present time, we don't have evidence to suggest that combining lots of things up front really benefits patients. And in fact, it may cause more side effects. We really think about safety of combinations, and those would need to be studied in clinical trials.
Thank you. And Dr. Clark, I love your input on this question as well.
So I think as a surgeon, where we talk about using systemic therapies upfront before surgery for resectable tumors, we're usually trying to use it for a reason. So either we are trying to test biology, which means this is a tumor that's exhibited some very aggressive phenotypes, whether it's because it's a higher grade tumor or the extent of spread is quite high, and we want to have a higher sense of confidence that the surgery is going to yield good results with a relatively long progression-free survival time, so that the operation is worth the stretch, because it is a prolonged recovery, etc. Or we're looking to either shrink or downsize the tumor to make the surgical resection a bit easier or less a smaller scale, so that the complication risk is different and the chance for recovery is a little bit higher. So in that setting, we call it a neoadjuvant approach. And I particularly try to use this whenever I see one or more of those scenarios. So for higher grade tumors, or for tumors that have high volume or high burden of disease, even if we're planning surgery, it's always good to feel a little bit more confident that we have some control of the tumor, or we have good downsizing before we do a big operation, so that the patient has a maximal benefit. And then we know that we can get them back on that same medication, either to continue to control the micrometastatic disease that we can't see, or just to even assess response to therapy in the event the cancer comes back.
Yeah, thank you so much, Dr. Clark. Dr. Malak, on a CT scan report, as you know, patients often read their reports. Does innumerable hypodense lesions mean more than 20 natural characteristics of the liver, or innumerable net or neck tumors?
Well, typically, I would assume that they must be like NET tumors because we do not like use this description for normal liver. Um, yeah, so that's what I would assume from it. And sometimes neuroendocrine tumors do that, like they do spread in a way that there are a lot of lesions in the liver. And typically there is no cutoff on when this term is used, but mainly when there are like too many to count. And so this term could be used, and then the reader might choose the biggest ones as representative lesions. So they would describe the largest and would follow them over time.
I see many heads nodding, so thank you for that. Thank you, Dr. Malak. Dr. Sukrathan, thank you for your excellent presentation on symptom management. This question is related to that. Is it true that just about everyone taking somatostatin analogs like somatoline depot, lanreotide, or octreotide will eventually develop diabetes?
No, not at all. So it is a small but significant percentage. I think it's probably in the range of around 10 to 15% or so, if I remember correctly. So I don't want people to, fear diabetes and not get on a life-saving medication. I think it's just a question of keeping in mind that sometimes we have to control other comorbidities when we start some of these medications. So, we've had some situations when people have really uncontrolled diabetes when I think twice about, whether this is the right time to start an SSA in someone. Because, as we know, people can have very long lifespan and very good prognosis with neuroendocrine tumors. And I would hate for someone to develop full-blown diabetes or uncontrolled diabetes, leading to complications like kidney failure or heart attacks or stroke. So this is actually just an informed conversation that I'd like to have with people who have comorbidities that can predispose someone to developing diabetes. But it also means that we work closely with endocrinologists and primary care doctors so that they are aware and they are keeping an eye out for an A1C that is increasing, and if they're not sure, to reach out to us, because that may be one of the reasons why the A1C is all of a sudden going up. So I think it's just about raising awareness among patients as well as in the community to keep an eye on this potential complication, but absolutely not. I would not say that everyone develops it.
Thank you. And a follow-up question to that, what are the recommendations for treating diarrhea with taking somatostatin analogs?
Yeah, so I think, it's a little bit nuanced because it depends on a few things. The first thing is, where is the diarrhea coming from? So as we all know, there are many reasons why somebody with neuroendocrine tumors can have diarrhea. Some of which can be surgical, as we know. When you lose a significant amount of bowel with surgery, you can develop what's called post-surgical short gut syndrome. That can be one reason. The other obvious reason is when you have metastases to the liver, which leads to carcinoid syndrome causing diarrhea. But also, when you get the shots, we know that especially for the first few days, especially the first few cycles, you can have transient increased diarrhea. So that's another reason. And sometimes breakthrough diarrhea, which means that in some situations the shot just wears off by the third week. So you really have to be thoughtful about what exactly is causing the diarrhea. When in the cycle is it, and think about if it is surgical, can we supplement some of these? For example, the enzymes, cholestyramine, for example, is a good drug that we sometimes use. If it is related to shot related to the first 3 days, then sometimes we consider Creon if there's steatorrhea. If the diarrhea is due to wearing off of the shot, then sometimes we reduce the frequency or increase the dose. And we have lots of second order medications like Zermelo and things like that in that situation as well. So I think it's a question of just kind of thinking about what exactly is going on and being thoughtful about it.
Thank you so much for your thoughtful answer. Dr. Kuntz, are there preventative measures for colitis or gastritis to do before chemotherapy treatment? And there's actually 3 questions here. Is Folfox more gentle than Captem, and what's the average number of cycles?
So maybe like a little primer on chemotherapy, but maybe I'll answer the first question first. There's really we don't know who will necessarily get colitis from chemotherapy, and there's no clear preventive tool, but I will make a comment about both Captem and Fulfox because there has been some sort of things in the news recently. So Fulfox is an IV chemotherapy. The two primary chemotherapies involved are 5-FU and oxaliplatin. It's an acronym that stands for those two. They are given every 2 weeks. The oxaliplatin is given in the office. It takes about 2 hours to infuse, and the 5-FU is infused over 46 hours. Patients go home with a pump in a special bag that they carry in a fanny pack, and it infuses automatically for that 46 hours. Captem are all pills. They are taken 2 weeks on and 2 weeks off. The capecitabine is taken for all 14 of those days, morning and evening, and the Temodar is taken for days 10 through 14 and overlapped with the capecitabine. So capecitabine is actually a cousin to 5-FU. It's actually, they're really the same kind of active drug. It's capecitabine is considered a prodrug of 5-FU, but they're really very similar. Fewer than 1% of patients can have something called DPD deficiency. That is an enzyme that metabolizes 5-FU and capecitabine. This has actually been lately in the New York Times and a lot of press because for patients who have this enzyme deficiency, they can be exquisitely sensitive to these medications, leading to colitis and diarrhea. Many institutions are now adopting a policy to test for DPD, and this is a kind of a genetic test that can be done prior to starting therapy. So patients can certainly ask for that, but many of our institutions are starting to adopt that as a routine practice.
Yeah, thank you. And how many cycles is typical with Fulfox or Captem?
Thank you. Yeah, sorry, I forgot all the questions. So for Captem, typically we will give a maximum of 1 year. We typically do treatments in 3-month blocks. So I'll do 3 months and then a scan to assess if a patient is responding or not. And if patients are either not responding or having really severe side effects, we may consider making some changes. But if they have evidence of progression, we would then stop and move to something else. And the same is really true for Fulfox. Fulfox, we would continue as long as patients are tolerating it and as long as it's working. Fulfox is harder, I have found, than capecitabine temozolomide, specifically in terms of neuropathy. So that can be numbness and tingling in fingers and toes. And we're often limited to give that treatment for maybe 6 to 9 months, but it really varies depending on an individual patient.
Yeah, and I'm just curious, is there a certain point where you plateau the maximum benefit? So would you continue it all the way up to 1 year if someone's receiving maximum benefit, or if they have tumor shrinkage at 6 months, you would kind of stop early for Captem?
Yeah, so the clinical trial that sort of led to us using this as a standard treated most patients for a year. But I think that's an excellent question that we don't really have a lot of high-level evidence for. But I would say typically we would treat for at least 1 scan beyond kind of the maximum benefit. And that tends to be around that 9 to 12-month mark.
Thank you so much for that excellent overview of that. Dr. Sukrathan, should most patients, NET patients, have the 5-HIA test done?
I think it's a little bit institution specific of a question because some institutions have plasma 5-HIA, other institutions only have access to 24-hour urine 5-HIA. Again, I think it's not a broadly generalizable answer, but especially in the beginning when folks come with certain symptoms, which may or may not be entirely related to the carcinoid syndrome, I do like to check a level in the beginning because in some of the situations that I alluded to, if you're not sure where the diarrhea is coming from, or if the flushing sounds, somewhat familiar and it's very similar to, let's say, menopausal symptoms. There are instances when it is a good idea to check it. But I think a lot of the times, if you have a very obvious carcinoid syndrome qualifying diagnosis, you don't really need to check it, in my opinion, especially if it's a 24-hour urine 5-HIA. It can be quite difficult to monitor serially. We have quite a few patients who find it very difficult to collect urine over 24-hour time span, and they expressed to me how difficult that is. So I tend to be very sympathetic about some of the logistical challenges associated with that. So we do check it, especially if I'm concerned about whether someone has a carcinoid syndrome or not. And also if I'm concerned if they are starting to develop things like, let's say, a worsening of their symptoms, but if a scan looks very stable. So there are certain situations where it does make sense to monitor, but I don't routinely do it for everyone, let's say with every scan, because I don't think it adds that much information.
Thank you. And a follow-up question. In order to prepare for that 5-HIAA 24-hour urine test, which you mentioned was very difficult to collect, we must avoid avocado, walnuts, tomatoes, since they're high in serotonin. So should I always avoid these foods to prevent net tumor growth?
No, because there's never been any study to show that eating avocados makes your nets any worse, right? And I don't think there'll ever be a study like that. I don't think it's actually biologically plausible. I think a lot of the reasons why we do this is because we want to make sure that we don't want to get, false positives that are just above the level of normal. And that can be very different based on where you do the test. So I also tell people something similar about chromogranin, that it's not the level itself is not harming you in any way. It's a surrogate for what the tumor is doing, and unfortunately, it's a poor surrogate. And I would say that also for HIA as well. So no, I don't think you need to restrict. I mean, that would be a very draconian diet to follow, and probably not even realistic and against the principles of having a good quality of life. So I would not recommend anyone avoid these delicious food items.
Food matters for quality of life. Thank you for that. Dr. Malak, considering a whole body dotatate PET scan the morning of liver ablations with the hope that enough of the dotatate remains on board for ablative guidance, how long is the dotatate able to visualize the nets for ablation guidance?
Very interesting question. Because I'm wondering whether the imaging at the time of the ablation is using the dotatate itself, or what my guess, like sometimes we do that where we do procedures under PET CT, but that's a very complex setup and workflow. What I guess most places would do instead is basically image the PET CT in the morning, and then they would target the CT correlate of that lesion for ablation later on. That's my guess of how that would go. Now, how long the dotatate will stay is depend on what we're using. So a gallium-68 has a half-life of 68 minutes, and typically after 10 half-lives is when you basically don't have much left to be seen. So if it's only after like few hours, then there is still signal on board. If copper-64 is used, it has a much longer half-life that it will definitely still be on board later on. So it's just few hours between the PET scan and the ablation, then enough dotatate will be on board to be able to see them with PET. But my best guess is that the correlate of the lesion that we're seeing on the PET is what's being targeted on CT. That's my best guess of how the procedure would go.
Thank you so much. We'll end with this last question, and I'll have Dr. Kuntz and then Dr. Clark answer this. How common is it for the cancer to change grades, and what causes it to change?
So I think we've learned a lot about this question in the last 5 to 10 years. And I think that we do now recognize that neuroendocrine tumors can change grade over time. And I think that I will base decisions on what's happening with scans for individual patients, and will make a decision as to whether or not to rebiopsy based on whether a clinical behavior, meaning does the cancer grow more quickly than what I would have imagined based on the original biopsy? And if that answer is yes, then I would consider rebiopsying. So we can see a kind of increase sometimes with a Ki-67 that might inform and change what types of treatments I select. And I think that there is an increasing recognition that getting repeat biopsies at time of real rapid pace of growth or change that's different than what we would expect, that is being done more commonly now. But I'll pass to Dr. Clark.
Exactly correct. We have a paper that we're working on right now that's essentially showing that the correlation between the primary tumor grade and the metastasis is much higher if patients present with both sites of disease at the same time. We call that synchronous metastases. Versus patients that develop metastases later on, maybe even separate or years from surgery for their primary tumor. And we call that metachronous metastases. And so why does that happen? I think for a variety of reasons. I think that there is treatment selection. So as you have neuroendocrine cancer and you've been treated with multiple lines of therapy, different medications, we believe, are very effective at treating certain groups of cells. And so sometimes what you have are the cells that survive, and they may be different than the cells that respond to treatments. And sometimes those cells can be a little bit more aggressive. And so we can see a change in grade over time, maybe from treatment selection or pressure selection of the cells that are surviving, and then also just time. As the tumors change. A good reason that we love to see where a tumor grade can change is after a neoadjuvant treatment. So, for example, we will often treat high grade tumors, grade 2, grade 3 tumors with therapy, and we tend to use, especially for pancreatic neuroendocrine tumors, CAPE-10, and then we'll have patients that have had a really great response. They still have some disease somewhere else, and it's just so rewarding when I take them to surgery and everything that we remove is grade 1. It tells us the CAPE-10 really did a good job at taking care of the higher grade disease cells, and sort of what was left behind was lower grade disease. I think it's a really good indication for response to treatment as well, and sometimes can portend to a better progression-free survival for patients that have these more aggressive tumors. So I think time is one big factor for why grades change, and then treatment response is another really big factor for why grade may change over time.
Thank you, Dr. Clark and Dr. Kuntz. I want to thank Drs. Clark, Kuntz, Malak, and Sukathan for your time and thoughtful answers. And I'm going to invite the second group, Josh Mailman, Dr. Carreras, Chan, Chauhan, and Mitra, to turn on their cameras and join us for the question and answer session now.
The changing of the guards. Thank you very much, Lisa. Very informative first set of questions. We have a lot of questions here that are PRRT and both in general as well. So we'll get right at it. So the first one we're gonna ask, and Dr. Chauhan, you really covered this well, but maybe a little bit more. The incidence of developing MDS following PRRT, and does this increase over time? And then the follow-on question to that is, and we can open this up to the oncology folks as well, is understanding, how this risk compares to other therapy. Well, you are the oncology folk as well. How this risk compares to other treatments that we may be on as well. And you already kind of highlighted that it may be not only prior therapies, but the number of total therapies.
That's great. Thank you, Josh. Thanks everybody for the invitation. Great question. Some of this we have yet to fully uncover and understand. As of today, the best data we have is probably NETTER-1, where they had reported out 6 to 7 year follow-up data for long-term safety. And based on that study, we can say that the risk of leukemias, acute myelogenous leukemias, is less than 1%, and the MDS is in the range of 1 to 2%. This is also inconsistent with the larger European data, which usually suggests the range between 1 to 4% based on individual institutional studies. So it's very reassuring that the long-term bone marrow side effects are in that range. Having said that, we are entering a new era of neuroendocrine cancers where patients have now been treated on several lines of therapies. In fact, several types of PRRTs, even under research, alpha, beta, and repeat beta. So certainly these data may not fully reflect the realities of the new age, or the next 10 years. So I think we need to continue to learn and reassess. But as of now, the risk is relatively low. This risk may actually be accentuated if there are certain risk factors. For example, if there's a personal history of leukemia, lymphomas, history of prior use of chemotherapy, especially alkylators. These are a type of chemotherapies that especially damage DNA and the bone marrow. So there's the risk is a little bit heightened. In fact, there was a retrospective series presented at ENETS recently, which suggested the risk of MDS to be as high as 8%, especially if there is cumulative risk factors of prior chemotherapies like alkylators in the past. But this is not an established fact yet. I would not like to dissuade or scare patients away with this. I think the risk is still very low based on the best studies and best evidence we have. However, this is leading us to study this in more detail, and there are technologies in development. For example, CHIP technology. It stands for clonal hematopoiesis of indeterminate potential. So these are a set of mutations or genes that we look for and we understand may predict the risk of MDS, and that has to be validated in neuroendocrine tumors. It has been validated in some other cancers. So we are looking into it, and there are some tools that we can rely on. As of today, the risk is low. Some of the telltale signs would be advanced age, personal history of leukemias, or prior exposure to alkylator-based chemo for a prolonged period of time. But these are not validated, or I would not preclude anybody from getting PRRT just because they had CAPE-10 in the past. Those are my 2 cents. I'd like to hear my colleagues, Dr. Chan and others.
Dr. Chan, how do you really talk to patients about this?
Yeah, I think I agree with what Dr. Chauhan has mentioned. I think the risk of leukemia we have seen is quite low, less than 1% over time. The risk of myelodysplasia, which might be a precursor to leukemia, might be slightly higher than that. I think these are just risks we need to be aware of and to monitor for any changes in blood work that might indicate that there's been some insult to the bone marrow. There are some, as Dr. Chauhan mentioned, possible risk factors that may predispose people to the higher risk, like prior alkylating agent chemotherapy. But I'd say that as we make decisions, it's just important to recognize these risks. But ultimately, we're also trying to balance that risk with the real benefit that patients may derive from PRRT to control their cancer. Some of our chemotherapy agents can predispose people to leukemia or MDS. For instance, even the alkylating agents by themselves, even without PRRT, may cause bone marrow damage. And chemotherapy agents like etoposide also can raise the risk of leukemia and MDS. Everything to be aware of. These risks are small, and I think those risks are outweighed by the real benefit of the treatment.
Following up, you talked a little bit about doing CHIP testing. How often does this happen in the real world as far as this point, or other predictives to see if we can at least move patients who might be predisposed to MDS or AML away from PRRT? And Dr. Mitra, do you do this in your practice?
No,
Right.
no, we don't. Yeah, I would echo, what the others have said, is that we know that there are some risk factors and there's some things to keep in mind, but we don't have enough information at the current time to really make decisions around avoiding PRRT, which we know is a very good treatment, and so if the patient is eligible for that, I think primarily we will go for it, but we don't routinely do that type of testing now.
Moving forward, one I think challenges, of course, talking in clinical trials, and Dr. Chauhan, you had a great
list of different PRRT trials that you were showing up there, but also, Dr. Chan, there are, whether there's the CAR T cell therapies or other therapies that Dr. Kuntz was showing, how do you counsel patients into what's right for them? I'm very curious for those of you who have both the alpha repeat trials and the Lutathera repeat trial, as well as other things that may become secondary, treatment after PRRT. That how do you do that? I mean, what's the criteria that you use? I'll point that at Dr. Chan first, and then anyone else can chime in.
Yeah, I'll start off, Josh. I think this is a great question. I think the fact that there are so many trials is really exciting. I think all of these trials, we hope, will lead to more knowledge and potentially even more treatments. I think as we counsel patients, we always will review what the standard options are, because there are, as you know, an increasing number of standard options that are on the table. There also are trials that may be relevant for patients, so we'll consider their situation and whether they may be a candidate, for instance, for one of their PRRT retreatment trials. And I think not all centers have both trials open, so we may be able to offer what is available at our own institution and point out what also may be being investigated for the field. I always encourage clinical trial participation if that's something that patients are interested. I think this may be a way, again, that we can, as a field, learn more about some of these newer treatments that may be better than what we currently have. I think patients may be interested in participating in these studies because it also gives them access to some of the newer, really interesting agents that are being investigated. But I think for me personally, it's a matter of just laying out all the options that are on the table, the standard options and the trial options, and then we'll discuss the pros and cons and ultimately arrive at what people feel most comfortable doing.
Josh, if I may add to that, I completely agree with Dr. Chan. I think as an overarching, while having the discussion with the patient, I, in general, advocate for clinical trials. We have come from an era during my training where we didn't have access to PRRT, and patient routinely used to travel abroad to get this drug. So clinical trials, the best way, is the most scientific way to advance science, which will help not only our patients, but the next generation of patients and the field in general. However, not all trials are the same. And that's where the nuance comes in. If we are dealing with a phase 1 trial, which is a dose escalation, and we have a very good standard of care treatment available, we need to make that clear to the patient. And if there is a trial with a placebo arm, is the patient comfortable to take that risk of being randomized to the placebo arm? So those are the things that we have to disclose to the patient. At the end of the day, we are patient's physician first and the trialist later. Having said that, most of the trials that are designed with the spirit that we are advancing on the current standard of care, that we are going to improve either the drug or the target or the side effects, or there is some improvement of the current standard of care. So, it's good that there are access to the trials. 90% of patients, if not more, will not either qualify for the study or don't have access to the studies. These are just national statistics. There's very few patients who have access to the studies. So yeah, it's good that we have trials to offer. We kind of tell not all trials are same. Phase 2, phase 3 may have more clinical data backing them up. Phase 1 are a little bit earlier, and these are usually reserved for patients who may have exhausted all standard options.
So, Dr. Carrera, was fascinated with your talk and talking about something that we don't talk much about in the United States. And I know you trained a little bit in Europe with Dr. Baum, the terbium and Auger electrons. What have you seen about them? I know that there's a few clinical trials going on in Europe on terbium 161, and it may be one of those radionuclides that becomes more available as time goes on versus some of the other challenges we have with alpha production. And I would thank you for unmuting as well.
Thank you. Thank you for having me, and thank you for the question. I think that this Auger electron therapy will have more importance in the future because it's really interesting how it works. Actually, beta negative or beta minus emitters are less probably to hit the both of the chains of the DNA, and the lethality of this kind of treatments is not as high as with alpha emitters or with Auger emissions. The results of the studies with this kind of treatments are amazing, actually. But all these patients have been treated before with lutetium. So I think in the future will be important to learn what happens when we treat the patients with terbium-161 first, because normally when the patients are not responding to lutetium, then they are switching to the other kind of treatments. And that means that the patients are already high risk or not as radiosensitized as they should. So the most important point of this terbium therapy is that the linear energy transfer of this kind of therapies is really high. So in the first place, we have alpha therapy. No, it's the most or the higher linear energy transfer. And second one is the Auger electrons, but the advantage of these terbium or Auger electrons is that they hit in different directions, not just in one direction. So that is helping a lot in patients with bulky tumors.
And it also may be easier to produce and more availability. Certainly, Dr. Mitra, and I don't know if you will also be in New Orleans next weekend for the SNMMI conference as we discuss radiopharmaceuticals and their availability. I will say one of the questions that came up both when talking about trials is and we didn't really get that from the earlier presentations, is how long does it take for these drugs that are in trial to actually come to the market? So even in the alpha trials that we have that are in phase 3, what's your best guess of how long that might be? And things that are in phase 2 might give us some not crystal balling because each drug is different, but just some idea of just how long that does take before they get into general practice if everything is successful. Dr. Chen, I mean, I realized that you just went and got a new indication for a drug that had already been approved. And how many years did that take from the time your phase 3 trial opened?
Yeah, Josh, thanks for that question. I think this is a really important point. So the cabinet trial studied the efficacy of cabozantinib in patients with advanced neuroendocrine tumors. And as you mentioned, just led to the approval of cabozantinib in March of this year. The trial itself opened in 2018. So it took a good 7 years to complete the study and to ultimately have the FDA approval, which I anticipate and hope will expand access to treatment. I think for trials moving forward, that is a long period of time. I think that's where having more sites participate, having the trials open in a kind of more global way may also help to speed the recruitment and complete the trials in a much faster way. But it can take several years to actually enroll the trials and then have the trials read out for the outcomes that we're looking for.
So I'm going to do another oncology question real quick. Stress, does this actually impact our disease progression or our disease at all? Other than it's not a great quality of life measure to have stress, but how does it impact our actual disease? And Dr. Chan, I'll go back to you on this.
Yeah, that's a really important point, Jess. I don't know that there have been many studies that have really looked at whether stress will, for instance, make the cancer grow or spread faster. I think you point out one thing that is really important is that we know that it can impact mental health and quality of life. And for some patients who may have carcinoid syndrome, that stress can also provoke more symptoms of flushing and diarrhea that also are probably tumor related. So there probably is some impact of stress and the physiologic changes with stress on the cancer itself. But I would say that we don't know yet that that actually makes the cancer worse and grows faster and spread. But it is really important to try to manage the stresses as best we can with medications, with counseling, with other interventions, because I think that ultimately will impact and improve quality of life.
Since Dr. Chan, you're shaking your head in agreement, you don't need to answer that one at all. Back to our radioligand questions or PRRT questions, Dr. Karas, Dr. Mitra, we talked about already MDS and AML, but the use of PRT when people have bone mets seems counterintuitive, but why does it work, or does it work? And are we more concerned with metastatic disease to the bone, developing MDS or AML?
I can take a stab at that. So the nice thing about the systemic therapies, including PRRT, is that they will circulate everywhere and target all the lesions that we see. When we're talking about PRRT in particular, it will go to all the areas that we see uptake on the PET scan, which often includes bone metastasis as well. And so it will target those areas. Generally speaking, both what we've seen in the literature as well as my own experience is that if there are more bone lesions, it doesn't actually lead to more side effects in terms of toxicity to the bone marrow. And it's thought to be that the toxicity is actually more related to the general circulation of the radiopharmaceutical, which will happen for all patients, not necessarily the subsequent targeting to those bone lesions. So we actually don't worry about that side effect more in those patients. On the other hand, as I mentioned, it is targeting those areas, so it's nice to be able to treat all the areas of disease that we see on the PET scan rather than only certain areas.
Dr. Kerr, any thoughts on your end from what you've seen?
Yes, I totally agree with Dr. Mitra. And I also want to add that in my clinical practice, we perform every patient as clinically every time dosimetry. So we perform a SPECT-CT after each cycle of PRRT, and afterwards we make all these calculations for dosimetry, and we have found very useful to do these kind of studies, at least after the first cycle, to predict more or less what is going to happen with the bone marrow, and not only with bone marrow, but also with kidneys, for example, if we are blocking properly the receptors in the kidneys with the amino acid solution. And it works until now very, very well. And yeah, not only for neuroendocrine tumors, but also for prostate cancer patients, it's working very, very accurate.
I will say you guessed the next question, because the next question was about SPECT-CTs after the treatment. And I know this isn't always commonplace in the US, but you laid out a great, two great reasons right there for why having post-therapy day of or second or day after SPECT-CT is important. Does it also predict whether the treatment will work well, or is it just more of we get the dosimetry data to look at, as you said, distribution in marrow, kidney, also calculate what areas got what doses?
Yes, actually, I think is the most important part of the dosimetry is this one, the if the patient is going to respond to the treatment or not. We have some cutoffs for predicting if the patient will have a good response to this kind of treatments or not. But the cutoff is not already or properly set. We need to make a lot of trials, and yeah, a lot of expertise is needed here to decide what is the cutoff. And for example, to decide if I get, I don't know, maybe 5 grays or 6 grays each cycle, should I continue with the treatment or not? It's not already set up.
Can I also add to that?
Of course.
Just to kind of make sure that everyone understands that, these things that Dr. Carreras is talking about, while very kind of state of the art and cutting edge, there's also a lot that is unknown about them. And so a lot of it actually falls kind of more onto the research side a little bit. We're right on the cusp of kind of bringing this into the clinic, I would say. So at our institution, for instance, we don't routinely do post-therapy SPECT imaging, and we do dosimetry, but only on specific patients. For instance, we were talking previously about this kind of additive cumulative toxicity potentially from lutetium therapies as well as subsequent alpha therapies or what other things. And dosimetry may well give us a lot of information about those types of things and to be able to avoid toxicities. But I also want people to understand, if you're not necessarily getting a SPECT CT, not necessarily getting dosimetry at your institution, that's also completely fine. There's a lot of heterogeneity throughout the U.S. and throughout the world on these topics. And again, at our institution, we on purpose choose not to do those things because we feel like it's not necessarily, clearly indicating which way to go with the therapy.
So one of the other things that came up, and it certainly was in the question and answer in the earlier session, is the talk about when to get the final or the final post-therapy scan, whether it's a CT, conventional imaging, or DOTA, but how many months do you wait after? And there's this worry about pseudoprogression and how to work with and know whether what might look like some progression be pseudoprogression versus actual growth. And I certainly read one study where the number of those who reported pseudoprogression versus the number that actually had progression were pretty similar. And I think both are important. The question actually in front says, should we wait 8 months and from the time of the last treatment? And that would seem to me to be a long time between the last time I took a look at an image to, things can happen in almost 2 years if you go to 8 months. So how do you look at this, or is this a case by case, how people are dealing with their symptoms, other blood markers and things like that? And Dr. Mitra, Dr. Kerr, I'll ask all 4 of you because it may be independent of practice as well. So Dr. Mitra, I'll let you start there.
Yeah, I think, I'm sure we could all chime in on this question and I'll provide a slightly different version of the answer, because this again falls into this kind of category where there are no clear guidelines. There's some suggestions. And so absolutely, it's kind of patient specific to some degree. It's also institution dependent. So there's going to be a lot of variability there. But I completely agree with your comments that, you do have to be concerned about pseudoprogression. And that's one of the reasons, for instance, at our institution, why we choose not to do too much imaging. For instance, some places will do a repeat PET scan or conventional imaging after 2 cycles of PRRT, but we choose not to because we're concerned for that. We actually do post-therapy imaging after 3 months after the last cycle of PRRT. But even with that scan, we kind of keep in the back of our minds that there might be some possibility of pseudoprogression, particularly on the PET scan. There's no response criteria established yet for dotatate imaging, so we don't really know what changes in SUV uptake, for instance, mean. What we can rely on typically is growth of tumors on conventional imaging that would indicate true progression. And then the 8 or 9 months post PRRT scan is definitely recommended, sort of a new baseline. But as you said, a lot can happen in between that time, so we sort of advocate for some additional imaging in between. But yeah, if others want to chime in, I'm sure you'll get several different answers.
Yeah, Josh, this is one of those areas where I think there's a lot of heterogeneity in our practice patterns. For my practice, if it is a higher grade tumor, so now we know based on letter 2, we can treat grade 3 and higher grade 2. Those are more aggressive biology, and I don't feel comfortable waiting 6 months or 8 months knowing what's happening, because those tumors can grow very fast. So I oftentimes will do a first anatomic scan, that is a CT or an MRI, after 2 doses. But this is a very unique subset. This is a higher grade, more aggressive disease. We may even consider, even before that, based on clinical symptomatology, there are some patients who would not just respond to PRRT, and that's a very smaller piece of pie. But if patients continue to lose weight, they are getting symptomatic, you're not going to just give them another PRRT, wait 4 months and get a scan. You have to act on the clinical judgment. But for majority of patients, and we are talking 80% plus patients which are grade 1 and low grade 2, slow growing indolent disease, I think it's an overkill to do a scan too early. Now, I've personally participated in 3 prospective ETCT and Lutathera studies, ETCT 10388, 10450, and now we're just about to complete 10558, and cumulative treated close to 160 patients. And in the trial, we are mandated to do scans every 4 months. So we were kind of privy to all this frequent scans. And the first scan is almost useless because there's really no clinical determination. It's almost always either stable, plus minus a little change. So the plus is pseudoprogression from the inflammation, from the radiation. So it really is not very helpful in guiding care. We had to do it. It's a part of research. So for routine standard of care patients, I oftentimes wait after the 3 cycles, a month after. So that gives us enough treatment and enough time for the treatment to work and get some sort of early information. And the real value is after all 4 doses, then I usually wait 2+ months to get a post-treatment PET scan. So I can show the patient before and after the PET scan and the whole 8-month journey that they had, 8+ months. And that's something that I personally use. There's no clear guidelines then what needs to be done. I think this is something that we should standardize in near future.
And so I can weigh in
yeah.
also. I was going to weigh in also. I think my approach is similar to what Dr. Chauhan had mentioned. I think for patients who are starting treatment and there is, I would say, fairly significant progression going into treatment, I do tend to look after 2 cycles, right before that 3rd cycle. Because I think if you do end up waiting until after all of the treatment is done, well over 6 months has passed. And I think it's probably helpful to look before that degree of time has passed. But I completely agree with the points that both Dr. Mitra and Chauhan mentioned, that it's usually the most important is what you see a couple months after the treatment is done.
Dr. Kerr, do you want to weigh in on that?
No, totally agree with them. Actually, I think it's really important what Dr. Chauhan had said, that after the first cycle or the first 2 cycles, it could be a little bit tricky to decide if the progression seen in the PET-CT is real or is like a flare, so due to inflammation or other kind of things. So yeah, we have to take this with a lot of care.
Right. And also what's going on with the patient at the time. I mean, after the first cycle, if they're really sick and other markers seem to go, you would probably look to do something else or look to do some imaging to see if you could see something else. I'm just there's a question, are there any clinical trials available for Canadian Fernet patients? And I know Dr. Chan, you're on the repeat trial with Dr. Simran Singh. Dr. Kuntz is on the NETTER-3 trial with Dr. Singh as well. I just want to tell all the patients that the NCF has a clinical trial finder where they can put their location in anywhere in the world, not just Canada or the US, but it will return based on who they are and what they are, that whether there's a trial and how close a trial is, and all sorts of things. But you've had the pleasure of working with the Canadian trial group. Do you want to, Dr. Chan, do you want to mention that through your NCI experience?
Yes, I've been working very closely with CCTG, the Canadian Cancer Treatment Group. That's the cooperative group that undertakes federally funded studies in Canada. And we have access to net retreat studies. So this is a patient population who progressed on standard of care Lutathera and have benefited from it. And currently, the approved treatment is only 4 doses. So many patients now are finding challenges in getting additional Lutathera approved either through their insurances. So the trials is a great way to kind of get access to these PRRT products. The other study is Action One study, which is also available in Canada. Having said that, my personal observation is as compared to options available in the US, the treatment or trial options in Canada are limited. So I would highly advise or advocate the Canadian patient groups to advocate and collaborate with like-minded people like Dr. Simran Singh. He's a great champion for NETs patients, and they have a great community, the CNETs community there. Empower them so that your legislation, the government, allow more drug development or more trials. This is a very common problem, and I learned more so when I moved to Miami, because many of my patients, they come from Canada during winters, and it is challenging to find many trial options in Canada, but there are some, and I'd advise you to please link with these high volume centers in Toronto and other areas to learn more about that.
And the challenges you have in Mexico with the number of trials that you have?
Yeah, that's really complicated for us in Mexico, because at least at this moment we have no trials involving PRRT. So the patients who are treated with this kind of medicine like Lutathera or another kind of analogs, somatostatin analogs labeled with lutetium, they are paying out of their pockets, or sometimes their insurance company are paying for them. We also have national institutes of health, like National Institute of Oncology or Nutrition, and they have some internal trials, but not involving PRRT, just another kind of treatments for neuroendocrine tumors, surgery, radioembolization, and embolizations like Professor Gabuti had already talked about in the morning, and also chemotherapy, lanreotide, and all these kind of treatments.
I'm going to change it up for our last question. You'll have 30 seconds each to answer this, but what gives you hope in the neuroendocrine tumor world? What is giving you hope? What keeps you driving forward? I'll start with Dr. Chan.
That's a great question. I will say, having been in this neuroendocrine field for close to 20 years, I think there has been tremendous progress that has been made. That gives me hope, and I see a lot of progress being made in the future as well, as we think about the number of clinical trials that are being done, the number of new agents that are being investigated. And I think as a community, we've grown a lot. I think patients have become more connected, and I think they have brought us also together as a community. So the fact that we're all united with a common goal of which is advancing treatment, advancing science, and just really trying to improve lives, that I think it motivates and gives me a lot of hope.
Dr. Mitra.
Well, Dr. Chan said it very, very well. I think all of those things are exactly what also give me hope. But I would especially highlight the community. I think this community, both on the professional side as well as the patient side, is really a wonderful group of people all around. And I think the investment that everyone is making into the neuroendocrine space is what really gives me hope.
Dr. Carrera?
I started learning about neuroendocrine tumors in 2010 with Professor Baum in Germany. And he was really angry because it took like 20 years to come from research to the real life, for example, the Lutathera. And now everything is going faster thanks to the clinical trials and all the effort made by the physicians and, of course, the patient community that is pushing really hard.
Dr. Chan, I'll give you the last word before I turn it over to our studio.
Thank you, Josh. So 2 precise things definitely get me motivated. One is the patient advocacy groups, Neuroendocrine Cancer Foundation, yours, Norcal CarciNet, NetRF, NCAN. There's so many, and that's really has galvanized the whole field and catapulted the field and pushing industry, academia towards doing more research. And the second thing is the number of new drugs in the development. This wasn't the case 10 years back. These days, we don't have time to see and discuss and meet all the people we can. This is a great problem to have. So I'm very, very excited about what's coming up and for the field, and keeps me up and running. Thank you.
And watching all you guys do the work you do gives me great hope as well. And with that, I'll turn that over to Mary and Dr. Hendafar back in the studio.
Thank you to all the speakers who joined us for the question and answer session, and to Josh Mailman for his skillful moderation. We're deeply grateful to each of the 22 speakers from across North America for sharing your time, expertise, and insights. Your contributions brought the theme, What Matters Most to Make Your Next Best Decision, to life in meaningful and practical ways. Dr. Hendafar, as we close, as you know, there has been many advances in the past decade, including this year. Could you speak to this and also how you see this field evolving?
Yeah, thank you. The field has changed dramatically over the last 10, 20 years. When I first started treating patients with neuroendocrine tumors, the best options were either surgery or somatostatin analog. And since then, we've had the approval of several targeted therapies. Several in this year, we've had the use of peptide receptor radiotherapy become mainstream. Ideas about liver-directed therapy blossom and be used more frequently. And then most recently, another targeted therapy for rare neuroendocrine diseases such as paragangliomas and pheochromocytomas. And I think now more than ever, getting a great team together and getting as much information is super helpful. And just don't always forget, just because we have fancy new medicines and treatments doesn't mean that surgery still doesn't have an important role. So again, broaden your treatment team as appropriate.
Yeah, thinking big and engaging the whole team. Mary, after living with neuroendocrine tumor for over 20 years, what do you now understand better?
There's such a wide range of treatment options, as we just mentioned, and it is complex and challenging to make these decisions of what to do next. So what I've come to understand is to take the time and to do your research. And my suggestion is, when you're living with stable disease and you have kind of more of a mental bandwidth, that's a really good time to do some of this homework. Listen to expert presentations, talk to your specialists, and talk to your net resources. Having these conversations about gathering information when you're not in crisis or under pressure or not feeling well can really make the decision-making process much less stressful in the future.
Yeah, managing your time and your resources. Dr. Hendafar, what would you like the audience to take away from today's conference regarding what matters most to make your next best decision?
Yeah, I think it's really important that the patients that are listening today really, think of the Neuroendocrine Cancer Foundation as a place where they can get a lot of the information they need to make their next best decision. And they do their best to engage the healthcare providers. But I think, this is a really great place and organization to get that information that you need to help educate yourself and your treatment team.
Yeah, it's a community and a team approach. Mary, what would you like the audience to take away from today's conference regarding what matters most to make your next best decision?
So I guess what I'd say is if you're like me, your next best decision is one that is considering both your quality of life and your quantity of life. And I'd say access to net experts who are invested in this as much as you are is key. And I'm so grateful that I have Dr. Hendifar on that team with me. For me, I want to feel like I'm in control of the disease as well. So I would say over the past 20 years, I've witnessed so many individuals profoundly shape the course of their cancer journey by having faith in their own instincts and combined with the shared wisdom of their net specialists. So I would say what matters most is you. No matter where you are in your journey, carry the strength and the resolve to make your best next decision and trust in your instincts, and you don't need to do it alone.
You're not alone.
It's really good.
Wise words. Thank you, Drs. Hendifar, and thank you, Mary, for a rich discussion. Your perspectives added real depth to today's conference. And now I'm going to hand it over to Heather.
Again, a heartfelt thank you to our 19 net experts for contributing their invaluable time, expertise, and compassion. Be sure to take a look at the valuable information from our sponsor pages. Visit all 5 sponsor booths and receive a $5 Starbucks e-gift card. Go to our conference page at ncf.net/2025 conference. Again, today's annual patient educational conference has been recorded and can be viewed on our website and YouTube channel a few days after this broadcast. You may receive a survey via email after this broadcast. We would greatly appreciate you taking a few minutes to complete that survey. It helps us affirm what's important to you and opportunities in our educational content, format, and in fundraising efforts. We'd like to sincerely thank our technical director, Rich at TVP Live, for this exceptional production. And now I'll hand it over to Lisa.
Today has been about sharing knowledge, insight, and connection. Our hope is that you leave feeling more informed, empowered, and confident in making your next best decisions. Most of all, know that you are not alone. Our community stands with you, fighting for you and alongside you. We hope you can join us for our future educational events. Join us on July 10th for our Living with NET, the Patient Perspective webinar, where we will hear from 4 people living with neuroendocrine cancer. Join us for our August 26th webinar, Nutrition and Diet Considerations for NETs, with NET dietitian Megan Laszlo from Cedars-Sinai Medical Center in Los Angeles. Join us for our September 22nd webinar, Understanding Alpha and the Evolving PRRT Landscape, with medical oncologist Udaville Grewal. And save the date for November 9th, our NET Cancer Day Symposium in person in Miami. I also wanted to highlight a couple key resources we offer on our website. Our Clinical Trials Guide is an educational resource featuring several key clinical trials for neuroendocrine cancers. You can browse the site by the type of neuroendocrine cancer or types of treatments. And there you'll find patient-friendly videos and information about individual trials. We hope this guide will help you better understand clinical trials that might be available for you. Net Vitals is a valuable tool to help you prepare for medical appointments, assess your understanding about your disease, and communicate with experts or with each other. Check out our podcast featuring an interview with an expert on various topics, including types of treatments and types of neuroendocrine cancer. We also offer Spanish videos and programs. Go to our website for these and other programs and resources, ncf.net. Now I'm going to hand it over to Kavya.
Once again, a special thank you to our sponsors, Novartis, Crinetics, Lantheus, Exelixis, and Curium. Our programs, such as this conference, wouldn't be possible without the support of donors like you. Become a part of our vision to empower neuroendocrine cancer patients and caregivers by donating at ncf.net. A heartfelt thank you to all of you for joining us virtually to learn more about what matters most in understanding and treating neuroendocrine cancer. And we hope to see you soon at a future event.